Hello and good morning. All around the world, there might be some people from different countries, different continents. Welcome to this exciting second day of this conference. Sorry for some delay because of the technical glitches. And I can tell you that doing a hybrid is 5 times more difficult than doing anything individually. It's very difficult to integrate the platforms, but still we are working hard and we are trying our best. Our team backend is working on this. So without further delay, we will start the first session, and I will call upon the moderators for this session who will take the proceedings forward. So our moderators for this morning session, Dr. Selvin George. Dr. Selvin George is a senior physician, internist, a wonderful doctor, and a great friend in Medcare Hospital, Dubai. He's my wonderful colleague. So please, Dr. Selvin. I also invite Dr. Chavi Mehra from India, Bangalore. She'll be joining online as a moderator. And hi, Chavi.
Hi, Brajesh.
Good morning. All okay? Are you able to see well? And
Yes,
wonderful.
absolutely.
Thank you. Thank you for joining. And Dr. Rajiv Lochan, I do not know whether he's online or is he on the way because he lives in Dubai. So maybe he is still driving and coming over. So we are waiting for him. Dr. Samir Kaka excused for some emergency. He had to rush to his country, Syria. So he had apologized yesterday morning. So Dr. Salvin and Dr. Chavi, you will start the proceedings with the lecture 1. Thank you.
Good morning, everyone. Hello. Good morning, everyone. Thank you all for being here on day 2 of our meeting on SHAKE, which is saving heart attacks. So today we are going to have a wonderful session, and this is going to be very exciting for not only just cardiologists, but as well as internal medicine specialists, family medicine doctors. So let's look forward to a wonderful session for day 2. And for the first speaker of the day, I want to introduce Dr. Abdul Jabbar, who is a consultant endocrinologist, a very dear colleague of mine too, working in the same hospital. He does not need much introduction because everybody who knows about diabetes knows about Dr. Abdul Jabbar and the wonderful work he's done for diabetes in Ramadan. And with Ramadan just round the corner, you're going to see more of Dr. Abdul Jabbar on stage presenting his views on how to manage diabetes in Ramadan. But today he's going to talk about early detection and optimal management of type 2 diabetes and how that's going to impact cardiovascular health and how we need to go forward in early detection and strict management of diabetes, because as we all know that many patients and even among doctors, there is this great inertia when it comes to management of diabetes. So over to Dr. Abdul Jabbar, and let's listen to his wonderful words. Thank you.
Thank you, Dr. Salman, for the kind introduction, and thank you for the organizers, especially Dr. Mittal, to invite me for this session. It seems really interesting to see that the cardiologists are inviting me to stop sending patients to them. And I think this is really speaks for the willingness, motivation, which should be expected for all the cardiologists. These are my disclosures. Moving forward, we all know that the number of diabetes patients as by the IDF region is increasing. The projections they made for the Middle East and North Africa are 96% increase, leading to 108 million in 2045, and they've corrected it. They say, no, it's not going to be 108 million, it's going to be 136 million. So, best of the interest, best of the healthcare system, we will not be able to handle it. So, a difficult topic, but I will just touch upon that because some of my colleagues will be talking about how to best manage type 2 diabetes. I am talking about how can we do that as early as possible. So we all know that the consequences of hyperglycemia affect almost every system of our body, whether it's heart, whether it's kidneys, whether it's circulation. At the same time, eyes, problem with pregnancy, nervous system, brain. Almost every body system is affected. So taking care of hyperglycemia means a profound impact. And that's why the new subspecialty is coming in the world, cardiometabolic. They are so closely linked in terms of the circulation as well. Now we know there are multiple factors as opposed to what we used to believe. The doctors, the scientists, and the patients and their families. They're all related everything to pancreas, what I eat. If I eat this, my glucose will go up. If I don't eat this, my glucose will not go up. But it's not so simple. And in the last 2 decades, we have learned wonderfully, and that has changed the spectrum of type 2 diabetes management, that there are so many things which are important. The tissues in the adipose tissue, the skeletal muscle, the kidneys function, the glycosuria, and the gut, the largest endocrine gland in the body with the incretin effects, and the hepatic glucose production. So if we want to focus on that, we have to focus on everything. But the important question is, when I was assigned the talk to talk about early diagnosis, what is early diagnosis? And how can we make early diagnosis? That's the most important part. Last month, I was in another conference from the primary care physicians for diabetes, and when I asked this question about why don't we do action early? Why do keep waiting for years and years to take action? And the response came back from some of the doctors sitting in the room was, how can we do that? My patient cannot afford an A1C. My patient cannot afford a visit to the doctor. My patient will not afford a lipid profile. What are you saying, Dr. Jabbar? And that's the answer. I said, what about prediabetes? And again, the same answer came back from the clouds, that how can we diagnose prediabetes? And the second question, when I started focusing on convincing them that we can do that and we should do that. If somebody becomes diabetic with a blood sugar of 350, then he comes to you, will you ask him, do you have money for A1C? Do you have money for lipid profile? Whether the insurance covers or not, you will say you need it. You are ready to do it at that point when this patient is already halfway through the cardiology clinic. Why not to do it before? So that's where the concept of prediabetes came in. And then the second question from me was, should we treat prediabetes? And my answer was, why are you making the diagnosis? If it is not worth doing something, why to make a diagnosis? The diagnosis came because it's real. It's common, it's very common. And most importantly, at that point, it is reversible. If you do something now, it is reversible. After diabetes, you're not taking care of early diagnosis and early treatment for that patient. It's already late. So you can prevent or delay prediabetes from turning into type 2 diabetes with simple, proven lifestyle change. You don't need a number of list of medications. And that doesn't cost you anything. It doesn't require any test. It doesn't require any medication. Amazing but true that 96 million American adults, 1 in 3 have prediabetes. But more important, more than 8 in 10 people with diabetes don't know they have it. And the second question is, I told you, how come we can diagnose? And I told them, even a layman, looking at the other person, without doing any tests, can see he is overweight or not, can see he has got central obesity or not, can ask, do you have family history of diabetes? These simple things don't cost you anything. So what is the concept of pre-diabetes? The very concept of pre-diabetes is prevent diabetes. That's why we make the diagnosis. We can educate our patients that pre-diabetes is a fork in the road. If you ignore it, your risk for type 2 diabetes will come. So start acting now. Lose a modest amount of weight, get regular physical activity. The evidence is there that modest weight loss of 5 to 7% of the body weight. For somebody who is 100 kilo, it means 5 kilo. Most of people, when are at the pre-diabetes stage, they are not even 100 kilo from our society and culture where we live. They are 70 or 80 kilo. So what is 5%? 4 kilo. And you don't have to lose it in 1 month. You can lose it in 6 months. But you have to give them the numbers. And the modern generation, the young people who are suffering from it, they understand the numbers. You give them the numbers, they will follow it. Regular physical activity, 150 minutes a week, just 30 minutes a day, works a lot. So as you can see, there are guidelines for that as well. So if possible, as I said, rather than checking for their profile at the end of the day when they have become diabetes and they are symptomatic, even the ADA guidelines suggest that you should test patients who have got an overweight or obesity. So we can see that from the look of the patient, how many have got overweight or obesity. Plus, one more thing, first degree relative with diabetes, high risk ethnicity, we are all in high risk. Any history of cardiovascular disease, if the person has hypertension, hyperlipidemia, women with polycystic ovary syndrome, we identify when they are going through their teenage, they are physically inactive, and any other condition with insulin resistance. For all other patients, even if those factors are not there, because of the high prevalence, 1 in 3, 1 in 4, and 1 in 5 normal people suffering from prediabetes or metabolic syndrome, we should test them. Being part of the Emirates Diabetes Society Guideline Committee, where we have changed it. The rest of the world is saying 45. Based on the very high prevalence at an early age and the obesity climbing up in this region, we are suggesting that it should be started at the lower age of 30 years, assessing 30 years. Adults of any age who are overweight or obese with more than one additional risk factor, whether they are 30 or 20, doesn't matter. Adult means they are above 18. Start checking them rather than waiting for it. And for persons with normal test results, repeat testing at least once every 3 years, unless condition changed, or 6 monthly if the person is diagnosed with prediabetes. So the risk-based certification I have already told you, but this is the one not for adults. This is talking about asymptomatic children and adolescents. And I bring this topic again and again now to all the forums. If you want to prevent diabetes or make an early diagnosis and start management early, that is the group. The person sitting in your clinic, mother or father, is already diabetic, is already hypertensive, has already lipidemia. That's why they are sitting in your clinic. Who is not in your clinic but is at high risk is sitting at home. So if you talk to these parents, you are suffering from what you had. You didn't have a choice. But did you check your kids? Did you start managing their lifestyle? Do you know what is their weight? Do you know what is their central obesity? And as I said, it doesn't require any tests. You just put 3 minutes, 5 questions, and you are on the track. So there are so many points. So in the children and adolescents, we don't put BMI because we don't have the data for that. We put the standard deviation. Above 85th centile is overweight, above 95th centile is obesity. A simple, are you at risk for diabetes calculator is available, very simple, anybody, and if it is in your clinic or if you hand it over, or you send the link to your patients, they can check with their kids, their adolescents, the other family members if they are at risk. So at least annual monitoring for the development of type 2 diabetes in those with pre-diabetes is suggested. Patients who are suffering or diagnosed to be pre-diabetes, you should start an intensive lifestyle behavior change in the form of diabetes prevention program to achieve and maintain 7% loss of initial body weight and increase the physical activity. A variety of eating patterns can be available to prevent diabetes in these individuals, and now we have got the treatment options available, like metformin is already available. This is the earliest treatment even before diabetes came. And once the diabetes becomes available in the diagnosis in the labs, you can put other molecules, which will come from my colleagues soon. So we know the typical history of the progression of type 2 diabetes, and you can see it there, that it comes at a much later stage, about 5 to 10 years of pre-diabetes, then the clinical diagnosis is made. So already 5 to 10 years are lost. The damage has been done. And even pre-diabetes are shown to have microvascular and macrovascular complication. In about 50% of the people diagnosed with type 2 diabetes, they already have these problems there. So we already wasted 5 to 10 years for these people. So early optimal management and a rational approach, everything should be made as simple as possible, but not simpler, as low as possible for glucose, cholesterol, as early as possible, as long as possible to maintain, as safely as possible, and as rationally as possible. So as I just pointed out, now we have got loads and loads of options available for managing these patients. And you can see, initially we had human insulin, sulfonylurea, metformin, but thereafter we have seen so many things coming. So if you wait for the type 2 diabetes to come and start managing then, we'll be a bit late and making the complicated, complex management pathways for these patients. So one important aspect I highlighted earlier, the precursor of diabetes and even the precursor of prediabetes are two things. Number one is genes, which you cannot change. I always say in my lectures, you cannot choose your parents. I was talking to the young doctors. I praised the word, you can choose your partner, but not your parents. And some of the answers came, I cannot choose even my partner. So it's not easy, but at least we are all sure you cannot choose your parents. Again, for all of us, you cannot choose your kids. They come with the genes. But what is epigenetic? The most important epigenetic precursor which we can identify is overweight and obesity. So don't wait for diabetes or even pre-diabetes to come. Start managing. Everybody knows I'm overweight, and I've got flooded clinics now, people coming to me at the young age. So those who come are already knowing. They know I've got a problem. The problem is the ones who are not coming. Their parents are coming, their grandparents are coming. They are not coming to the clinic to ask, what should I do? I'm overweight. So use a patient-centered approach to foster the collaboration. Say people with diabetes, don't say you're obese. Never use the word. Say, what do you think? Do you want to do some more physical activity, being a healthy lifestyle, being more fit, rather than saying lose weight? They don't like it. Some of them come, okay. They don't come and you start initiation. They came to you for some other thing, totally different. Measure height and weight and calculate BMI. Based on the clinical considerations, you can do a number of things to be done. And then, again, we have got the approach which my colleagues In the follow-up sessions, we'll talk about the various modalities available for the artery treatment, and so many systems are responsible for the pathophysiology, and fortunately we have got all these covered in most of the recent armamentarium. We have got the loads of medications available to manage them, taking care of obesity, taking care of prediabetes, taking care of heart problems, taking care of kidney, everything is available. You have to be the right choice. So there are so many guidelines available which are focusing on the new molecules which have got a better, easy availability. They focus on the obesity and overweight. They focus on prevention of hypoglycemia. At the same time, they are contributing to the management of hyperglycemia, and they are protective for the heart and kidney so that our patients don't end up in the interventional cardiology. As I said earlier, my friends may not like it, but I'm sure they are all true professionals. They love my words for it. Thank you very much. These are my references. We'll be happy to answer any questions if needed.
Hello. Hello. Thank you, Dr. Jabbar. It was wonderful presentation and a beginning of the day. And I know it's not the easy task to come over so early in the morning and deliver the talk. Now, the next speaker is in line for diabetes, Dr. Chavi Mehra. Dr. Chavi practiced in US for a number of years, then returned back to India, and now she's practicing for more than a decade in Bangalore. Dr. Chavi is very much into the field of diabetes, protection, treatment, reversal. She's Chief Medical Officer, SugarFit, which is a new entity which Dr. Chavi has founded, I suppose, recently. She can tell more about it. So she's senior physician, internal medicine, internist, a good doctor, an humble doctor, and a very worthy doctor. I know her. So please welcome Dr. Chavi. She is online. Her lecture is already recorded, which will be played, and then stay on for the discussion in the end. Thank you so much.
Hi, I'm Dr. Chavi Mehra, and today I'll talk about type 2 diabetes mellitus reversal, a reality. Diabetes reversal is normalized sugar levels, which is fasting less than 110 and A1C of less than 6.5, over 6.5 maintained over 2 readings 3 months apart, and of all anti-glycemic medications. This does not include metformin as a medication because it is a metabolic medication and is not considered under the anti-glycemic medication profile. Diabetes, as we know, is the tip of an iceberg and the visible response of our body, but we know that a lot of our population has insulin resistance, beta cell dysfunction, or metabolic dysfunction, which will lead into diabetes sooner or later. Is there scientific evidence for diabetes reversal? From the narrative review of evidence over the last 5 to 10 years, bariatric surgery, low-calorie diets, carbohydrate-restricted diets have shown promise towards reversal. Bariatric surgery has good initial results, but it is difficult affordability. Risk of surgical complications are there. Patients are limited to mostly with BMI more than 40. Long-term remission studies are yet to be, we need more data on that. And they do require strong dietary restrictions. Low-calorie diets primarily linked with weight loss and treating insulin sensitivity, and the long-term sustenance of these is a challenge. There's a yo-yo effect in weight management, there is a difficult motivation sustenance, and energy levels are found to be low. Carbohydrate-restricted diets have very promising results where macros are managed well, like carbohydrate, fat, proteins, or fiber. Short-term ketos have shown good results but are not sustainable. Complex carb portion controlled balanced diet have seen longer adherence and sustenance among users. How does your sugar metabolism work? We eat carbs in diet that has changed to glucose and absorbed into our blood as glucose. Sugar levels rise in our blood. signals are sent to pancreas. Insulin is secreted. This insulin helps in transporting the sugar to skeletal muscle and liver. The receptors on the cells of these organs also respond to insulin and open up, and as a result, the sugar from the blood goes inside the cells for storage and future use as an energy vehicle. What is the root cause of type 2 and prediabetes? It's insulin resistance. You eat food, insulin is secreted, but the cells resist insulin. Sugar, then, which is excess in your blood, is stored as fat. And as a result of it, we gain weight, we are tired, we are fatigued, we are hungry, and we eat more. So I felt that the most important part of all of us to understand where reversal is concerned is to understand metabolism and how adipocytes and fatty tissue works in the body. Recent evidence has shown that 85% of type 2 diabetic adults are obese. Originally classified as a simple energy storage organ, adipose tissue is now known to function as a major endocrine system that secretes adipokines, growth factors, cytokines, chemokines. When the capacity for adipocyte recruitment is overwhelmed, fat accumulates in ectopic sites, visceral depots like liver, skeletal muscle, and also pancreatic beta cells. Visceral adiposity is associated with insulin resistance, adipose tissue and systemic inflammation, dyslipidemia, dysglycemia, hypertension, thrombogenic profile, and also non-alcoholic fatty liver disease. In obesity, adipose tissue becomes dysfunctional, promoting a pro-inflammatory, hyperlipidemic, insulin-resistance environment. The mechanism by which dysfunctional adipose tissue simultaneously promotes type 2 DM and cardiovascular disease is by adipose tissue, depot-specific adipokines, inflammatory profiles, and metabolic dysfunction. I will come to all of them in my slides as we go along. In obese patients, the primary mechanism believed to be for insulin resistance is that's derived from white adipose tissue of the liver, skeletal muscle, accompanied by impaired insulin secretion by pancreatic beta cells. Role of adipokines in chronic inflammation. So if you look at this slide, this is the most important slide, I feel, to understand metabolism, where on the right-hand side, you see an obese adipocytes and on the leftmost side, it is a calorie-restricted, thin individual, underweight adipose cells. So on the right side and in the middle, we have the lean, healthy, muscled adipocytes. So obese adipocytes, as you can see, secrete into your systemic circulation high pro-inflammatory adipokines, and they have a decrease of anti-inflammatory adipokines, IL-6, IL-12, IL-18, tumor necrosis factor alpha, and these all contribute in these patients to chronic inflammatory diseases associated with obesity, and that is atherosclerosis, type 2 diabetes mellitus, non-alcoholic fatty liver disease, osteoarthritis, and asthma. On the leftmost side, I would like your attention for the calorie-restricted adipocytes, where because of there is an expansion of the brown adipose tissue, which I will also come and explain later. And in these cases, there is a high anti-inflammatory adipokines, but there is an excess lowering of pro-inflammatory adipokines, which also work on macrophages, which are very important for infection fighting in our body. So there is an increased susceptibility to infection in some cases. While in the lean adipocytes, we see high anti-inflammatory adipokines and a balance of the pro-inflammatory adipokines. So there is a wonderful balance between an immune and a metabolic homeostasis in lean muscle. Adipokines and their functions. Adipokines are important mediators of various metabolic processes such as fatty acid oxidation, lipogenesis, gluconeogenesis, glucose uptake, insulin signaling, energy expenditure in metabolic active tissues such as liver, skeleton, muscle, and brain. I just mentioned three, we have more, but the three are most common. Leptin is one of them, which is found to be low or absent in extremely obese patients. And prolonged fasting cases, we have shown sharp drop in plasma leptin levels, which drives food intake. So basically, leptin is for satiety. Adiponectin, I feel, is the most important, is a new insulin sensitizing hormone that impacts a wide range of tissues. Its expression and circulating levels are inversely proportional to adiposity levels. It has higher expression in subcutaneous white adipose tissue than visceral white adipose tissue, and leads to metabolic improvements involving decreased hepatic gluconeogenesis, increased liver and skeletal muscle fatty acid oxidation, increased glucose uptake in skeletal muscle. Adiponectin receptors are also highly expressed in skeletal muscle, liver, adipose tissue. Adiponectin also works in mitigating beta cell loss by neutralizing inflammatory and lipotoxic ceramides. All of it put together, adiponectin plays a protective role in mitigating features of metabolic syndrome. Resistin is so named because of its ability to resist or interfere with insulin action. Plasma resistant levels have been shown to be increased in obese animal models and humans, and to decrease with weight loss in humans. Evidence suggests that visceral fat is the largest contributor to circulating resistant level, supporting the case for an association between resistant and insulin resistance. What is white adipose tissue and brown adipose tissue? White adipose tissue, which can be broadly classified by location, and this is very, very important. Subcutaneous, located under the skin, and visceral, located intra-abdominally. The subcutaneous white adipose tissue is the most prominent depot in lean, healthy subjects, makes about 80% of all adipose tissue. Subcutaneous white adipose tissue acts as a metabolic sink for excess lipid storage. When this storage capacity is exceeded, either due to an inability to generate sufficient new adipocytes or an inability to further expand, fat begins to accumulate in ectopic visceral sites. Certain conditions such as obesity and lipodystrophy, the white adipose tissue mass increases ectopically very fast in the visceral regions. Certain conditions, the brown adipose tissue represents a distinct type of adipose tissue that is characterized by its morphology and function, with concentrated mitochondria giving it a characteristic brown appearance. And the brown adipose tissue mitigates ectopic lipid storage by taking up circulating fatty acids, clearing triglycerides by oxidative phosphorylation. It represents only about 1 to 2% of fat stores in humans, so it's not as important as subcutaneous white adipose tissue for metabolic function. So if you can see in this diagram, the trained white adipose tissue is on the left side, which is the healthy subcutaneous adipose tissue, secreting healthy adipokinins, which improve your metabolic health through work with skeletal muscle, liver, and expanding the brown adipose tissue mass in the body. So what should be the basis of reversal of concepts in T2DM? The loss of visceral fat is associated with reduced fasting glucose levels and insulin levels. It is also established that aerobic exercises increase fuel mobilization from adipose tissue by increasing lipolysis and subsequent free fatty acid mobilization, which ultimately decreases adiposity and adipocyte size. The number 3 criteria should be, it has been suggested that pronounced sustained weight loss over time can lead to improvements in adipose tissue inflammation. This was not observed in the same subjects following acute moderate weight loss. So it's very important to understand that loss of visceral fat is definitely associated with reduced fasting glucose levels. And they have also found out that in aerobic exercise, the fat that is the fastest to move from our body is the visceral fat. So it is very important for us. Lifestyle management approaches. So if we have precise nutrition by complex carb counting, portion appropriate, balanced schedules, progressive fitness plans where we break the movement inertia, and we have frequent empathetic coaching for sustained habits, giving cues, cravings, response, understanding them, and then working with individual person. There is a very high chance of overall reduced insulin resistance by long-term beta cell function recovery, prevention of glucose accumulation or overflow in the blood vessels, and hence reducing inflammation, insulin production optimized through receptor structure recovery, prevention of excess fat generation in liver, and improve the gut nutrient sensing and microbiota community, which we all see now is become a very important factor in glucose homeostasis in our body. The role of tech in medicine cannot be ignored anymore. How do we achieve this? Is by having a connected ecosystem which has all 100 plus signals which are captured daily through this connected tech ecosystem and given to the health care professional that takes care of diabetic patients. This could come through fitness device integration through your Apple Watches, Fitbits, and you do image-based, voice-based, WhatsApp-based activity logging. You can do continuous glucose monitoring, connected glucometers. You can have vitals recordings. And these 100 plus signals are captured daily and analyzed by your personal healthcare provider, which gives you personalized intervention plans, leading to better patient outcomes in type 2 diabetes mellitus reversal. Now, where is this all a reality? So I'm bringing to all of you a retrospective evaluation of the combined effectiveness of a coach-led, technology-enabled, habit-based approach with personalized nutrition, progressive fitness, and behavioral interventions on reducing A1C levels in people living with type 2 diabetes. So the objectives of the study was to retrospectively evaluate the combined impact of various lifestyle interventions through their approach on A1C, fasting blood sugar, and body weight. Target identified components and use relevant approaches through, again, personalized interventions to improve glycemic goals. Prove efficacy of an end-to-end program for a sustainable reversal that leads to beta cell recuperation, metabolic recovery, and reduction of end-organ complications from diabetes. So this is, again, 150 individuals with type 2 diabetes who participated in SugarFit's diabetes reversal program was compared with a control group of 110 individuals also with type 2 diabetes on a usual pharmacological treatment plan for a duration of 90 days. And in the SugarFit diabetes reversal program, there was a personalized daily life coaching, one-to-one nutritional counseling, personalized progressive fitness routine, personalized nutritional plans, behavior change assessments, positive habit adaptation, teaching them mindfulness, looking at their sleep, and doing a person-centric one-to-one approach. A physician teleconsultation on demand at regular intervals during program happened, where the assessment of continuous glucose monitoring readings, SMPG glucose monitoring readings, and medication titrations were done. This was all channelized by highly personalized lifestyle interventions and educational content, a deep tech that brought in all the information that was fed by the patient to the healthcare provider for a more personalized solution. There was a deeply empathetic coaching, which was crafted on evidence and science-based knowledge. So the A1C changes over 90 days, and this showed a mean decrease of 1.9 plus minus 1.53%, P less than 0.000%, and they were divided into age buckets of 20 to 35, 36 to 50, 51 to 65, 66 to 80, and they analyzed the reduction over 90 days in all these cases. And if you see that the average reduction actually was 1.87. In the control group, there was a mean A1C gain of 0.04 plus minus 0.29%. It was further analyzed that in various groups of A1C, they showed that the higher the starting A1C, the greater the drop after 90 days. So if a person was more than 11, showed a 3.65 average drop in A1C compared to somebody which was between 6.5 to 7.5, and the average of all these was 1.87. Fasting blood sugar over 90 days also significantly showed a reduction of 62.2 plus minus 51.8 with a P less than 0.0001. And in the control group, the mean decrease was 1.42 plus minus 2.5. So the age buckets, again, with the average fall of FPS drop was highest seen between 36 to 50, but it was very similar in most age groups except 66 to 80. Weight changes over 90 days also in this population, 79% of the participants had weight loss goals and their average drop was 3.18 plus minus 2.62 kg. This was also statistically significant. I don't have the number here. The control group actually showed a mean weight, 0.50 plus minus 2.37 kg. The final summary here with an average A1C, average fasting blood sugar drop, average weight change between the various age groups was determined, and all of them showed A1C showed a 1.87 and the fasting blood sugar showed 62.2 as an average drop, and weight was an average 2.80. So my takeaway for today's talk would be reversal of T2DM is here. It is here to stay. Understanding of metabolism, and that too at an individual level, is the key. Weight reduction with personalized nutrition and progressive fitness with increase in lean muscle mass and subcutaneous wide adipose tissue has shown tremendous results for type 2 diabetes reversal. Intensive monitoring of patients through personalized interventions for nutrition, progressive fitness, mindfulness, and well-monitored medication has shown significant change in patient outcomes. Thank you very much. These are the references in case you want to read. And thank you again. In Bengaluru, we have beautiful flowering trees at this time, and we would love to welcome you here in case you visit. Thank you.
Thank you, Dr. Chavi. That was a wonderful talk and definitely gives all of us much hope for the future in reversal of type 2 diabetes. And for our next speaker, let me welcome Dr. Virendra Mishra, senior cardiologist from Burjil Hospital, Ream Island. Morning, he has traveled all the way from Abu Dhabi to be with us today physically to deliver this wonderful speech. Unfortunately, we are a little delayed in timing. So the coming speakers, just be mindful about the timing and let's try to be on target. Otherwise, we may compromise on our tea break. Thank you, and let me welcome Dr. Virendra Mishra to deliver the next talk, and that's going to be about saving lives by changing a lifestyle. So we are going to focus on these simple advices on how we can really make a difference by doing simple acts, but with long-term benefits. Thank you, and over to Dr. Virendra Mishra.
So, good morning. So, the second step after the reversal of diabetes, what we can achieve is control of your cardiovascular status. WHO says a healthy lifestyle is the way of living that lowers the risk of being seriously ill or dying early. It also says that though not all disease can be preventable, but the large proportion of deaths, particularly those from the coronary artery disease, lung, can be avoided. And how it can be avoided? Just all of you, those who are here, ask 4 questions. Are you smoking? Can you control your weight in the BMI of 18 to 25? Are you eating 5 servings of fruits and vegetables? Are you doing exercise of 45 minutes, 5 times a week minimum? These are the 4 pillars. Let us see what other pillars and what are the other proof for it. So as the first most important pillar is the diet. What is important in diet? It has been repeatedly told by WHO as well as AHA guideline, we need to eat 5 servings of fruits and vegetables every day. Eat the colored fruits. Whatever the colored, whether it is a yellow, orange, red, they all give different flavonoids and different vitamins and different minerals. Cut down processed food. All processed food is not for the health. They are for the business. If somebody is producing food in the market, he's not doing charity. He's just using the cheapest oil available and allowed to use. He is using the preservatives and other products to make it more tasty for you. It's not for the health. Avoid trigger foods. Take time for your eating. Prepare your meals on your own. Then you're going to use the best product to prepare your meal. Avoid more calorie food. Take the low calorie food, healthies. Keep BMI in 18 and 25, even by intermittent fasting. Smoking, there is no role of smoking in this world, whether it is a vape smoking, midwak smoking, or cigarette or shisha smoking. We have nearly 20 to 30% patients, they are addicted to midwak. Midwak is very dangerous. I don't know how many of you really have seen this in public literature. So drink more waters, get enough sleep, do good exercise. For exercise, always is stress. It is not only simple walking. There is independently has been proved in many publications, which will come. Physical exercise, which is your gym, walk, run, dance, any games, play, they are good. Yoga and joint exercise with breathing exercise has shown independently improves your milieu inside the body or internal organ fat, which is the endocrine organ. Meditation, mind controls body. If your mind is good, your body is happy. If your mind is depressed, your whole body is depressed. What is the proof? This 1990, very good publication came in Lancet. Can lifestyle reverse coronary artery disease? It is a lifestyle heart trial. It's one of the very good trials. Here what they did, it's a prospective randomized controlled trial, and these patients were followed up for 1 year, just 1 year. 28 patients. They have taken and given an experimental group as a low-fat vegetarian diet, stop smoking, stress management, moderate exercise, and 20 patients with usual on their lifestyle, whatever they are doing, control group. All were gone coronary angiogram, or their lesions were categorized. They have 195 lesions. They were aggressively pursued for experimental group to follow the control of the lifestyle. After a year, the lesion from 40 regressed to 37 in experimental group and increased from 42 to 46 in control group. They also analyzed what about the significant lesion. Those days when it came, they say anything above 50 is significant, which is now is anything above 70 or 75 is significant. So anything above 50, from 61% reduced to 55, just in 1 year. And from 61, it gone up to 64 in control group. 82% experimental group shows changes towards regression. Amount 82%. And this is only in 1 year, that is without lipid-lowering drug. So this has proved. Then in 2003, another publication says we can control and prevent our blood pressure by simple lifestyle. And what they have shown, that if you go for DASH diet, which is they say diet appropriate to stop hypertension. And what is this? It's very simple. Fruits and vegetables, low-fat diets, reduce saturated fat, reduce total fat, reduce cholesterol, continue exercise. Simple thing. And what they have shown here, there is a marker here. What they have shown here, from 132 or whatever the blood pressure to prevent it, gone down to nearly 8 to 10 millimeter of mercury, both in systole and diastole. Whatever product we have here, whether it is a weight reduction, electrolytes control, all of them has shown beneficial effect. But if you join all of them together, there is a significant reduction in systolic and diastolic blood pressure. Another came, randomized control trial for lifestyle and pharmacotherapy. So people were saying, no, I can't reduce my weight. I have to take some injection. So they have gone to sibutramine. The time that publication came was very popular. So they, okay, let's check how much your injection working, how much is our lifestyle working. So simple thing, they give only injection, they reduce 4 to 5 kg. Is working. They give simple lifestyle, it reduces 7 kg. Better than simple your injection. So there is a third arm where they combine both. They reduce by 11 to 12 kg. So it is indeed working, but lifestyle has much beneficial and upper hand. Effect of comprehensive lifestyle for blood pressure, another premier trial. What they have shown in this premier trial again is that if you control your lifestyle, control your diet, control your exercise program, you will bound to reduce your systolic blood pressure as well as your diastolic blood pressure, both of them. So it has been confirmed. The lifestyle alone can prevent your blood pressure, can control your blood pressure. So they say if lifestyle is so much good, what will happen with the fatty liver? Now everybody is going ultrasound, found to 30 to 40% comes out with fatty liver. So let's say, okay, let's take this group also for lifestyle change. And in this group, when they realize, then when the lifestyle aggressively change, their fatty liver also has improved, their enzymes has gone down. Then they say, if the blood pressure is controlling, atherosclerosis and the blood pressure, the main control is our stiffness of the vessel. As the age advances, the vessels get stiff. So say what happens of lifestyle for our stiffness or the arterial stiffness. And they did lifestyle aggressive for them in just 3 months. Just in 3 months when they checked, the arterial compliance has increased significantly statistically. The carotid artery compliance in just 3 months with exercise and lifestyle. So there is numerous evidence which is suggesting that there is some help is coming. So they say, okay, let's do some analysis, find out how much it is doing, how much it is protecting. So they did the analysis, 55,000 patients with the different study. They come out, if you have a favorable lifestyle, no smoking, reduce your weight and obesity, engage in regular physical exercise and healthy diet, you protect yourself by 50%. So the lifestyle alone is protecting 50%, which none of the procedure can give you that much of benefit. None of the medicine can give you this much of benefit. So they say, what will happen? My father is having cardiovascular, he has a heart attack, my mother has a bypass surgery, I'm genetically prone. So I will have a problem with this, how much lifestyle can protect? So this is a beautiful publication which came in New England Journal of Medicine as a original article. And what they take, they took the 3 biggest study where they have a genetic, complete DNA analysis of the group. So one of them has 21,000 from atherosclerosis group. Another one is women's genomic, where 22,000 patients. Third one were from cancer study. And this group, they ask, okay, you go for aggressive lifestyle, you go for diet control, obesity control, and exercise. And look here what happened. They are all highly risk group, both atherosclerosis, women, Malbo. Their risk was so high, so they divided into the low, intermediate, and high risk group. And they also divided favorable lifestyle, intermediate, or unfavorable lifestyle. Where people are not listening, they say, no, I can't do that. I'm living the way, I like it, I'm enjoying it. Here they are. And if they go to favorable, they drop here, more than 50%. They are when they are genetically predisposed, their genes are bad, they are good. So in spite of the bad genes, in all the group, is the same trend was seen. It has been confirmed that the genetic predisposition give you 20 to 27% risk. But environmental factor can correct up to 70% of risk. There is another publication came for that part. So what they say, okay, we are taking lifestyle, what we should eat? You said we have this oil, we have that oil, with this oil. So this American Heart Association gone for that, our dietary fat and cardiovascular disease. So what oil is best, what should we cook, what should we eat? So they come out with idea and they have taken all the oils. From canola oil, coconut oil, palm oil, sunflower oil, and they found out how much saturated, how much monosaturated, how much polyunsaturated fat are there. They calculated lauric acid and their percentage, monounsaturated fat and polyunsaturated. Then they say, okay, let's do one thing. Just 5% of your saturated fat, replace it with polyunsaturated. Another group, 5% of saturated, replace it with monounsaturated. And someone replace with something else. And look what they found. 5% change with the MUFA, monounsaturated. They improve 15%, risk reduce. 5% saturated change with the PUFA, they 25% reduction, better than even MUFA. Then if they go only 2% to trans fat, which is all processed food they have, they've gone worse by 5%. They replace with whole grains 5%, they reduce at 9%. They replace carbohydrate refined one, not much benefit, just 1% was. So here it is very clearly says that your 5% replacement from saturated fat can give you benefit to 25%. In this trial, we also calculated if total mortality, what will affect to total mortality, what will affect on cardiovascular, cancer, neurological, or respiratory. To all surprise, they found out that the cardiovascular and total mortality is reduced more with the PUFA than MUFA. So if your polyunsaturated reduce, they are beneficial, just 5% we are talking here. Then they get the benefit here, cardiovascular much benefit here to compare. But of course, neurological shows much better with MUFA. And others are nearly same, cancer and this PUFA, almost same benefit. So there is a definite benefit and it has been proved. So what the presidential advisory came? It came by AHA to all of them, that the greater relative risk is reduced. If you just reduce your saturated fat, it can reduce your LDL. And what they say for cardiovascular, it is the polyunsaturated has given a good regression in non-human primate in polyunsaturated fat. So they have done this study and did the angiogram in primates, and they found out that they are regressing it. Lesions are regressed. But overall, irrespective, you change it to MUFA or PUFA, they are going to give you much beneficial effect and reduce your cardiovascular risk. Lifestyle modification and TRIUMPH trial. This is a very interesting. Why? Until now, we have shown you lifestyle, you can reduce your prevent your hypertension, control a little bit of hypertension. Here they say, no, we are talking resistant hypertension. What will happen if our blood pressure is very resistant? And they have got diabetic 31%, they have got chronic kidney disease 21%, and they will ask to go for aggressive lifestyle. So the same group who is a resistant hypertension on treatment now add aggressive lifestyle, control weight, go for DASH diet, go for diet control and exercise. Look at here, significant reduction, about 13 to 15% of blood pressure more, 13 millimeter of mercury, whatever already there. So this has been proved beyond doubt that it is working whether in the beginning of the hypertension or resistant hypertension. So they say, okay, so what is the guideline by AHA or came in circulation for lifestyle? If you look at the guideline, all are A1, 1A, 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 so controlling. So they say this is the primary treatment. You have to recommend them for them, whether it is a diet, whether it is a physical activity, or whether it is exercise. So the guideline is very clear. It is 1A. You have to do it. So they say, okay, so what is our risk? So they say health heart score. How much is our risk for the lifestyle? If we can predict, if this is our lifestyle, how much are risk? This is his lifestyle, how much is on risk? This is a control lifestyle, how much they are risk? So they have taken 61,000 women, and out of them, 3,700 has a disease, and others were free. 34,000 men, 3,500 have disease, coronary artery disease, stroke, coronary artery disease. They all were followed up for 24 years. 24 years. They all have lesions later on. 25 events they have, 2,500, 2,500 events. They calculated if you are having without disease, with disease, these lesions, what is our score? And okay, just 3 slides forward.
Thank you so much.
So we have got different fruits, different way to calculate, and what they have found, if you have control with healthier lifestyle, you drop from here to here, both in this man or both in woman. So there is a significant control. Last 2 slides. So reduction of atrial fibrillation, they have also come out that if you control your lifestyle, you can control your AF. So they came out with the 4th pillar in AF is lifestyle. What they have come out, all these things regressing your AF control. So here is the AF management, and this is the lifestyle control for the AF. So chances of AF is less, and this. So all-cause mortality and control of the lifestyle, what they have come out is that if you just stop smoking, and if you have a disease, you reduce 35%. If you do not have disease, like everybody healthy here, you have a chance of reduction 50%. If you add physical activity, you can reduce 25 to 30%. If you have a moderate alcohol consumption, 15 to 20%, or the dietary change, 45%. So ladies and gentlemen, what we say is in conclusion. We say that healthy lifestyle definitely lowers our risk for being ill, dying, or cardiovascular risk. Eat 5 servings of fruits, cut down your processed food, stop smoking, exercise, do regular exercise. This is very important for keeping your body fit and healthy. Avoid negative people in your life, avoid negativity in your control associated diabetes or hypertension or lipid. Definitely, lifestyle reverse your coronary artery disease, improves it, control blood pressure, control cholesterol, control your sugar, reduce your obesity, control your AF, your fatty liver, non-alcoholic fatty liver, and cancer and different conditions. So lifestyle has to be there, whatever management. Thank you.
Thank you, Dr. Mishra. That was a wonderful talk. I think there is, by simple lifestyle changes, we can do a lot to improve cardiovascular health, and that's very encouraging for all our audiences. And for the next speaker, I would like to invite Dr. Rami Nimtala. He is a consultant cardiologist here based in UAE, and he's going to speak about the role of MRI in cardiac imaging. I think this will be very interesting for many of us, internal medicine, family physicians, etc., because we know all about CT, but let's see what MRI can offer. And over to Dr. Rami Nimtala, and that's try to make it fast to compensate for the.
Well,
Thank you.
I'll do my best, I don't promise. Stop me when it's time. Good morning, everyone. Thank you, Dr. Mittal, for the invitation. And after 3 lectures, excellent lectures about diabetes and prevention, I'm going to take you somewhere else to cardiac imaging and a subject that I'm very passionate about. Well, cardiac MRI, as soon as they're ready. Okay, so, well, anyway, I'll start while they're talking. So basically, I'm supposed to give you a full overview on what cardiac MRI can do, is doing today, and can do in the future. Of course, it's pretty much impossible in 15 minutes, but I'll do my best at least to show you the strength of this technique, a technique that does not have radiation in comparison to many other techniques that are used in cardiology, so it's safer in this way. And a technique that can do a lot. It can do a function of the heart, morphology of the heart, characterization of the tissue inside the heart. It can check for ischemic heart disease by doing perfusion studies or viability studies, depending on what we're looking at. It can do flow imaging to study valves, to study shunts, to study congenital heart disease, Of course, it can characterize better than the other techniques, cardiac masses, pericardium, etc. So basically, it's a technique that basically can pretty much have, and it does have today, class 1 indications in most of the cardiac pathologies. So based on that, I was hoping that the technical issue is sorted. Well, I do apologize for that, but this is not coming out of my time, huh?
Of course, yes. It is coming out from the coffee times. So
Sure. You did try it. The video files are in the folder. Yeah. Which? Where's the USB? Should I give you my laptop?
Then we can do the next talk.
No, try from this laptop directly. No, but the videos will not work this way. But then we tried the presentation already on a different computer. So where did the presentation disappear? We tried it together.
A kind message to the audience. Kindly bear with us. There has been some technical glitch while loading the presentation. So hopefully we should be back soon. So while we sort out the slides of Dr. Rami, we will proceed to the next talk, and that will be Dr. Rupesh Singh, who is with us at this moment. And just to give a quick introduction of Dr. Rupesh Singh, he's a specialist interventional cardiologist from Al Zahra Hospital in Sharjah, UAE. And he's going to give us a presentation on chest pain triage and the strategies to roll out ACS. As we all know how important the triage is, and that can save a lot of time, as we are always targeting the time from the door until the needle or interventional procedure. And Dr. Rupesh is going to highlight how important the role of triage is, and where that's going to help save many lives and myocardium. And over to Dr. Rupesh Singh. Welcome to the podium to give the talk. Thank you.
So good morning, and thanks for the kind introduction. So my topic is to present the chest pain triage strategies to rule out the ACS. And in the coming few slides, I'm going to emphasize what is important to do in the ER department particularly, and for the triage of these patients. So this is the overview. I'm not going to discuss anything here. So basically what the importance, chest pain is the common presentation of ER department, almost like 5% of all presentation. And spectrum is quite wide. It can be serious, both like cardiac seriousness like ischemic heart disease, or it is non-cardiac but still very serious like pulmonary embolism, pneumothorax and aortic dissection. or maybe trivial like osteochondritis. So we have to deal in this spectrum and everything require different treatment. So what the aim of triage is to sort out the urgency with which medical assessment should occur. And this is based on the obviously presenting problem, patient clinical appearance, vital signs. Usually definitive diagnosis is not possible during triage. So basically once we come to the chest pain, basically we deal with the three categories of the patients. There are two categories were very clear, like first one, as we know, it all depends upon the pre-test probability sort of things. So like in this example, 62-year diabetic male with significant chest pain for the last 2 hours and with diaphoresis. So from beginning very we know that what we are going to deal with. Second group like 35-year female, known chronic disease with chest pain for last few days unrelated to efforts. Again we know that we are going to deal some very trivial issue, not any big issue. But the majority of chunk of patients come in the third categories, we can say almost 80 to 85%, where we have to take some decision on based on the test and this thing. That like example, 55-year-old hypertensive male having chest pain for last few weeks unrelated to efforts, but since morning having the pain present in the rest, but in mild in intensity. So these patients basically gives the, you have to apply the rules and how to evaluate. So proceed whether they require admission or just observation or just discharge and follow up on the OPD basis. So what are the features of cardiac and non-cardiac chest pain? Just summarizing, as we know that dull, tight, ache, pressure radiating to arms, shoulders and neck associated with some nausea, sweating or shortness of breath, worse with the exertion or emotional disturbances, presence of cardiac risk factor. So all this make the probability of having the real ACS. And this right hand side reassuring that they are usually non-cardiac. Example, sharp stabbing, shock-like or pin pricking pain, very brief like few seconds or few minutes only. Worse with the inspirations, point tenderness on chest wall, no associated other symptoms, no risk factors. So usually we're not dealing with the cardiac chest pain. But remember, none of these are foolproof, because in the particularly females and old age population we deal with where they are present very atypical symptom but having the ACS. How do I know if it is serious? Sometimes it is very obvious, as we have discussed, like the itching chest, gray, sweaty, shocked patients. Sometimes very minor, as we know that boil on chest, minor falls, chest wall tenderness, abrasions, so we know that it is non-cardiac. But as we discussed in previous slides, mostly it is somewhere in between where we have to apply these rules. Assume it is serious until proven otherwise. It's a golden line when you are dealing in the emergency. The basic goal of assessment of chest pain in ER is obviously perform ECG within 10 minutes of arrival, which is a standard protocol I think every hospital follows, and immediately exclude the STMI, which is the most dangerous and most life-threatening condition. Identify complications by just some clinical examination like shock, heart failure, arrhythmia, which can clinically, with focused clinical examination you can rule out. And then commence urgent treatment if you are dealing with the STMI, because time is they are very important. What the disposition? Obviously STMI, they have to go for CCU and primary PCI, cath lab. Intermediate risk, here you have to take again decision whether they need ICCU or in advanced investigation like CT or MRI something. Low risk, they can go and come with the OPD follow-ups. So basically last year the HA has published the guideline also for the chest pain in ER. I just briefly review those slides. So same thing with which are the significant chest pain probabilities more when the left side like central pressure, squeezing, gripping, heaviness, tightness and exertional is stress related, and retrosternal chest pain. And same time on right side sharp, fleeting, shifting, pleuritic and positional pain. They are very less likely to the cardiac things. Initial evaluation, these are the pretest probability according to age group. If you see when we are dealing above 45 years of age, the pretest probability of non-specific chest pain, the next common cause is the basically ACS. I'm not going to details, but these are the description of the typical chest pain. But location of the radiation, we have to remember any pain which is going beyond the umbilicus or hip, they are usually not from the heart. Like patient coming telling I have some pain radiating to my left arm, but is still going to the left arm, left lower limb. Usually it is non-cardiac pains. So the uniqueness of chest pain in females, as we have discussed, they can present with atypical. So women who present with the chest pain and at risk of underdiagnosis and the potential cardiac cause should be always be considered. You cannot exclude just by saying that the gender. And in women presenting with chest pain, it is recommended to obtain the history and emphasize accompanying symptoms that are more common in females than with ACS than the male. They may present with the like atypical symptoms, only tingling sensation or burning pain over the chest rather than typical retrosternal heavy pain. Similarly, in the old age population and patient with the chest pain who is above 75 year age, ACS should be considered when the accompanying symptoms such as shortness of breath, syncope, acute delirium are present, or when unexpected falls happen. We have seen some patient coming with the second immediately delirium only, we found they have inferior wall MI and shock related all symptoms are going on without any chest pain. So in patient presenting with the chest pain, focused cardiovascular examination should be performed initially to aid in the diagnosis of ACS and other potentially serious causes of chest pain, example aortic dissection, P and the esophageal rupture, to identify the complication of ACS by simply seeing the pulse, BP and these things, and chest examination. These are the characteristics of the other non-cardiac but still serious issue like the P. The patient can have tachycardia, tachypnea, and like the aortic dissection, they have usually other comorbid condition in the form of connective tissue disorder, extremely pulse difference, severe pain, abrupt onset, pulse difference. All this can are the mediastinal widening on the chest X-ray. These all suggest for the aortic dissection. Other sometime patient can come with the chest pain, but the cardiac chest pain, but they have not ACS like SCM, as we know. Pericarditis, myocarditis also can many times present with the chest pain, but they have not the ACS. In all patients who present with acute chest pain, regardless of the setting, an ECG should be required and reviewed for the STMI within 10 minutes of arrival. This is the AHA guideline basically. In all patients presenting to ED with the acute chest pain or ACS, troponin should be done at the time of arrival, irrespective of the duration. For the patient with chest pain, like example, presenting to the OPD basis, we have to sit immediately to the ER without any delay. X-ray chest in patient presenting with acute chest pain, a chest radiography is useful for evaluating potential other cardiac or pulmonary and thoracic causes of symptom, as we had seen every time in ER patient presenting with acute pneumothorax, severe chest pain, and simple X-ray have make the diagnosis what we are dealing. Coming to the biomarkers in patient presenting with acute chest pain, serial troponin at high sensitivity basically level are useful to identify the abnormal values and rising or falling pattern indicative of acute myocardial injury. And in every institution they do their own, you can say, cutoff point that we have to aware wherever we are working. Nowadays the CPK, these things are now class 3 indication, means they are now no need for doing them when you have high sensitivity troponin available in your hospital. These are the ASC. I have put one slide which is very important for acute diagnosis of ACS. Like there are 3 categories. Either they present with a very low drop, like example 0, or delta change. Delta change usually like 1 to 3 hours change, and usually in the different assay it is different defined. But general rule is that a raise of 10 nanogram or raise of the 20% in that duration, then you are dealing with the high sensitivity. Here high delta changes, and then it is rule in. Basically you have to take the decision whether you are keeping CCU or a ward. But if delta change is less than 10 or 20% rise or very low troponin like 0 or 1 or 2, then it is ruled out. You can discharge and you follow up in the OPD basis for the CCT or CMRI. And those in the in between you have to observe, then you have to repeat this thing over the 3 hours, then you have to take the decision. Yeah.
short on time.
So it is also recommended that whatever hospital you are working, some clinical pathway has to be developed for the making the decision, which sort of patient we are dealing. So, like in this approach, we have to just see the history and physical examination. Then obviously ECG is the first thing. If it is the obvious non-cardiac cause, it is excluded, and obvious non-ischemic card also included. If possible, if possible ACS is there, then we have to order the troponin, and then we have to apply some clinical decision pathway, and according to we classify these patients either low risk, intermediate risk and high risk, and then accordingly we have to take the decision. These are the different pathways, clinical pathway. In our hospital we are using heart pathway, which is basically based on the ECG, troponin, ACE and the risk factor, and over that we classify the patient whether we are dealing with the low risk, intermediate risk or high risk. For the basically for the intermediate risk, which is the bulk of patient, where we have to do the bedside some transthoracic echocardiography to rule out the any other possibility of chest pain like the ventricular and valvular function, evaluate for wall motion normality, and assess for pericardial effusion. For patient with acute chest pain and who are high risk, who are high risk, the invasive coronarography is recommended, because then it can be as a part of treatment, not only for the part of diagnostic workup. And for high risk patient with acute chest pain who are troponin positive, in the whom obstructive CD is excluded by the either CT angio or the invasive angio, CMR or the echocardiography can be effective in establishing alternative diagnosis. So now the two other serious conditions which we deal in the chest pain is the acute PE, where they are basically CTP is the class 1 indication, and patient with acute chest pain with possible PE need to be further testing should be guided by the pre-test probability. These are the differential diagnosis of acute non-cardiac chest pain, which is long list. So in conclusion, the chest pain triage is the mainly to rule out the high-risk ACS patient and rule out the low-risk cardiac or non-cardiac chest pain patient to better utilize resources in the emergency department. Focus clinical examination, ECG, high-sensitivity troponin assay, and clinical decision pathway are the backbone of chest pain triage. Thank you.
Thank you, Dr. Rupesh. That was a wonderful presentation on how to manage and triage chest pain in order to identify and make the right decisions. And now for the next talk, we will have Dr. Rami, who will come back, and he's going to talk more about the role of MRI in cardiac imaging. And hopefully we'll have everything going on smoothly.
So let's see.
2 coffees for you.
So that's a better start. So role of MRI in cardiac imaging, no disclosure for the study. As I already explained, cardiac MRI can do a lot for patients, okay? From function to perfusion, to morphology, to viability, tissue characterization, flow and shunt evaluation, angiography evaluation, all this without any radiation, so definitely it is appealing. Now, and again, as I told you, based on what the MRI can do, today we have class 1 indications of the MRI. Class 1 indication in practically all of cardiac disease, from ischemic heart disease, of course, to cardiomyopathies, where there is a very important role of MRI, congenital heart disease too, valvular heart disease, especially for pulmonary valve stenosis or regurgitation, cardiac masses, of course, pericardial disease. So why can the MRI do that? How can the MRI do that? And what are basically the areas where we really need to order an MRI? Basically, the MRI has multiple pillars. The first one is the functional analysis to evaluate wall motion disturbances and ventricular function. Of course, the tissue characterization by doing the edema imaging, the T1, T2 fat sat to eliminate fat infiltration, for example, the T1 mapping, T2 mapping to differentiate different cardiomyopathies, stress perfusion, as we already talked about, we'll elaborate a little bit there, the infarct or the fibrosis imaging to quantify the injury, to check for viability, and also as we talk about flow imaging. So the first point is mostly functional analysis to evaluate the wall motion disturbances and ventricular function. We all know that calculating the ventricular ejection fraction is the most important predictor for morbid mortality in patients with heart disease, and the MRI does this best, basically. It is the gold standard to calculate that, and why? Because unlike the echocardiography, which is the first intention exam to do this, there are geometrical assumptions in echocardiography. There are limited echographic window. While the MRI is a 3D technique, we basically do slices through the heart. Okay, we calculate each slice, the end diastolic volume, the end systolic volume, and at the end of the day, we have the actual volume of the heart, so we calculate the exact ejection fraction. Most studies say that in average, there are 4% difference in the ejection fraction of the echo and the MRI. Of course, it is less when the heart is normal, and it is more when the heart is pathological or if we have regional wall motion abnormalities. So this is the first strength of the MRI. This is a 42-year-old patient, previous history of MI, multiple coronary stent. He had the RCA stent occluded. Let's see if it's going to work. Okay. So this is the video just to show you how we do the short axis. So we can have like these circles of the left ventricle, where's the anterior wall, the lateral wall, the inferior wall, the septal wall, and we can very clearly check each area of the heart really with an excellent spatial resolution, and even the untrained eye can clearly say that there is hypokinesia if not in this inferolateral or inferior wall. So it makes it really easy for us. The second pillar is tissue characterization or edema imaging. So MRI can really differentiate between acute and chronic infarct and can tell us when we have acute myocarditis, which also is complicated for other technologies. And this by using different techniques. The mostly used technique is basically the stir technique or the T2-way images, where the ventricle will look brighter in the area of the edema. Of course, new sequences like the T1 mapping and the T2 mapping are starting to be used for myocarditis, and while T1 mapping is more sensitive, T2 mapping is more specific for edema. And this is basically a case of acute myocardial infarction where you can see the clear edema in the anterior anteroseptal and septal wall, and then the correspondent fibrosis or scar, the late gadolinium enhancement after contrast administration. So the tissue mapping, I think this is something maybe not all of you are very familiar with, because it has gained only in the recent few years more importance, more validation, and especially in cases of cardiomyopathies. So doing the T2 mappings can really differentiate cardiomyopathies from iron overload to amyloidosis to Anderson-Fabry to myocarditis. So we don't only say infiltrative heart disease, we can say infiltrative heart disease, and this is looking like this pathology. So this is how it shows, for example, doing those the mapping and the different parameters. So depending on the different pathology, for example, if you have Fabry's disease, you have an inferolateral, in the inferolateral area, reduction in the native T1, and the extracellular volume is equivalent. While if you have myocarditis, that can still have the same late gadolinium enhancement in the same area, in this case, the native T1 are increased and the extracellular volume is increased. So the MRI will differentiate and will really guide us to which cardiomyopathy we really are looking at. So depending on myocarditis, whether it's infiltrative, whether it's MI or chronic ischemic heart disease, we have different values, and then we can differentiate by doing the mapping. So this is a case of Anderson-Fabry disease with the late gadolinium enhancement with the reduction of the T1. And this is also hypertrophic cardiomyopathy. So one of the cardiomyopathies, MRI not only can get us more clear image than the echo, but the cases that are really borderline, like this one, the echo was not really diagnostic, so they sent it to MRI. And okay, so this is the scene where you can see the 3 chambers view and the 4 chambers view. So we have increased thickness in the septum, but really not dramatic. It was measured by the MRI 16 millimeter. The ratio between the septum and the posterior wall is 1.7, and very importantly, we had fibrosis inside this area of hypertrophy. So the presence of fibrosis, definitely, it's not hypertensive heart disease. In fact, this patient did not have hypertension, and this led to the diagnosis of a mild case of hypertrophic cardiomyopathy. This is a case, a few months back, a patient from Africa came to me, 85-year-old, chronic kidney disease, severe LVH on the echo, restrictive pattern, wasn't diagnosed at that time. And by doing the MRI, checking everything, especially the late gadolinium, the quick wash out of the late gadolinium here, which is very white in all the ventricle, even with subendocardial, mid-myocardial. So this led to very suspicious case of cardiac amyloidosis that was, in fact, confirmed later on. Acute myocarditis, we already talked about. This is a recent case, a patient with hypertension, syncope, left ventricular hypertrophy on the echo with a reduced ejection fraction. So the T2, the STIR imaging showed increased signal in the inferolateral wall, myocardial edema, and then regional wall late gadolinium enhancement in this area also. Both these are 2 of the 3 criteria for the late Louise criteria, and this was a confirmed case of acute myocarditis. Now, to move from cardiomyopathy tissue characterization to stress imaging. So, of course, MRI can test for coronary artery disease, especially by doing stress perfusion. We can do it in 2 ways, either with vasodilator stress using the adenosine, regadenoson, or even dipyridamole, but mostly adenosine, or by doing a chronotropic, inotropic stress by using dobutamine. The idea is to detect a perfusion defect with the adenosine in the area where there is a significant stenosis. An MRI has been shown that basically is superior to, dobutamine MRI is superior to dobutamine stress echo in regard to diagnostic accuracy. And if we go back to the previous one, stress myocardial perfusion in MRI has a better sensitivity and better negative predictive value compared with SPECT. Okay, so SPECT is much more used than MRI because probably is availability and it's older, but MRI is more accurate and without radiation, and this is an important point to be taken. Okay, so this is a case of a patient who had an intermediate circumflex stenosis. This is the regional wall motion abnormalities. We can see it in the inferior wall here. It's a dominant circumflex. And looking at the perfusion study, this is basically the rest perfusion on this side. This is the stress one. You can see this complete inferior wall stress perfusion defect that was basically much bigger than the one seen at rest. So in this case, it was a positive case of ischemia, and the patient was revascularized. Today, not only we can do it visually, but we have software to do a fully quantitative perfusion, but even more than that, today we are starting to be doing stress imaging without the need of pharmacological agents. So there are MRIs that are compatible with exercise using treadmill or mountable bikes, and even we can do MRI stress perfusion without the injection by using the T1 mapping sequences with stress. So this is still work in progress, but this is quite important for the future, I would say. The fibrosis or scar imaging, which also is a hallmark of MRI to check for viability, to check and to quantify the extent of myocardial infarction. Depending on the pattern, we can say this is ischemic, if it's subendocardial or transmural, or if it's mid-myocardial or subepicardial, it's mostly non-ischemic pattern. Of course, the MRI has an excellent spatial resolution. It outperforms SPECT to check for small areas of infarct, especially in the non-anteriorly located infarcts. So then for the viability with MRI, if the scar is less than 50%, then the myocardium is mostly viable. We should revascularize, and if the scar is more than 50%, then we shouldn't vascularize. So this is how a chronic anterior MI would look on regional wall motion, and this is how a transmural scar would look on the late gadolinium enhancement. So it's a fibrotic white tissue of the ventricle. This is another case where we have an anterior MI, but also a no reflow. So even though the epicardial artery was open, there was complete microvascular obstruction. Sorry, it's not coming back. okay, microvascular obstruction leading to this effect of black area inside two white areas, and of course this is completely destroyed myocardium, and there is absolutely no viability there. So also, by using the late gadolinium, we can diagnose whether it's ischemic or non-ischemic, the cause of heart failure, for example. And this is a case where we have a small pericardial effusion, we have a low ejection fraction, we have a clear akinesia of the posterior wall, hypokinesia of the anterior wall. We know that we had an infarct here and we have a stent on this artery, but what's the cause of this whole reduction of the ejection fraction? Doing the late gadolinium enhancement, seeing two different patterns of gadolinium. Here it's a transmural gadolinium, and here it's mid-myocardial. Mid-myocardial gadolinium in the septum is typical of dilated cardiomyopathy, and in fact it was a case of ischemic cardiomyopathy on top of a non-ischemic dilated cardiomyopathy. So we had both. To finish the study with the flow, velocity, and flow mapping. So I'm going to just show you the new technology, what it does. We have 4D flow today, not only 2D flow, where we can clearly see, in fact, the flow of the blood. This is a bicuspid aortic valve, so the flow here is completely different, is eccentric, is going into the aorta and dilating the aorta. We can quantify the flow, the gradient, at any point of this image. And this is a case where we have a complex atrial septal defect that wasn't clearly diagnosed by echo. So we did the MRI, and on the MRI we can clearly see here an unroofed coronary syndrome. So the communication is between the left atrium and the coronary sinus just before it goes into the right atrium. Doing the MRI without any contrast in this case for the flow quantification and without radiation, we managed to see the unroofed coronary sinus. We measured the diameters, got the QP over QS, which was moderate in this case, 1.55, both ejection fraction, left ventricle, right ventricle, and a clear assessment of the right ventricles, which is definitely superior in MRI than in X. So to conclude, cardiac MRI today is the gold standard for volume quantifications and cardiac function evaluation, as I demonstrated, as well as the gold standard for the assessment of myocardial fibrosis or scarring. Many validated advances in tissue characterization and flow studies, as we've seen, have been achieved recently to keep the MRI, have the MRI a fundamental roles in pretty much all cardiac pathology, and definitely the absence of radiation is a quite important advantage to MRI. However, and we have to note that today's MRI availability and expertise is still a major limiting factor. It's not widely available. It takes time. It needs subspecialty and expertise, and hopefully we'll get it more and more in this region. Thank you.
Thank you very much, Dr. Rami.
To have your questions later on.
Yes, so Dr. Rami, you are the only person who can do justice to this complex talk in such a short time. And let me tell you that Dr. Rami is one of the best, rather the best cardiac imaging specialist in the city for CT, MRI, everything, and we rely and trust him so much. With his practical as well as scientific knowledge, he is not a diagnostic guy to start with, he is actually a cardiologist and entered into cardiac imaging. Thank you so much. We go forward for the next talk. Dr. Chavi will introduce the next speaker and the topic. Dr. Chavi, over to you. Are you able to hear Dr. Chavi?
I can hear you.
Yes, please.
So before I introduce Dr. Adriana, I'd like to really congratulate Dr. Rami for this fabulous talk on his MRI imaging, cardiac imaging, and various kinds of cardiomyopathy, stress imaging, flows. I mean, thank you so much. This has been so informative that we'll carry with us as primary care doctors. Fabulous. And it's my pleasure now to introduce Dr. Adriana
Dumitru.
Dumitru, and she is a critical care specialist at Medicare hospitals in Dubai. She has not only taken care extensively the ICU and critical care, but she was highly involved in the COVID care of patients during a hard time. So thank you so much, Dr. Adriana, and please continue.
Thank you so much for inviting me. I think my talk is especially at the end of this morning session, after discussing about what can happen if you don't change your lifestyle, if you don't control your diabetes, your weight, so you can end up in a critical care unit. Because I've been asked to discuss about the critical care aspects in an unstable patient, and this is quite a vast subject. I decided to illustrate that through a case presentation. I'll be quite quick. Okay. So I decided to choose the case of a 47-year-old patient who became responsive after while playing cricket. I'm sorry, but I think I sent yesterday a little bit updated presentation. This is another one that I sent yesterday. Anyway, I'll go forward. So it was a 47-year-old male that while playing cricket, he became suddenly responsive. Luckily, a bystander who was BLS certified, he started immediately CPR, and the ambulance arrived there in about 5 minutes. On the ambulance monitor, there was a VF freedom. He received around 5 DC shocks, and he was brought to our Medcare hospital. In our hospital, CPR was continued. This is just a few segments from the strips that we had there, and finally the patient he went into ROSC. He was very unstable. He was very hypotensive. So he was put on. He was intubated, put on the mechanical ventilator, and he was started on inotropes, dobutamine, and noradrenaline. I think I have. Okay, and this is the previous. Okay, there was an ECG also which was showing the ST elevation mainly in the anterior leads, and the patient was quickly taken to the patient was taken to a cath lab. There it was a reperfusion done. LAD was stented, and because the patient was very hypotensive, an intra-aortic balloon pump was also placed and shifted to CCU. In CCU, he started to slowly improve. And what I wanted to highlight here was the monitoring that was done for this patient. So alongside with the daily echo, for which the cardiologists were helping us with, the patient was put on minimally invasive cardiac monitoring, and he was daily having assessed his fluid responsiveness, systemic vascular resistance, and his cardiac output and stroke volume variations, just to adjust the inotropes, noradrenaline, or dobutamine. Luckily, this is a case in which, this is the ECG that he had. This is the case with a happy end. In the next couple of days, the patient's condition slowly started to improve. And his inotropes were slowly decreased, and intra-aortic balloon pump was removed, and he was taken off the ventilator successfully. And the patient was discharged with an improved heart condition, meaning that after arrival, his EF was around 25% with global hypokinesia. At the discharge time, he was already having a EF of around 45% with some hypokinesia of the anterior wall. What I just wanted to highlight here is the importance of the collaboration between the critical care doctors and the intensive care unit. I am lucky enough that in our hospital we have a very good collaboration, and we are having we understand and we know how to help each other. because it's so important to have a good cardiologist that understand your point of view as a critical care specialist, and for you also as a critical care specialist to really take in consideration the cardiologist's points. It's what was also it was very good to see in this case was a few aspects, like, first of all, this patient had a very good chance from the moment he received CPR from a bystander. There are studies now showing that for usually around only 40% of the cases of out-hospital, from out-hospital cardiac arrest, only 40% CPR is starting from a bystander. And there is one study, I'm sorry I don't have the proper slide it seems, in one study which showed that in some countries in which they have a very good education of the population, they actually have a 60% of starting the CPR in out-hospital cases, and for these patients the survival is much better. And they are comparing with the same demographics. There is one study showing Norway and Holland. In Holland they have around 40% of CPR started by bystander, comparing with Norway where they have around 60%, and this is mainly because of the awareness that is it is through education in public places, through schools. So this patient was lucky enough to have someone that can start early CPR. The ambulance came in less than 5 minutes, and the DC shock was given in the first 5 minutes, which also studies show that a DC shock that given in first 5 to 7 minutes, it can increase the survival to around with more than 50 to 70% in shockable, if we are talking about cardiac arrest through shockable rhythms. After that, the patient was brought to ER, and from there, the door to needle time was less than 1 hour. So this is why this patient had so much luck, because there were all these factors that worked, and it ended up with his survival. And we are talking about a young patient of 40-something with diabetes, and actually he was not overweight, but he was having unstable diabetes, uncontrolled diabetes. And one other thing that I wanted to highlight through my presentation was also the post-cardiac arrest care, which is so important, and it has now a special role in even the ACLS protocols. Now there is a full chapter that's discussing mainly about the post-cardiac arrest. Starting from the patient's optimization of the ventilation, optimization of the hemodynamics, optimization of the sugar, which is so important for the patient not to become hyperglycemic, which is showing that it has worse outcomes, but also very tight sugar control can end up with episodes of hypoglycemia. So this is why it's so important to have a very close monitoring of that. It's also very important to have a very good control of the electrolytes and acid-base balance. Well, most of you are cardiologists, and you already know how important are the electrolytes for the heart function. And not the last part, it is about the prognostication, which is so important for us to have from the beginning a very good prognostication, and to prepare the family for what can happen to the patient from the early stages. Again, I'm sorry I don't have all the slides, but I hope that I highlighted what I wanted to do. Okay. Thank you so much. Thank you.
Thank you, Dr. Adriana. That was a wonderful presentation on how the ICU can coordinate with the cardiology department, and this is really a backbone of our hospital. And Dr. Adriana has helped us in multiple ways in stabilizing the patients until definitive intervention can be done. And this is one of the very good cases that she presented today.
So now you helped us a lot in saving time, Dr. Adriana. Thank you so much. That is great. So we can spend 5 minutes for summarizing the. We can spend 5 minutes in summarizing the talks of the morning session. And we have Dr. Chavi, Dr. Selvin, myself, then we have the speakers. So anybody can volunteer, can give few quick comments about each lecture. If there is any question from the audience, we can take it. But the time limit will be 5 minutes, then we'll break for a small coffee break.
I think I will start with asking Dr. Abdul Jabbar. So you can pass the microphone. Dr. Abdul Jabbar, so I really enjoyed your talk. And I would really like to comment that we are focusing more on the younger population, especially adolescents. Early recognition, I think insulin resistance is very, very common in this region, especially because of their access to sugary foods. This is very, very significant in this region. I think in our younger days, we could not afford many sweets. Maybe we were fortunate, but the younger generation has their own pocket money and they tend to spend a lot on sweets. And we are seeing this obesity as well as insulin resistance in the younger age group. So I think the early start of metformin is one of the treatment strategies that we generally use, and sometimes convincing parents are a bit difficult. I want to ask you about the role of GLP-1 for using in younger population. So I just want to get your opinion, especially since we have oral options available these days.
Thank you, Dr. Selvin. So I think you already summarized. I agree with you. I think the most important part to give the education for the lifestyle change. So I've seen since the availability of the GLP-1, some of the nutritionists even are prescribing Saxenda before giving the dietary advice. So I think we have to look into the root cause. Like you said, insulin resistance is the root cause. The root cause is the lifestyle, which has changed. It's not only the pocket money, it's the mobile phone. You don't have to go and pick the phone we used to do when we open the door, we had to go. Change the TV channel, we had to walk. So all these steps are gone from our life, and more so from the children's life. And if you're talking about the early, I think the early means as soon as the problem starts, which is around 10, 20, teenage group. Thank you very much.
Yeah. So interestingly, the first 3 talks which we planned and designed are focused around prevention. So early detection of diabetes is prevention. Dr. Chavi said reversal. Then there was an excellent talk rather from Dr. Mishra for saving lives by changing lifestyles. So all these things focus on prevention. And may I remind you once again to everybody that SHAKE was founded not to teach the techniques of doing angioplasty or interventions. It is planned to prevent deaths and damages from heart attacks. So that means prevention. So we are working on this part. Now, in one line, Dr. Chavi, can you explain our audience once again, what do you mean by reversal? Do you mean reversal in each and every patient possible?
No. So reversal is possible in most patients. And as Dr. Jaffar said, the earlier you diagnose, the easier it is to reverse.
Yes. Okay. Correct. So
Since
you can give us.
one-liner.
Yes. So I can actually request two of you, and including Dr. Mishra, if you can give one paragraph or slide of your presentation, which I'll post and put on the website forever, for our website clickers as an easy information. So I will appreciate that. That will carry forward our plan and messaging mission.
Absolutely.
So thank you so much. for taking part and all the way from there. Now, we had a presentation from Dr. Rupesh. Dr. Rupesh, in one line, can you tell us what are the fallacies in the ER and how to overcome that and delays which leads to more damage and more deaths in cases of heart attacks?
Yeah, actually, I think what we deal many times in this part of the world, we are dealing very young population, and many times we assume they have something else rather than the cardiac issues, and that make the main differences. Like inferior wall MI patient presenting with the upper abdominal pain, diagnosed as a gastritis or something, and we miss them. So this is the main fallacy. So whatever as we have discussed in our slides, any patient who present with some chest pain or discomfort has to assume ACS until unless proven otherwise. So do ECG at least within 10 minutes, keep high suspicion for that, and do troponin sensitivity, high sensitivity troponin, which almost have very high sensitivity for rule in and rule out both. That's true. So that is correct. The high index of suspicion is the key, and do not take it granted until proved otherwise. So then Dr. Rami's presentation was self-explanatory in many ways. We are still not yet so much tuned to refer our patients for MRI. One is the cost, insurance hindrances, and some kind of barrier in our minds also. So we need to learn more. And Dr. Rami, please start messaging and giving message to all the cardiologists time and again to utilize this much more. Dr. Mishra wants to comment, but please be very quick. We want to wind up soon.
Yes, just want to say one thing, that we should start what we call it the correction from home. As a cardiologist, we should be the example to our patients. So first, what we should do, none of our cardiologists should smoke. None of us should eat any processed or food. Get encouraged more for the fruits and vegetables, even in our conferences.
Oh, sorry, we have a coffee break now, please. That includes everything.
And then we should have one session of physical exercise, or even while session is going on, I was just thinking, stand up and keep walking. Even when you walk with the phone and you do something, step up from your chair, walk in your room. Keep walking. You will surprise you are completing 10,000 steps in a day. These are simple maneuvers.
Yes. Okay, thank you so much. The last is for Dr. Adriana. Would you like to make one comment about her presentation and anything specific?
Yes. Dr. Adriana, thank you. That was a good presentation. And how your ICU has really been helping all our departments. And we all, really, she is the backbone of our hospital when it comes to intensive care. She has really helped us even with COVID. And even you have managed many cardiac cases during the COVID pandemic with myocarditis, etc. So after stabilizing patient in the ER, how do you go about coordinating with the cardiology department?
Well, I will answer this. I leave upon her completely, and I forget and go to sleep. So that's the best answer from my side. Please, your answer.
So as I was saying, I am lucky enough to be surrounded by very reliable doctors. I believe that we have a very good communication between our team and the internal medicine and the cardiology team. So the patients are stabilized in ER, and after that, if needed, they go directly to the cath lab. We are already aware about that they are in the cath lab. Most of the time, I also go in the cath lab with our interventional cardiologists if the patients are unstable, and this is very good because you can see how the patients are behaving, and you know what are the main points of their post-procedure care. If the patients don't require intervention, they come to CCU. We also see them there, and there is
so much that it is done for an unstable patient that I think we should have a full presentation for that. Yeah.
Thank you. I think I will ask one last question, and that will be to Dr. Mishra. So we were all interested in seeing that the list of the oils that you presented there. Which would you say is the best oil?
One word answer.
You see,
One word.
Yes, the best thing what I will say, use oil as little as, not the 25 or 30% recommended by AHA, it goes down to 18 to 20% and low. And use PUFA and MUFA more than saturated.
How about coconut oil for all of us South Indians who are available here?
Coconut oil is in the past. They used to blame a lot on coconut oil. But coconut oil being saturated is one of the best.
Thank you.
Thank you so much. With this, we come to the end of this first session. It was a very good session. Finally, we ended reasonably well, and we will catch up for sure. So please give a big hand and to all the speakers who have taken efforts. Thank you so much. We cannot hear the clappings from the people who are attending online, and I suppose, as I've been informed, there are at least 100-150 audience who are available online. So we appreciate on their behalf also to all the speakers. Now we break for coffee break. 11:30 sharp, we will be back and start once again. So we are only 15 to 20 minutes away, but we can catch it up in the next session. Thank you so much. Thank you. 4 lectures. 2 are recorded. First 2 are recorded, and next 2 will be live. Please bear with us. There is some technical glitch on the monitor here, but the recorded lecture will start now.
Hello. Welcome back after a. Is it correct? Welcome back after a good break and excellent morning session. Now we are going to have lectures on revascularization, the real world situation for whether CABG is good, PCI is good, and what is happening in the real world. In view of the ischemia trial and other earlier trial, we should know what is CABG versus PCI for the correct revascularization. I welcome Dr. Hemant Lukras, Chief Consultant Cardiothoracic Surgeon at the American Hospital, Dubai, in UAE. And he's the expert in myocardial revascularization by CABG, and he will put forward the view on PCI. Welcome, doctor. Voice, please. Can we have voice? Can I request you to hold on for a minute because we don't have voice here?
Good afternoon. It's a pleasure to be able to talk to you today about And the things we were considering is obviously the clinical picture of the patient, but also predicted surgical mortality. What is the anatomical complexity of the coronary disease? Are we likely to be able to have a complete revascularization? And other factors which are patient and procedure related. So from that experience that I had in the UK, we published a fair amount of manuscripts. And I was lucky enough in 2015 to be able to be part of the group which had a joint statement from the British Cardiac Society, the British Cardiac Interventional Society, and the Society of Cardiothoracic Surgery. And our work was also recognized in the 2014 European Guidelines for Revascularization. So what did this experience teach us? In terms of the decision, when we looked at the huge number of patients that went through that process and we reviewed the heart team discussion meetings, we find that actually in about 20% of patients, the recommendation is either for medical therapy or PCI, or we need some further investigations to be able to make a decision.
CBG is a
And about a
preferred
third
option for patients with
were
diabetes,
recommending
poor
a
health
split decision
function,
on the table and make a decision,
recurrent diffuse
or
incidence of
also
noses,
consider what was recommended
competitive
whether it would be carried out.
dual antibiotic
And
therapy,
we checked
and
6
from
months later
anatomical
what happened.
considerations, the pricing and
We
score,
found that in
and also the
96% of the patients, the heart team recommendations were carried out. There was some change in the recommendation in the treatment that the patient received, either because the patient refused or the doctor who assessed the patient prior to carrying out the recommendation found that there were some additional comorbidities and had to change the decision, or some further investigations were required to actually come to a final decision. Now we did one more thing during those studies is for those patients who had already discussed and made a decision, 6 months later, we represented the same patients and sort of checked whether we're going to have the same decision. And it was quite interesting. The majority of the patients, it was the same decision, but in around 25% of patients, there was a slight change. And that's because there are certain patterns of coronary artery disease where there's equipoise, where we could treat the patients either with CABG or PCI, and either treatment was deemed reasonable. Now, what are the risks and benefits of either procedure? I'm not an interventional cardiologist, so I leave the risk and benefits of PCI to the cardiologist to discuss with the patient, but we have to take into account the need for dual antibiotic therapy, which in some patients can be a significant issue. However, patients recover very quickly after PCI. We're still not too sure in terms of long-term durability because the latest iteration of stents have been on the market for only a short period of time as compared to CABG. CABG, on the other hand, we have to recognize that there is a possibility of multiple early complications. Patients do take time to recover from the surgery, but there is a long-term benefit to be gained. There's a lot of misconceptions among patients when it comes to either procedure. When it comes to PCI, there was a study in the US, which was published about 10 years ago by Lee et al., which was basically a survey of patients who had undergone elective angiography. And some of them have had PCI during the same procedure. So when asked, about a third of them thought that the PCI was an emergency procedure that needed to be carried out during that elective procedure. And 2/3 thought that the PCI was saving their lives. In my clinic, a lot of the time, patients who come to see me prior to their CABG, they think that their life will never come back to normal. Actually, that's not true. I've got so many patients who would write to me after they've had their CABG. Most recently, a gentleman in his 70s, he wrote to me from the UK, raising some charity funds for treating COVID patients, and he had swum up and down a river in the UK in the cold weather for 5 kilometers. Some of the patients have done 7 marathons in 7 days, and others have been to base camp in Everest. So CABG actually does bring the patient back to normal life rather than impairs return to normality. So from a patient perspective, they want the best treatment with the least inconvenience and least amount of pain and a quick recovery, because many of our patients in Dubai are self-employed and they want to have long-lasting benefits. So they want all the good stuff without any bad stuff. And that's not always easy. So in summary, I would say that our patients need guidance because their coronary artery do not read pathology books, and we need to tailor our recommendations to the patient needs. We as doctors, we need to be transparent in our decision-making process. And we need to use evidence-based practice to ensure that the patient will get the best possible treatment. I thank you all for your attention and enjoy the meeting.
Thank you, Dr. Hemant. It was an excellent talk. We will have discussion at the end of the session. Now, voice is quite thank you, Dr. Hemant. Now we'll proceed to the next lecture. A calcified lesion in coronary artery has been a difficult question, and we don't know the correct answer. Dr. Mittal has put a very nice title to this, Suspect and Respect. So Dr. Hussain Heshmat is going to enlighten us on the calcified lesions, how to handle them. Dr. Hussain, please.
Hello and welcome. I'm glad to be in this SHAKEHEART wonderful meeting for the third year in a row. I'd like to thank Dr. Mittal for inviting me for this session. I'm Hussain Heshmat. I'm a professor of cardiology and interventional cardiologist in the UAE. And in the coming 15 minutes, I'll be talking about calcified lesions, how to suspect, and how to handle properly. So we'll be talking about why calcified lesions are notorious, how to grade the severity of calcified lesions, which tools are available, how to handle these tools, the advantages and disadvantages of each tool, and I'll be giving case examples from my practice on calcified lesions and how to handle them. So first, why is coronary calcification a problem for PCI? Because number one, it's a marker of advanced disease. Whenever you see calcium, the disease has been there for several years. Calcium is part of the healing process, so the plaque has developed as a fatty streak and it has grown, became inflamed, then it regressed, and calcium came here as a healing process, so atherosclerosis has been there for a long time. Calcium is hard, it impairs delivering the balloons, it impairs inflation of the balloons. Our balloons are plastic or nylon, they are nylon balloons, so they cannot inflate against a piece of rock. The rock impairs the delivery of stents and the expansion and position of the stents. Our stents now are drug-eluting. These drugs need biologic tissues that are active to interact with. Calcium impairs the delivery of the cytotoxic drugs. It can disrupt the polymer that releases the drug. The presence of calcification is associated with dissection, perforation, not only of the calcified but also the non-calcified segment. It's a major contributor to stent failure in the long term. How prevalent is it? We know that from the Horizons MI and the Acuity MI, looking at patients with acute coronary syndromes, moderate and severe calcifications are present in roughly 30% of patients who come for acute coronary syndrome treatment. The three major determinants are age. As we grow older, the vessels get more calcified, diabetes, and chronic kidney disease. STEMI is also a risk factor. Male gender is a risk factor, and high blood pressure are all risk factors. So whenever you see a constellation of these factors, you tend to suspect that the coronaries are calcified, even if we don't see it clearly on fluoroscopy. And you can see that calcium, as it gets more severe, tends to be associated with a more event rates, whether death, MI, stent thrombosis, target lesion failure, major outcome. In general, severe calcification results in roughly 20 to 25% chances of stent failure in the two registries. How can we see the calcium? fluoroscopy is here. When we see dense shadows, then we know that there's calcium, but if we don't see it, it doesn't mean that it's not there. That's why CT scan gives us more penetration and more visualization, but with a blooming artifact. Intracoronary, intraluminal imaging is the gold standard. We have IBUS, we have OCT, one based on ultrasound and one based on light. Intravascular ultrasound is easier to use, is a bit cheaper. Calcium here appears as a very bright and reflective signal that you cannot see what's beyond. There's a reverberation. Optical coherence tomography has a high resolution but less penetration. Calcium here would look different. It looks like a well-delineated segment. It's like a rock thrown in the middle of a sand. It's well delineated, can be superficial, can be deep. We hate the superficial because it impairs the expansion of the stents and of balloons. And the most notorious part is the nodular calcium that is projecting inside the lumen, and with these heavy thorns that can result in catastrophic events. The advantage of OCT, it can give us a quantified score of calcium, depending on the length, depending on the thickness of the calcium, which can be measured only by OCT, and by the calcium angle. A score more than 2 millimeters or 4 millimeters means that we need to be very aggressive, because if you do not prepare properly, then the outcome can be bad. What tools do we currently have? We roughly have balloon-based tools and catheter-based tools. The balloon-based tools, they exert pressure, where the catheter-based tools, they exert another form of energy by rotation or by laser energy. The balloon-based have advantages, and the catheter-based, the debulking, they have other advantages. And I will try to summarize them in this matrix that I came up with. We'll talk about first ablation techniques, the debulking techniques. Of course, cost is an issue for these techniques, higher of course for orbital atherectomy, but they give us an advantage in crossing, they give us an advantage in efficacy, but they are a bit clumsy in terms of demanding, not clumsy, they are demanding in their use, and they need a learning curve which is not essentially steep. Laser, of course, is the best. It works for thrombotic and for calcific lesions, but it's more expensive than any other tool, and it's not also easy to use. The balloon-based approaches are handy because we're all familiar with balloons. There's no big learning, there's no steep learning, no intense learning is necessary, and the cost is much less. My preferred of these is the high-pressure balloon. It's cheap, but the issue with crossing, it's very effective for both superficial and deep calcification. How to utilize all these? Go for balloon or for ablation-based? It depends. If you can cross the lesion, then of course go for a balloon. If you cannot cross the lesion, then you have to go for a rotation atherectomy, orbital atherectomy, or laser. If the balloon expands and gives you a good lumen, modifies the lesion, then that's fine. Then we can go for stenting. But if the balloon does not expand, then we again have to go for an ablation-based techniques. Now we go for the interesting part, which is real cases. Whenever we have severe calcification, I'll show you some balloon-based approaches and some device-based approaches. And the common dictum here, if you do not prepare the lesion well, then you are preparing for failure of the intervention. The first example is a balloon-based approach. This was a middle-aged gentleman who comes with a STEMI, and you can see here that the calcium is seen even before you inject, and all through the cardiac cycle. Means this is a severe calcified lesion. We crossed with our wire. Mind you that the presence of STEMI is usually a contraindication for debulking techniques like rotablation and orbital atherectomy. Laser can be used here, but where I work, laser is not available. So we went to the balloon-based approaches. We inflated the balloon, and the result was okay. Because of calcium, I tend to use the specialty balloons. In this case, we used a cutting balloon, and the result was marvelous. So we just treated that with a drug-eluting balloon, and the result was fine. So this gives us an idea and an example that balloon-based approaches, if they can be delivered and the balloon expands well, they are more than enough. Another situation here, more complex, a 70-year-old lady, history of PCI, history of cabbage, contrast nephropathy, severe chronic kidney disease, refusing dialysis, presenting by a very high risk and non-ST elevation MI. And you can see the culprit here in the proximal circumference. We did balloons and we counted heavily on IVUS because we wanted to minimize the amount of contrast. So although fluoroscopy doesn't show any significant calcium, if we look here, we see in the proximal circumference this part, which is 180 degrees of calcification. And if we go more proximal, you can see here that there is almost 270 degrees superficial calcification, not probably thick, but we used here a cutting balloon, the Wolverine. It can cross easily, inflated at 12 atmospheres. And then we looked again by IVUS. You will see here that the calcification is, you can see the cracks here of calcium, and the part that had a 270 degrees calcium, the calcium is starting to break. So we stented, and this is the final result. Just after cutting balloon and stenting, we achieved a good area and a good expansion. Another demonstration of if you can deliver a balloon and it expands, then it's all what you need. But it's not always smooth as we wish. This is an 80-year-old lady with a very high risk on ST elevation, ACS, and it seems like the calcium is not very aggressive, and it looked like a straightforward lesion, but here the OCT doesn't cross. And whenever you see shadows of fluoroscopic calcium and the imaging catheter doesn't cross, then you know that you should go for a debulking strategy, not just a balloon like I did here. We dilated with a 2-0 and a 2-5 balloon, but we still see a significant lesion that was not treated. And you see the dot boning effect with a 2-5 balloon, and the lesion did not yield to the balloon expansion. So we went in with an aggressive balloon. We used a 2-5 balloon up to 25 atmospheres. The lesion opened finally, but there was an abrupt vessel occlusion, and the patient was on the verge of cardiac arrest. You see the stagnant flow. We had to go with a quick stent and optimize the stent. And you see here the final result. We were able to save the patient. We did the classic bifurcation work, but if we went here first with a debulking approach, then the chances of a blood vessel occlusion would have been much less. And we learned the lesson. Whenever we see calcium and we see by fluoroscopy, then we can go first by debulking approaches like this 60-year-old lady. We see the calcium visible fluoroscopically in the LAD and in the circumference. So we ablated with a 1.25. We made sure that the balloon is expanding. Then we placed our stent only when the lesion was treated, and you see the final result with the DES proximally and the drug-eluting balloon distally. The result is marvelous. The circumflex, you can see here that the balloon was not able to be delivered, even with the presence of a guideliner. So straightforward ablation with an atherectomy, and then with a scoring balloon that is able to expand, and here we get a decent final result, both in the circumflex and in the LAD. Another case, a 55-year-old lady, diabetic hypertensive, smoker, mild CKD, non-ST ACS, and you can see here that RCA shows a critical lesion with probable some calcification that is not very evident. The calcium is obvious in the LAD in the circumflex, and you can see here the classic dot boning. This is a 275 millimeter balloon, and you can see it's not dilating. And again, this is a no-brainer. Go immediately for aorta. We went for 1.5 millimeter rotation and atherectomy, gently crossing the lesion, ablating it, and then the balloon is expanding. Then we can stent and we can optimize, because here we did the proper preparation with a debulking and with an NC balloon, and this is the result after stenting. Another gentleman here, you can see the shadow of calcification in the total occlusion of the LAD with a poor ejection fraction. So we had to support with impella, directly going for rotation and atherectomy. We see the calcium and the total occlusion. We ablated the lesion, we ballooned and we stented, and here is the final result. So the take-home message, calcified lesions are notorious. They are a marker of aggressive disease, marker of complex procedure, risk of perforation, risk of stent improper expansion. We need to quantify and plan with imaging. Take a low threshold for debulking tools. Balloon approaches work after debulking, provided the balloon can be delivered, and proper handling is the key for long-term outcome. Thank you for watching. I'll be available for discussions after the session. And thank you.
Excellent talk, doctor. We will have discussion at the end of the session. So please be available. Thank you.
Okay. Our next talk is on SGLT2 inhibitors in heart failure, which is the current latest management for heart failure, and it is included in the guidelines. But Dr. Amrish Agarwal will do the talk, and he is a consultant cardiologist at Fujairah Hospital. Thank you, Dr. Amrish.
Good afternoon, ladies and gentlemen. It's a pleasure to be once again physically in the SHAKEHEART, and I am with Dr. Mittal in this meeting from the time inception. And thank you, Dr. Mittal, for asking me. Big thank to Boehringer for bringing this very important topic to the attention of the people in this room. Now, one of the most important discoveries of the 21st century is actually the discovery of SGLT inhibitors and the implications it has in the field of cardio-renal and the heart failure. This SGLT inhibitors, they act on the proximal tubules of the renal tubules, proximal nephrons, and they actually prevent the absorption of glucose from the proximal tubules. This is the radar, proximal tubules, and eventually causes a loss of nearly 80 to 180 grams of glucose every day. The SGLT inhibitors are a powerful drug in the sense that they cause excretion of glucose from the body, and this causes a loss of the calories, and there are a number of neutral effects which occurs, particularly putting the body in the starvation modes and thereby reactivating a number of defense receptors which causes increased survival of the cells, decreases cytotoxicity and the phagocytosis and the atrophy of the cells in the human body. So the discovery occurred by a number of trials over the time, and one of the drugs which came up in the discovery by the work of Joseph Mering, this guy discovered ferrozine, which occurred discovery nearly 150 years before. So this was a German scientist, and he discovered the phylorizine. He described the blood glucose lowering effect of the phylorizine, and not only that, he postulated the action occurs in the kidney. And eventually, the scientists at the level, molecular level, were able to discover the action occurs in the proximal tubule of the intestines. So one of the big trials occurred with the SGLT inhibitors were the trial which was actually kind of game changer trial. The trial started to describe the efficacy and the safety of the molecule in the setting of type 2 diabetes. So this was the population with unselected diabetes and the high-risk diabetic. So they had a previous coronary artery disease or multiple high-risk features, age more than 60 years. And the effect was to examine the effect of empagliflozin versus placebo in addition to standard of care. The results were kind of remarkable, astonishing, surprisingly, and took the cardiovascular community and the nephrology community as well as the diabetes community by surprise, because the results showed very, very clearly a tremendous advantage reduction with respect to cardiovascular death. No cardiology drug has shown this type of magnitude of effect which is shown by cardiology by the SGLT inhibitors. So there was nearly a 38% reduction in the cardiovascular death, a 35% reduction in the heart failure hospitalization, first and the second one, and the death from any cause was reduced by 32%. In addition, a very, very powerful beneficial effect on the renal outcomes with the nephropathy and the composite renal outcome, and thereby establishing the role of SGLT inhibitors in the field of diabetes. Unfortunately, there is another disease which our cardiologists are having in our population, which we are suffering, is the heart failure. And overall, prevalence of heart failure in the population in the range of nearly 2 to 5%. And this population, prevalence of the disease increases with the age. So as the population advances, the prevalence of heart failure goes up. And typically, by the age of 60 to 80 years, which is the type of population we see in our cardiology practice in the Ministry of Health hospitals, the prevalence can reach as high as 10%. Secondly, these patients with diabetes, they have worse outcome when you are in the presence of heart failure. Secondly, the prevalent people with diabetes are increasing risk of heart failure. So the people with diabetes are nearly 2 to 5 times more high risk of developing heart failure. And once they develop heart failure, there is a more likelihood that they will succumb from the disease. So the outcome of diabetes with the heart failure is far worse than either of the outcomes when they are present alone. So the data was very, very clearly shown from the CHARM trial that whatever the category of heart failure we look at, whether we look at the reduced EF or we look at the preserved EF, you can actually see that the outcome is worse in the presence of diabetes than in the absence of diabetes. So after trying the empagliflozin in the unselected diabetic populations, whether they have heart failure, they don't have heart failure, and showing there's a tremendous advantage in the setting of heart failure in the patient with diabetes, researchers look further how we can work on this problem. So initially, we have this population with the showing the outcome, beneficial outcome of the SGLT inhibitors in the preclinical, because anybody with diabetes is actually stage A of heart failure. In this population, the researchers went on the further trial in the populations with the detectable cardiac involvement. And when we say detectable cardiac involvement, means population with a background of heart failure with a reduced ejection fraction, irrespective of the presence of diabetes. So the two trials will come out with both the SGLT inhibitors. 2019, we had the DAPA heart failure trial which came out, and 2020, we had the empiric-reduced heart failure which came out. And what did it show? The empiric-reduced heart failure was done in the population with nearly 3,730 population with the ejection fraction of 20%, with a very sick population, 20% population with the ARNI, and people with a EF of less than 30% were included. But those people with a EF of between 30 to 35%, they required much more higher level of BNP to be included in the trial population. The results were astonishing and surprisingly, because it showed very clearly that that the primary endpoint, which was the composite endpoint for cardiovascular death and heart failure hospitalization, were reduced by 25%. And second, the total heart failure, so total heart failure means the first heart failure as well as subsequent heart failure hospitalization, was reduced by 30%. In addition, what did the trial show? There was a tremendous advantage in the renal outcome, and you can see in this diagram that the renal outcome came down by nearly 50% in the population. So hazard ratio for developing a renal composite endpoint was significantly reduced in empagliflozin versus placebo. So in the setting of the heart failure with the reduced EF, empagliflozin showed in the primary and the secondary endpoint significant statistical reduction. More importantly, both the trials showed the benefit is not at all just limited to the population with diabetes. Whether you have a background of diabetes or you don't have background of diabetes, it has got a significant effect. And that is why both the guidelines which came out in 2021, the European Society guidelines and the American Society guidelines update, they included SGLT inhibitors as one of the pillars for the heart failure. So they say that the initiation of heart failure, patients should have an SGLT inhibitors right on board at the same par level what you have with the patient with the ARNI, beta blockers, MRA, and SGLT inhibitors. So this population, or this phenotype of the heart failure in which all the drug was studied was the population with a reduced ejection fraction. And typically this population is characterized with a patient with a diffused hypercontractile left ventricle, dilated left atrium, you can have some degree of mitral regurgitation, dilated right side of the heart, and the speckle tracking will show a globally reduced longitudinal function. This type of population, what we see in our group, is not seen in all the patients with heart failure. This characteristic phenotype is seen in less than 50% patients with heart failure. And in 2021, the Heart Society guidelines, Failure Society guidelines from all over the world, they came together and they actually put a very, very clear criteria of classification for the heart failure based on the ejection fraction. So this is the universal definition and the classification of heart failure, which is a report by Heart Failure Society of America, European Society of Cardiology, Japanese, and also endorsed by half a dozen other societies. And they said very clearly, if the EF is less than or equal to 40%, we can say this population is with a reduced EF, and data which I showed you was applicable to this set of population. However, 50% of the population have the group which comes from more than 50%. This from 41% to 49% is called as mildly reduced ejection fraction, and those people who are 50% or more is called as heart failure with a preserved EF. So this is the major RESIZE classification. Of course, the patients from one set can move to another set. They can go downgrade or they can upgrade with respect to the ejection fraction, but they are classified on the basis of initial presentation of the ejection fraction into the various subsets. So what are the phenotype in which the heart failure function is not reduced? This phenotype is characterized by the this image is not going on the left side. They're actually very, very nice images because you didn't enable the contents. So you can see this segments are the one. Let me try once again if you can move. No, it's not moving, but no problem. This is characterized by the left ventricle, which is not nearly normal size. A thickened left ventricle, you can see not all the left ventricle is thickened. The ejection fraction is preserved. It was moving. You could appreciate that the EF is more than 60% plus. You can see some amount of pericardial effusion. You can see the dilated atrium and the dilated right atrium. And you can see that the longitudinal strain of the left ventricle is kind of preserved. Here, the GRS values are 30%. This population with the heart failure, with the preserved EF, is having a big chunk of the population. We can say approximately 40 to 50% of total heart failure patients fall in this group. And this population has a high mortality. So the historical study says that 30% of this population can die within 1 year of admission with the heart failure hospitalization. In the real life, we see less death for him because we are able to put on the medications far before they go to a natural history of the disease. Second of all, there is no clinical proven therapies which are available to reduce the outcome in this population, and the treatment options by the current guidelines are recommended for symptom control and the control of the morbidities. So if you see the contemporary guidelines and the latest contemporary guidelines, the European Society guidelines, there are no change in the recommendation for the heart failure preserved EF. This population have the very poor outcome. So it appears very clearly that the preserved ejection fraction does not implicate a preserved outcome in this population. The European guidelines of 2021 have no recommendation which are class A for the population with the heart failure with preserved EF. So the evidence in this population is lacking. Second of all, the European Society guidelines, if you see and you see the text for him, you can see these are the two recommendations they are giving for the population with the heart failure with the preserved EF. The first recommendation is that you screen and treat the underlying etiologies, which are cardiovascular, non-cardiovascular, and the only recommendation which is class 1 is diuretics. All the recommendations are class 2 recommendations for the population with the heart failure with the preserved EF. Over these years, number of drugs have been tested in this population with the heart failure with the preserved EF, and you can see that all these drugs have been shown the neutral outcome in the population. So this drugs therapy in the population with the heart failure with the preserved EF is not working at all, and data is neutral in this regard. What about the newer drugs? There are certain newer drugs in the pipeline, and if you see the newer drugs, they are also neutral in the population with the heart failure with the preserved EF. As you can see, there is no support for sildenafil in the heart failure preserved EF. There is no support for nitrate. There is no support for ivabradine, and there is no support for vericiguat, which is the new drug and which we'll hear from Dr. Mittal sometime shortly. So all these drugs have been found to be very, very neutral in the population with the heart failure with the preserved EF. So what are we left with? That is why the trial which came out with the empagliflozin in this population with the heart failure preserved EF is very, very important, because we have seen a tremendous advantage with respect in the population with the unselected diabetic with the empiric outcome in the population with the reduced EF, which is the reduced ejection fraction, and trial which came out few months back, which I will present somewhere down shortly, is the trial which is called the Emperor Preserve trial. This Emperor Preserve trial is the trial which is done in the population with a preserved EF more than 40% or plus. In the background of whether they have diabetes, they don't have any diabetes. So in this population, which is a phase 3 trial, included nearly 6,000 patients. So this trial was identical to the trial of Emperor trial, except the EF is more than 40%. Otherwise, the patient selection criteria, the pathway, the clinical pathway, the inclusion criteria, the exclusion criteria were nearly identical. That is where the results can be compared, and we will see the result comparison somewhere down the line. So what the trial showed? The trial included this population more than 18 years of age with the EF more than 40%. A number of composite primary endpoint was studied. This composite endpoint was the sum total of cardiovascular death and the time to the first hospitalization for the heart failure. A number of secondary endpoints were studied. Second of all, what the trial included, the populations were very, very, very matched between the two groups, and you can see with respect to the population, they were quite similar. So more populations were in the class 2 patients. So class 2 population were nearly 81% of them, and the class 3 and class 4 were total, including 20% of populations. What about the ejection fraction? Each subset, more than 40%, included 1/3 of the population. So you can see that nearly 1/3 of the population was between 40 to 50%, 1/3 between 50 to 60%, and 1/3 were more than 60%. Overall, we can say that 2/3 of the population had the ejection fraction more than 50%, because we know between 41 to 49%, we call them heart failure with mildly reduced ejection fraction. So what the results showed? The results showed very clearly dramatic, similar data which is parallel to the data that was seen in the heart failure with the reduced EF. The results showed very nicely there was a 21% reduction in the primary endpoint, and this p-value is very much significant. So the 21% reduction in the sum total of cardiovascular death and the heart failure hospitalization, which was driven mainly by reduction in the heart failure hospitalization. The total heart failure hospitalization, which included the first event and the second event, showed nearly a 27% reduction, and you can see the curve they separated very early, and they kept on separating to the duration of study, and I'm sure if we continue the study more longer, we will have more separation of the curves. So mainly the primary endpoint was driven by the reduction in the heart failure hospitalization. Cardiovascular death came down numerically, but the p-value did not reach significance. What about the kidneys? The benefit of the kidneys with respect to the empagliflozin in the population with a preserved EF was matching similar to those of with the reduced EF, and you can see that the rate of decline of GFR with empagliflozin with the population with a preserved EF was very excellent, and the rate of decline decreased by nearly 50% as compared to the general population. So the trial had 3 hierarchical hard points. First primary endpoint, secondary endpoint were 2, which included the real endpoint, and we can see the trial was positive in all 3 respects. The primary endpoint reduced by 21%, the key secondary endpoint reduced by 27%, and the GFR showed improvement. There was a composite endpoint which was changed in between the trial and the post-hoc analysis from 50% to 60% reduction in the GFR, and that also showed significant improvement for him. Other important takeaway from the study, there were a number of other important findings which were noted in the study, but which were not part of the pre-specified primary or the secondary endpoint was there was a 29% reduction in the need for admission to the intensive care unit during the heart failure hospitalization. So that means these patients are stable enough to be welcome in the ward. There was no need to be put in the intensive area. A non-significant 33% reduction in the need for IV vasopressors or positive inotropic agents which was seen during the heart failure hospitalization. Second of all, a significant increase in the number of patients achieving a higher NYHA class function class, and more importantly, which was seen that the treatment with empagliflozin was also linked with a significant 39% relative reduction in the emergency or urgent care visits that require intravenous therapy. So these are the sum total of benefit which came out from the trial. Like I told you, the trial will release only 4 months back, and I am sure somewhere down the line we will have more interesting papers published for the Emperor preserved heart failure trial. So what could be the theoretical mechanism of benefit in the population with the preserved EF? Well, this is all theoretical because empagliflozin has been shown to have favorable effect on number of molecular mechanisms which can show a tremendous benefit. For example, you can see it can have a increased nitroxide bioavailability. It's been shown in the study. It shows in the protein CKG signaling. This is the type of signal which is active when the body is in the starvation mode. There is a reduction in the stiffness of the myocardium, so myocardial stiffness is reduced. So is the reduction of fibrosis, hypertrophy, and so on. Overall, whatever happens, there is an improvement in the diastolic function. As a clinician, we are looking at the improved diastolic function and thereby causing improvement in the cardiovascular outcome which occurs in the patient with a preserved EF in this population. So if we compare and contrast the 2 trials which were parallel, the reduced EF and the preserved EF done in the similar set of populations, done by the same investigators, the only difference was that the left side had EF less than equal to 40%, on the right side EF equal to 40%. You can see a parallel outcome regarding the patients. What was seen, you can see that the cardiovascular death and hospitalization heart failure, which is the primary endpoint, was reduced in the both statistically significant. Time to first hospital hospitalization decreased significantly. Death was reduced numerically in both the groups, although it did reach the p-value of significance, and the total heart failure hospitalization for heart failure reduced by 30% in the reduced and reduced by nearly 27% in the preserved. So it appears the benefit of the molecule extends from across the whole ejection fraction from the reduced to the preserved. So can we take the data pool? So there was a very, very interesting paper published in the same European Society in the presentation by Milton Packer and his group. What they looked, dissecting the results of the emperor according to the ejection fraction, what we can learn. And they showed that the benefit of empagliflozin, when you plot according to the ejection fraction in the pool data, extends all the way down to 65%. So the benefit, you can see this is the hazard ratio, the line is the unity, and you can see 25%, 35%, 45%, 55%, up to 65%, there is a benefit in the hospitalization for the heart failure. Whether you take the first heart failure hospitalization or you take the total heart failure hospitalization, the benefit becomes negotiated only when the EF crosses 65%. Similar benefit was seen across the heart failure hospitalization and the renal endpoint, and you can see the benefits when you dissect by the ejection fraction, whether you take 40 to 50%, 50 to 60%, and more than 60%, up to 60% or 65%, you can have a benefit in the cardiovascular outcome with regard to hospitalization of heart failure, as well as with the renal endpoint, whereas the cardiovascular death we said was neutral in the respect, as because the p-value did not reach significance. So it appears to us that the two group end of the spectrum, the preserved EF and the reduced EF, they behave differently. This data, when you look retrospectively, data from the other historical trials, you can also see that the benefit in the respect to the outcome goes beyond the population we see in the EF for more than 40%. For example, you can see in the paradigm trial, the benefit extends up to 57%. When you see the results for the spiral electron, you can see the benefit also goes up to 55%. When you see the beta blocker trials, you can see the EF reaches nearly 50% benefit. And the same thing for the candesartan, which is the ARB, the results is going to 55%. So it appears we are dividing the heart failure ejection fraction a little bit erroneously. We are taking EF of 40% as the cutoff, but the clinical data shows that the cutoff goes beyond 40%, perhaps around 55%, 57%, and 60%. So the heart behaves differently depending on the ejection fraction. You can see on the left side is the population with the reduced EF in the 40%, and there the modifiable outcomes, so the targets, neuroendocrine targets are very, very important. That is why RNA is very, very effective in this population. On the other hand, once the EF crosses 55%, our ability to modify the disease diminishes because non-modifiable outcome factors come in the play. These targets are not yet defined, but we know certain drugs are acting on these targets, such as the SGLT inhibitors. There are comorbidities such as hypertension, obstructive sleep apnea, and many other parameters which come into play. So that is why our drugs are not that effective. And then there is a band between 40 to 55% where certain drugs act on the benefit and the variable degree, which has been seen historically from the different trial. So when you will take this data of the RNA, which is another class of drug which is very popular in the population with heart failure, and you take the drug in the SGLT inhibitors, what can we compare? What we can see very, very clearly that SGLT inhibitors are far more effective than RNA across any class of ejection fraction. So the red lines are the lines with the SGLT inhibitors, and the blue are the one with the RNA. So they are having much more benefit regarding the cardiovascular death and the heart failure hospitalization. However, in both the classes of drugs, you can see the benefit persists approximately up to 60 to 60%. It's only when you cross this line of the ejection fraction, the benefit diminutes and there is not much benefit in the clinical outcome. So is the time has come to revise what are the cutoffs for the ejection fraction for the heart failure? I think this is true. And there was a paper which was published by Lamb and his group, and along with Scott Salmon. And what she said that the classification of ejection fraction or the heart failure according to ejection fraction, and the time has come to revise these cutoffs. What they are suggesting? They are suggesting very, very clearly it is much more easy when the population with the EF of less than 40%, we can call as the heart failure with the reduced EF. This we all agree, and we have no quarrel with this calculation. This should stay like this before. But however, what is the normal EF? The normal EF they are saying should be classified differently for men and women based on the data, because the men, they derive benefit up to 55% based on the trial from the 100 trials and the dissection from the benefit of circuitry valsartan in the population with the preserved EF. Second of all, for the women, what about the women? The women that derive more benefit up to the population of 60%. For the woman, it seems that the EF cutoff should not be 55%, should be 60%. And there are a number of reasons why the woman EF cutoffs are different, because the women have a smaller ventricle, smaller cavity size. So the percentage of stroke volume which is ejected out from the left ventricle is much more higher numerically. So for the woman, the cutoff is around 60%. And anything in between, they are saying you can put as a mildly reduced EF. So we cannot have an abrupt fixed cutoff of 50%. It is possible, I'm sure down the line, within a year or two, next time we'll meet and maybe next SHAKEHEART, we can discuss this, more data will come out, that this cutoff will be revised by the guidelines. Till now, what we saw, the consensus of all heart failure guidelines is 40%, 50%, and 40 to 49%. With this, I come to the end of the talk by saying certain things. Empagliflozin is a very, very important drug, and I want to just show one slide before I say my conclusion. This is dated 24th of February, and we are today on 17th of March. This is like 2 or 3 weeks back, that FDA approved empagliflozin for the treatment of heart failure with the preserved EF. This is the only molecule which has been approved till now. And this subset of the population, the FDA has approved by saying to a group of the patients, a group of heart failure where few treatments have found to be effective. So FDA really approved this molecule very, very rapidly based on the trial of Emperor Preserve trial. With this, I come to the end of the talk by saying that historically, Emperor reduced trial has shown remarkable benefit in the population with heart failure reduced EF, and this is now a standard recommendation by all guidelines, and we need not want to debate and discuss this because this is a done thing now. Second of all, heart failure population with the preserved EF, they comprise 50% of all group. So we cannot ignore and dust it below the carpet, because this is 50% of the group. Every second patient we'll have come to this group, and historically the guidelines are not clear, the data is very sparse, and the drugs are not very effective. Till that introduction of Emperor Preserved EF trial, which shows clearly a benefit in the heart failure hospitalization. Heart failure hospitalization is a very important surrogate marker for the outcome regarding the population with heart failure. If you have a heart failure hospitalization, the chances of dying subsequently increases dramatically. Readmission is a marker for sudden death somewhere down the line. Emperor Preserve trial showed very, very clearly that empagliflozin can significantly reduce the rate of cardiovascular death and hospital heart failure, a 24% reduction. And FDA has granted 2 weeks back approval for empagliflozin for the full range of heart failure. Thank you very much.
Dr. Pandey, the chairperson, friends, colleagues, it's my pleasure to take this focused update on inclisiran. And some of you may have heard about it, some of you may have used it, but I'm sure majority of you do not know about it. So let's look what inclisiran is, how to get to the LDL target. So learning objectives are that we know that cardiovascular disease is #1 killer. LDL is the key factor. Statins are the backbone of therapy. Ezetimibe and PCSK9 inhibitors are established non-statin therapies as far as we knew or we know. And now we have a new and exciting molecule. So most cardiovascular disease and most cardiovascular deaths are due to atherosclerosis, known as ASCVD, atherosclerotic cardiovascular disease. 18.6 million people reported to be dead by this alone in 2019. It is a leading cause of CVD mortality and morbidity. In the past 60 seconds, when we are talking, about 34 people may have died with atherosclerosis worldwide, and either by the MI or by stroke. So imagine the magnitude of the problem. It is a problem much bigger in our part of the world, in the Gulf world. In the Gulf, it is reported that most common cause of deaths and up to 45% are accountable due to CVD, cardiovascular diseases. We have a population which is abnormally and very high prevalence of dyslipidemia in this area, and our population is 10 to 12 years younger than our Western counterparts. So there are two studies which I will show very quickly about cardiovascular disease in the UAE. So UAE has a high prevalence of multiple cardiovascular risk factors, out of which dyslipidemia is the maximum in the prevalence. Then each year 294 per 100,000 people die from cardiovascular disease in the UAE. On average, people in the Gulf region are younger, as I showed you earlier. The burden of dyslipidemia is very high. If you take the Emirati population, it is as high as 72%. If you take the prevalence in the total UAE population, it is about 35%. In another trial which was conducted in Africa and Middle East, it was shown that among all the prevalent cardiovascular risk factors, the maximum prevalence was for dyslipidemia to the tune of 70%. So elevated LDL is the key factor for atherosclerotic cardiovascular disease, and other two important factors being, out of three top factors, are the unhealthy diet and high systolic blood pressure. Now, benefits of lowering cholesterol have been shown long before, more than 2 decades before this very large analysis, meta-analysis of 38 trials in primary and secondary prevention settings showed that as you reduce the LDL or as you reduce the cholesterol, you reduce the total mortality as well as coronary heart disease mortality. But despite all this, approximately half of patients did not reach the recommended LDL cholesterol goals in several studies. This was a CEPHEUS trial done simultaneously in the Asian countries and in the European countries, and you would notice that as many as 50% patients or more did not reach to the requisite level. This was a bit older trial, and then we can say that there is a lost opportunity in prevention. Most coronary patients do not have optimal LDL cholesterol level. This is a bit newer trial, EuroAspire 5. Patients on lipid-lowering therapies. So you can see that although 81% patients were on statins, only 32%, only this number actually reached to a goal of less than 70 in the patients who were actually suffering from coronary artery disease. So 70% or 78% patients were not at the target. In the real world, too many patients are still at risk. 33% reached to their goal, and 18% reached to a real possible best goal in the established ASCVD patient. We know the targets. Now, when we talk about a meta-analysis done 10 years before, 15 years before, which showed that we had lost the opportunity, since then the targets have actually been stricter. So if we put those targets into the perspective, then you would see that even lesser number of people are reaching to their goals. So now the targets are tighter. The LDL is less than 70 as per the ACC AHA guideline in the high risk category, and went further down by the ESC recommendation in 2019. So they added a new category of very high risk group. The LDL target was set at 55 or below. So to reach to this target, we need to have more medications. Statin alones have tolerance issues. They have their limitations. They alone cannot work in the full go. So non-statin LDL lowering therapies are being studied. We know two of these categories, ezetimibe in IMPROVE-IT trial, as well as PCSK9 inhibitors showed in the Odyssey and Fourier trials. We have used them. We are using them. They are in the recommendations. So now there is a next molecule which is known as inclisiran. So how, first of all, if we want to understand inclisiran or any other LDL lowering agent, we should know how the LDL is controlled. The LDL is controlled by the LDL receptors. If you have more receptors, there is more clearance. So what we need to have, we need to preserve the receptors. So what does inclisiran do? Inclisiran is, so LDL concentration is largely regulated by level of LDLs in the bloodstream. So how the different agents work to regulate the LDL level? The statins actually upregulate the LDL receptors. Then the PCSK9 inhibitors inhibit PCSK9, which is a destructor of LDL receptors. So if you inhibit PCSK9, you will have more LDL receptors. And inclisiran actually prevent formation of PCSK9. So when there is less PCSK9, there is more availability of LDL receptors. So everything is based on LDL receptors, and we have to make more LDL receptors available. So inclisiran was studied in the Orion program. It was a large program. So first, what is inclisiran? It is the small interfering double-stranded RNA. It acts in the hepatocytes at the level of the cytoplasm, not in the nucleus, and it mimics the RNA interference pathway to prevent production of PCSK9. So it's competitive inhibition with the original messenger RNA, which makes PCSK9 and this molecule. So this molecule prevents formation of more PCSK9. When there is less PCSK9, there is more LDL receptors. So this is what we would need. Now there are three sets of trials, as always do happen in the research areas: phase 1, phase 2, and phase 3. So there are a number of trials in phase 1, phase 2, and then phase 3. Some of the trials are still ongoing. The most important clinical studies, phase 3 studies, are Orion 9, 10, and 11. The Orion, they almost came simultaneously, were published in the early 2020 in NEJM, both the sets of trials. Now, Orion 9 involved the patients with heterozygous familial hyperlipidemia if they had LDL more than 100. The Orion 10 included patients with ASCVD alone, and if their LDL was more than 70. And the third group, Orion 11, involved the patients who were ASCVD or ASCVD equivalents. So these are the three important trials which were carried out. So these were 18 months double-blind and randomized placebo-controlled trial. The first dose of injection was given on day 1, and then second dose was given at day 90. Third dose was given after 6 months of this dose, and fourth dose was given after 6 months of third dose. So this is how it was planned: 0, 3 months, and every 6 months. The key primary endpoints were percentage change in LDL cholesterol levels from baseline to day 510 or 18 months. Time-adjusted percentage change in LDL cholesterol levels from baseline after day 90 and up to day 540. So there are two important things here which you can see: how much is the percentage change, as well as how much is the change sustained between 90 days to 540 days. So these are the two very important primary endpoints. In the secondary endpoints, there was absolute change in LDL levels from baseline, and similarly between 90 days to 540 days. And then there are changes and studies of the other markers of lipids. So the baseline characteristics of the patients were mostly similar in the three groups: so Orion 9, 10, 11 patients, and a high number of patients were on statins, more than 90% already. Now, this was remarkable. If you see that on top of a statin or maximally tolerated statin in all the three trials, 9, 10, and 11, the percentage change was huge in LDL, and the reduction was to the tune of 50% plus minus. So it was a huge change. And if you see in this specific particular trial on ASCVD, the Orion 10, which was dedicated to ASCVD patients, you would see that there was 52% reduction in LDL cholesterol at month 17. And there was 54% sustainability. Between 90 days to 540 days, this change was sustained over a period of time. You can see the curves which are highly separate between the placebo and inclisiran. So not only the levels were reduced significantly, but they were sustained also. So there was significant absolute reduction in all three, Orion 9, 10, and 11, up to 60 in Orion 9, 56 in Orion 10, and Orion 11, 51. So percentage change was almost 50%. The absolute change was also in the tune of 50 to 60. So up to 74% of patients from Orion 10 and Orion 11 were able to achieve guideline recommended LDL cholesterol levels of less than 70. So this was a great achievement. At least you were having some extra agent which can help us in reaching to the guidelines in a majority of the patients. So what inclisiran did, it not only reduced LDL cholesterol, it reduced the PCSK9, it reduced the total cholesterol, it reduced the non-HDL cholesterol, it reduced the ApoB, it reduced the LPA, and in all three trials, we could see some positive impact on the HDL also. And what about the side effects, which were generally similar between inclisiran and placebo groups? Most participants experienced injection site reaction. That was the only real side effect, if you can say, which was different. It was predominantly mild, and none of were severe or persistent. Now, there are ongoing trials, and our interest is mostly in this trial, which will be cardiovascular outcome trial, Orion 4, which includes patients of more than 55 years with ASCVD, with prior MI, stroke, or PAD. It's a huge trial of 15,000 patients, and as I understand, the results would be out somewhere in 2025. So we are waiting for this because CVOT is very, very important method to look for the efficacy of any medication. Also, the adherence is increased when you have the agent which is infrequently to be given. You see, interestingly, when we have statin 1 pill a day, when we have PCSK9 inhibitors which are given twice a month, so approximately 26 injections per year, and when you have inclisiran-like injection, you will give twice a year, and if you have vaccination, occasional, if you have gene editing, maybe once in a lifetime. So adherence increases as the frequency of the medication or medical therapy reduces. So effective and sustained LDL cholesterol lowering with 2 maintenance doses a year, which is very promising, and the initial dose is given, then 3 months later, second dose is given, and then every 6 months, the doses are given. This is how it is administered. It is approved. It was approved by EMEA in December 2020. In UAE, it was approved in February 2021. Recently, FDA approved 3 months before. It is available here, and we have used. So we'll share some of the experience. Now, this patient is a very important patient, is an Emirati person, 66 years old male. He had presented to our previous hospital in June 2016 with acute myocardial infarction, and he had a totally occluded artery. I don't know whether I can play it. If not, then it's fine. So in addition, in between 2016 and 2020, he also developed paroxysmal AF, and he also had a mitral valve repair in 2018. Now, we can play it, but it was a completely occluded, we can play it, that's nice. So you can see a completely occluded ectatic artery, right coronary. And this was after the procedure. It was a long procedure with multiple dilatations, thrombus aspiration, large stents. So it was a difficult one. Now, after initial procedure, this patient, after discharge, he moved somewhere else. He did not present to us until 2020. And that was our first meeting after several years. And then when we saw his medications, the most astonishing part was he was without any anti-lipid. That was so surprising to us. And then we did his levels. So LDL was 253, so huge, extremely high. And he said mostly he was not advised properly about statins, number one. Number two, he was reluctant. He thought statins might harm him. When he tried once, in the beginning, at the time of first admission, he felt some pains, so he stopped. And finally, he was not on this. So we counseled him well. Then we gave him a dose of atorvastatin, which he did not tolerate so well, but at least his levels became better. And they were still not at the target, so we added ezetimibe. And even after addition of ezetimibe, it didn't change much. So finally, we talked to him in May 2021, last year, soon after inclisiran was launched here. And first dose of inclisiran was given to him on 9th June 2021. Before that, the level of LDL was 107, which became 48. At this time, he continued with atorvastatin and ezetimibe. Then he argued against and he stopped atorvastatin by himself. So even without atorvastatin, his level was 74. That was after 3 months, 4 months of the injection, first injection. After the second injection, we gave second injection at 3 months, and then we gave another injection. Third injection was given recently to him last week. So before the third injection, his level was 60. So you can see that in general, the levels are reasonably maintained. He has played around with atorvastatin a bit. So when he stopped completely, it was 74. When he restarted, it became 60. So he's doing reasonably well and mostly at the target. The second patient is interesting only for the illustration purpose, a 65 years old male. First visit was in May 2020, hypertension, Asian origin, mother family history, known to have very high lipids for many years, but he tried every damn statin, but he could not tolerate even the smallest dose. LDL was 279, which clearly you can see at a very high level. High calcium score, although treadmill test was negative, there was high calcium score with a significant plaque, calcific plaque in CT coronary. Again, we planned and gave him a small dose of Rosuva, which he could not tolerate. He stopped. We tried PCSK9. He said, I can't take an injection every 2 weeks, so again stopped. Finally, these were his levels, 279 and 281 and 263. Here, we counseled him so much that finally he agreed to take inclisiran first dose. The levels became much better after first dose, but then again he disappeared. So this is the problem of compliance and adherence. If you have, even with the lesser number of injections, he was not so willing. Finally, he has now agreed, and once again he restarted his program, and we gave him a second dose. So I will call it not the second dose, it will again be first dose because there is a big gap between first and second. So he will restart as a first dose, then 3 months, and then 6 months. So this is the patient. He was quite happy for his picture to be taken. When he was given the first dose in the beginning. So, ladies and gentlemen, this last case is an illustration that what we can do for our patients in difficult circumstances. So Mr. B is a 53 years old Indian male with acute myocardial infarction, 6 weeks, primary PCI done, resistant hypertension, known hyperlipidemia, maximum on a maximum LDL noted to be 205, also having diabetes mellitus. So current medications are atorvastatin 80 milligram with muscle pains. Current LDL is 92. So I leave this question for everybody. What should be the target? I would prefer the target to be 55, and I'm sure I cannot achieve it just by statins, which already he is complaining of and he is not able to take. So the next step could be inclisiran. So we'll counsel him. There are issues with the cost. There are issues with the insurance. So we'll work upon this, but such are the patients who should be considered for advanced therapies beyond statins. Thank you for your kind attention. The current cost is approx 12,000 dirhams per injection. So the cost is same as PCSK9 inhibitors. If you see, because you need 26 injection of PCSK9 versus you need 2 injections of inclisiran, except first year. First year you will need 3, then you will need 2 injections per year. So final cost will be roughly the same.
Thank you, Dr. Brajesh Mittal, and we can take some...
only 5 minutes maximum. We can discuss
5 minutes.
Some key comments or...
Okay. I would like to, ask, because I have been also using inclisiran, and what I have seen in some of the patients, like one of your patients, when you stop the statin and the ezetrol, you do not achieve only with inclisiran the desired level. I don't know what your experience, but I have seen this and I've brought it to the attention of Novartis, the levels which we see in the trials, that it has dropped by 70%, 60%. Yes. You actually, if the patients, because the patients think that we take this injection, we don't need to take the statin sometimes, or the ezetrol, but or if they can't tolerate the statin and azitrol,
Yes.
and you give only the injection, the desired levels are not being achieved.
Absolutely. So I must
Your
clarify
comments.
once again that I showed the Orion program 9, 10, 11. 90% patients were on statins. So all the trials say that give maximal, optimal possible statins.
Yes.
If you, like in our patient also, when he stopped statin, his level went up,
Yeah.
right? But this applies also to PCSK9 inhibitor. This
No,
applies
I
to
agree.
everything.
Yeah.
So we have to consult the patient. We have to give ezetimibe. We have to give statin as much as patient can tolerate, and then it is his luck. If he can't tolerate even a smallest dose of statin, then he has to put up whatever it is. Yes, doctor.
Yeah, in the face of quite a lot of rejections for treatments that are well proven by the insurers, how do you get this stuff through the insurance companies? What do you say to them?
Well, we write the necessity according to guidelines, like in our first patient, that he had a huge risk of a secondary event, and he was unable to tolerate even the smallest dose of, he was on optimal dose, he was not well controlled by LDL, and the target was 55. We played it and we succeeded, so we got it.
No, I think so far I have not had any problem getting approval for inclisiran or the PCSK9.
Presumably you go through statins.
Yes, yes. Yeah, you give the whole history because they'll ask you for the whole history details. Yeah, yeah. Dr. Mishra?
Yeah, I totally agree with you. I had about 4 or 5 patients on inclisiran. One of them has a statin-induced myopathy. So I just cannot use a statin in that case. And inclisiran is not giving that desired effect which I am getting in other patients who are on a statin. Totally agree.
Yeah.
Any other questions to the other
So I think
speakers?
we will have 5 minutes, one message from our patron, which I'll play here for a few minutes. After that, we'll break for lunch, and we'll assemble back at maximum at 2:15, 2:10, approx 2:10. So can you please run this? Please be here with us for 5 minutes. Good evening, dear friends, colleagues, esteemed faculty members. This is my immense pleasure to welcome you all in the 6th edition of Annual Conference on Saving Deaths and Damages from Heart Attacks. We started this movement in 2015, in the month of April, first week, when we held our first meeting and first launch of the concept of saving deaths and damages from heart attacks by the name scale. And we had our first annual meeting in November 2015. And then we realized that it has to be more generic. Scale was very specific. So in the end of 2019, we launched with a different name, shape, Saving Heart Attacks Key Efforts. And the idea was to expand it not beyond the medical realm, to take it forward to the public, and we did some events for the public education. How are we contributing? We are doing this mostly by education. Education is the key. And we are in a good state as compared to many other illnesses like cancers, where we don't have much control, we can't prevent much, we can't treat much. Here we are in a situation, we are dealing with an elephant which is uprooting, but still it can be tapped, it can be controlled, it can be put in a straight line. So cardiovascular diseases give us an advantage that a lot can be done. A lot of lives can be saved. I usually tell my patients when they deny the medications, when they resist the medication for cholesterol control, for blood pressure control, I tell them one thing. Everybody applauds me when I treat a patient with acute MI successfully, and I'm a hero. I think I should be a bigger hero when I prevent it, and then he understands. So the problem is prevention is not as easily quantifiable as saving the life of a person who has already suffered. But who should be given more marks? The one who prevents or the one who treats? So I believe there is a lot of scope in prevention. Based on this concept and idea, this is my humble effort, more or less in a very solo way, to apply these principles to derive some pleasure and give some benefit to our patients and also to our society. So this is the 6th annual conference. Besides, we have had multiple smaller meetings at times, including a few for the general public. This is being done on a hybrid platform. Today it is only virtual. Tomorrow it will be hybrid, which is for me also been a challenging task to take it forward. But the important part is that I've been so blessed to have a stream of wonderful colleagues, very highly acclaimed people, established cardiologists and physicians in the world who have joined hands in delivering their thoughts and their ideas and putting the key message across. So I welcome you all to join and participate, to learn and give your comments, to encourage us. Your participation will encourage us in a bigger way, in a better way, year after year. We do not have any means to exactly quantify and tell you that how much did we achieve, but I am sure the knowledge or colleagues it carries forwards. It is also like infection, a positive infection from person to person. So let us all work towards it. We have an exciting program. We have faculty from 7 different countries. We have senior people, we have researchers, we have pioneers. We have almost 40 faculty members, 7 sessions. Some are the focused talks on neurotherapies and neuromedications. You can go through the agenda, it is available. And we have at least 25 talks. Some are smaller, some are bigger, but divided in a very crafted, in a very different way. So I need your blessings to carry forward this effort. I welcome you, and I would be happy to hear feedback and comments, both positive as well as negative. What else can we do? What else can we take through this program? At the end of the conference, please fill in the feedback form, and once you fill the feedback form, you will receive a certificate. The certificate of CME will take time because the DHA accreditation is under process. It doesn't come soon. It may take a couple of weeks, but we promise you, our team at the back end is working hard to achieve it successfully and to complete all the desirable protocols which should be done. With this thought, I acknowledge our patron, Dr. Azhar Mubin, a physician, an entrepreneur, and also a philanthropist. He was very, very kind enough to accept the patronage of Sheikh in the end of 2019 when it was founded, and his blessings are with us. Though it is an inaugural speech, but I will take this opportunity at the same time to thank you all those who have supported immensely in carrying out this program. Our backend team has been working hard for last 1 month, day in and day night. The last 2-3 nights I remember that for some reason or other, if I woke up, I found that there was some other message going on in our group of people who are working for this conference. So I take this opportunity to thank them, and as well as I thank all the sponsors who have made it possible. They have contributed for the benefit of the society, for the benefit of the quality of physicians, to take this educational program forward. So thank you everybody, welcome once again. And now I invite our patron, Dr. Azhar Mubin, to deliver his inaugural speech. Thank you.
Welcome everyone to this fantastic program, the Shake Initiative. This is a moment which is actually a crusade by a single doctor in various areas of healthcare especially those pertaining to the area of heart. Dr. Brajesh Mittal, who is my colleague, has been doing this crusade over the last 5 years, and he has done it very successfully. Single-handedly, I should say, and he has helped in increasing the awareness as well as serving large number of patients and saving lives by educating all of us about the various aspects. Now, this year he has focused on saving lives and preventing deaths by educating people about acute heart attacks, acute MI, as we call it, myocardial infarction. And this is, as you know, one of the most important causes of death in the present day. There are various aspects to it. How can you save somebody who has an heart attack? The first thing is to have that awareness in the patient himself, that this is something which is serious. Many people just think that this is gas or some other pain, muscle pain and all, just dismiss it when there is a pain. And people, especially people with diabetes and all, they don't even have a pain, and they have to know what are the symptoms that they should be looking at. So that's one of the important things, the awareness. Then from the people who are actually around the patient who gets this, they also should be taught about the way in which this patient has to be transported to the hospital, preferably in an ambulance, as well as in case, God forbid, something happens like an arrest and all, what is to be done. Then even the doctors, what is the best way to treat patients who are having a heart attack, how it has to be tackled. There are various ways it has to be tackled. I'm not going into the details. This will be discussed in this 2 days program. I just want to congratulate Dr. Mittal, who has been doing this very religiously every year, and he has taken such troubles to take it to this level. He requires an applause as well as he should requires our support, and may God bless him for whatever he is doing for mankind. This is a very, very important area. We are losing significant number of people to this malady of heart attack. Not only old people, but very young people. We have a lot of examples of youngsters, including professionals, just succumbing to heart attack. So let us support him. Let us hear from him as well as the other very eminent people who are speaking in this today program. I once again wish him all the best, and may God bless him. Thank you.
Thank you so much for your patience. Time for lunch. We'll try to reassemble at 2, maybe a few minutes past, but we'll try to maintain time as much as possible. So thank you, the moderators, Dr. Pandey, Dr. Rajesh, for carrying out this session well. Sorry we could not have more time for discussion, but still we did learn a lot. Thank you. Thank you, everybody. The lunch is being served at the 5th floor restaurant. So please come back at 2 if possible. Thank you. Good afternoon, welcome back. It's a difficult time after lunch and after a break, big break. But nevertheless, it's also going to be very important topic, a focused update on a very, very new medication, which the practicing cardiologists and physicians who are dealing with the heart failure patients would love to hear. We have the chairperson, Dr. Jafar. He is online available, and he will be interacting with us after the talk is completed. So the topic here is worsening heart failure. Do you see the worsening heart failure in practice, and how to act to improve the outcomes? So first part is heart failure, the burden and unmet needs. Heart failure has a significant impact on patients, healthcare physicians, and healthcare systems. More than 60 million people worldwide have heart failure. This is more than 4 times the number of cancer patients globally. It is associated with high rates of morbidity and mortality. 50% of patients with heart failure and reduced ejection fraction will die within 5 years of diagnosis. Again, it is worse than cancers, worse than many cancers. It poses a significant strain on healthcare systems. Heart failure is the number 1 reason for hospitalization in patients over age of 65 years. It is a progressive condition. Patient suffers once, then he suffers second time, and every time he or she further worsens. So it is a worsening condition. The graph keeps on going down for the morbidity and for mortality. So worsening, and finally death. It is worsening heart failure events are characterized by progressive signs and symptoms of heart failure for which medical treatment is warranted despite the use of guideline-directed medical therapies. Experience of a prior worsening heart failure event, need for IV diuretics regardless of setting, heart failure hospitalization, and need for an urgent hospital visit for heart failure. These are all the indicators of worsening heart failure. Patients with chronic heart failure may progressively deteriorate over time. As you can see, from the time of initial diagnosis and treatment, the stabilization at healthcare professional's office, clinic, or hospital, treatment and management, patient is fine, but then he will need additional follow-up, and a later alarm continues that despite all this loop of a favorable part, there is also worsening and worsening and worsening and death. So the cardiac function keeps on declining over time. Despite the use of heart failure medications, patients remain at risk of cardiovascular death and hospitalization for heart failure. At least 1 in 6 heart failure patients with reduced ejection fraction will develop worsening heart failure over next 18 months after the diagnosis. So the progressive decline is a very common phenomenon. And chronic worsening of heart failure accounts for almost 80% of hospitalization for heart failure. It is an area of unmet needs, the worsening chronic heart failure. As you see, the first hospitalization, second hospitalization, third hospitalization, fourth hospitalization. Each hospitalization continues to reduce the median survival of the patient. 56% of patients are re-hospitalized within 30 days of the worsening heart failure events, and the number of hospitalization for heart failure increases with time. So there is a need to reduce the recurrence of events and death, both. The current treatment and emerging therapies, this is for last 1 decade. There is a good improvement, good progress. Dr. Amrish also showed some part of heart failure management So in case of heart failure with reduced ejection fraction, there have been several important trials with some new medications, like from Paradigm Heart Failure Trial, sacubitril valsartan ARNI, which came out in 2014, then DAPA Heart Failure Trial, then Victoria Trial, about which we are going to talk about in details, then Emperor Reduced Trial with empagliflozin. This trial is not yet released, omecamtiv. This is a cardiac myosin activator. This trial will be coming in next 1 or 2 years. Then sotagliflozin, another SGLT2 inhibitors. So at least we can say that 1, 2, 3, 4 agents have proven their efficacy to some extent in preventing the progressive worsening of heart failure and hospitalization for heart failure. The various targets have been recognized. One of the most important targets is renin-angiotensin-aldosterone system axis, for which RAS inhibitors have been developed, ACE inhibitors, ARBs, and mineralocorticoid receptor agonists. Then we have ARNIs, which act through neprolizine system as well as through RAS system. Beta blockers reduce the sympathetic nervous system, and then SGLT2 inhibitors, empagliflozin, dapagliflozin, which are now approved. And then the other way of action is making more availability of cyclic GMP. So nitric oxide, soluble guanide cyclase, cyclic GMP pathway. So vericiguat is a new agent which works on this pathway. So how it works? We know the importance of nitric oxide and how nitric oxide works. Nitric oxide is present outside the cell and then it goes inside. Then it stimulates guanylate cyclase and then it creates more cyclic GMP. Here we have a medication which directly stimulates the soluble guanylate cyclase and converts it into cyclic GMP, makes more cyclic GMP available. So indirectly it also restores and upgrades the availability of nitric oxide, and then you don't have to depend upon the inherent nitric oxide alone. We have an agent which can directly increase the cyclic GMP. So how it works? The heart, progressive myocardial stiffening, myocardial thickening, reduction in ventricular remodeling, reduction in fibrosis, in vasculature, reduced arterial constriction, reduced vascular stiffness by cyclic GMP, and renal system, reduced sodium and fluid retention, increased renal blood flow. So the final aim is to increase cyclic GMP, which is done by this new medication vericiguat. So vericiguat was studied in Victoria trial. It was designed to study patients with symptomatic chronic heart failure who had a previous worsening heart failure event. So there were two kinds of patients: those who were having symptomatic chronic heart failure with NYHA class 2 to 4, ejection fraction less than 45, on available heart failure therapies. The second group was those who showed a recent worsening by one of the criteria. Either they have hospitalization for heart failure, or recent use of IV diuretics, or very highly elevated natriuretic peptides. So the eligibility criteria was ejection fraction less than 45, 2 to 4 NYHA class, very high BNP or very high NT-proBNP. eGFR had to be more than 15. The heart failure hospitalization within 6 months, or need for IV diuretic treatment within 3 months. So the patients were given for 2 weeks 2.5 milligram once a day vericiguat, then 5 milligram once a day for another 2 weeks, and subsequently 10 milligram. The primary endpoint, and this was a trial with a good number of patients, 5,050. The primary endpoint was time to first occurrence of the composite of either death or heart failure hospitalization. After approximately 12 months, 10 mg target dose was achieved in 89% patients. So there was good achievement of the target dose of 10 milligram in a large number of patients. So that proves the validity of the finding of the trial. So baseline characteristics between the drug and the placebo quite similarly matched. 84% of patients randomized had an index heart failure hospitalization within 6 months. So these were quite sick patients. at least 40% patients were NYHA class 3 or 4, which was quite a good number. Then at least 10% patients were less than 30 ejection fraction, and a large number of patients were also between 30 and 60. So less than 60% was almost 53% patients. So again, proving that they were quite sick patients. Then most of the patients were on triple therapy. Most of the patients were on triple therapy with a very high median NT-proBNP, 4,805, very sick group of patients, and 60% being on triple therapy, a reasonable number also on an average basis on ICD or biventricular pacemaker. So, as we said, there was a good number of patients, almost 85% of patients were less than 40% of ejection fraction. Then the patients who were on beta blockers were 94%, good number of patients on either ACE or ARB. In general, 3 standard of care medications were given in at least 60% of patients. So Victoria trial demonstrated a significant reduction in the annualized absolute rate of time of hospitalization for heart failure or cardiovascular death by 4.2 events per 100 patient years. So if we know the end point of the trial, then only we can judge the importance of the trial. So you see the curve separating the medication versus the placebo. Median treatment duration for primary endpoint 10.8 months. Annual event rates for vericiguat and placebo per 100 patient years were 33.6 versus 37.8, which en face looks not much, but actually it was significant. And absolute risk reduction of 4.2 per 100 patient years. Annual number needed to treat is 24, which is on a positive side, favorable side. If you treat 24 patients of this category of very high sick patients, you will prevent at least 1 death or hospitalization for heart failure. There were secondary outcomes listed as below. The cardiovascular deaths were not significant. All-cause mortality was not significant. The main important point was total hospitalization for heart failure, first hospitalization for heart failure, and combined mortality and hospitalization for heart failure. These were nearly significant. So total heart failure hospitalization and the composite of heart failure hospitalization or all-cause mortality were significantly reduced with vericiguat versus placebo. The difference in time to all-cause mortality between vericiguat and placebo was not statistically significant. In most subgroups, the medication proved to be better. There are some exceptions here, more than 75 years of age, and patients with EGFR less than 30. So bearing these some subgroups, most of the subgroups showed a very well and overall a much better favorable result in vericiguat group versus the placebo group. Also, the quintile of NT-proBNP, which were having BNP more than 5,000, was very sick group of patients, and again they did not do fairly well as compared to all other groups. Then patients who are having higher ejection fraction, so in other words, patients who were having lesser than 40% ejection fraction did fairly well. You didn't get expected outcome obviously because they were not as sick as the patient with less than 40%. So sicker the patient, the more beneficial is the medication. It demonstrated similar rates of adverse event and serious adverse events, as this group was of a very high serious nature. So anyway, the event rates were much higher, the adverse events was much higher, but they were equal in vericiguat and placebo group. So there were small differences in the rates of symptomatic hypotension and syncope observed with the medication group compared with placebo, but it was not shown to be statistically significant. There were similar incidence rates of organ class serious adverse events between the vericiguat and placebo arms. where small between group imbalances were seen in renal, GI, blood disorders, and hypotensive adverse events. More anemia developed in Vericiguat than with placebo, for which the authors concluded that they did not have a clear explanation. And then there was newer data from the same trial, and this was important, that over half of patients in Victoria had an eGFR of less than 60 ml. There were 5,000 patients tested, so 47% patients were having eGFR more than 60, and 43% more than 30 to 60, and 10% less than 30, meaning thereby that 53% patients had GFR less than 60, and medication was safe in this subgroup of patients. So it proved benefit in patient across different eGFR categories, and also it did not impact the eGFR on a long-term basis. So eGFR change in the medication group was initial decline, but at the end of 48 months, it was same as the placebo group. Similarly, the creatinine initially rose in the medication group as compared to the placebo, but the curves met at 48 months. So over a long-term period, there was no difference in the renal adverse events. So this gave us a new pathophysiological target for a population with substantial medical need. So it created a new physiological target in heart failure. Vericiguat, a once daily cyclic guanylates, soluble guanylated cyclase stimulator, which targets an untapped pathway in heart failure to improve outcomes. It's a new patient population with a worsening heart failure, which generally has a very poor prognosis. It showed improvement in cardiac outcomes. Vericiguat significantly reduced the risk of heart failure hospitalization or cardiovascular death by 4.2 events per 100 patient years, and number needed to treat was 24 for 1 over 1 year. It was very well tolerated, and adverse event profile was comparable to placebo. More than 90% of patients could achieve the target dose in the Victoria trial group. 2021 ESC guidelines for heart failure included a mentioning of this medication already in the trial, in the guideline. So if you see the flow chart of heart failure with reduced ejection fraction guidelines, there is standard treatment with ACE inhibitor or ARNI, beta blocker, MRA, plus SGLT2 inhibitors as were shown in the previous talk before the lunch, plus loop diuretic for fluid retention, and as a part B of the treatment, it is a 2B indication at the moment already in the guidelines. The Vericiguat may be considered in patients in NYHA class 2 to 4 who have had worsening heart failure despite treatment with ACE or ARNI plus beta blockers plus MRA. It is also been mentioned in Canadian guidelines, although not yet approved in Canada, but it is mentioned as to be considered in recent hospitalization for heart failure. The starting dose is 2.5 milligram once a day, and keep monitoring the patient, and to be taken up to 10 milligram per day. So this medication has been listed in the medication list of heart failure with reduced ejection fraction treatment by the ESC guidelines. And then we also have seen the ACC expert consensus document for the treatment of patients with symptomatic chronic heart failure with reduced ejection fraction. So in this guideline also, we know the standard treatment is standard of care with ACE ARB plus beta blocker, diuretics as needed, add MRA, add SGLT2 inhibitor, add ivabradine, and then they have not yet made a proper specific recommendation for Vericiguat, although they have mentioned that guanylate cyclase stimulation is mentioned as a pathway shown to improve outcome for patients with heart failure with reduced ejection fraction. So the drug is already getting its due, getting into the guidelines gradually, though obviously it is not the medication of first line use. Vericiguat efficacy in heart failure with reduced ejection fraction is mentioned, but not yet specifically recommended by ACC expert committee. So this was a review of SHAKEHEART. These are the references on which one can work upon. The most important data which came was from Victoria trial. So now we are open for some discussion. I think the chairperson is online, so we can interact with him, and if you can put him also here on the monitor.
Yeah, hi. Can you hear me? Hello?
Yes, hi, we can hear you.
Yeah.
Dr. Zafar.
I'm just getting a little bit of feedback. Thank you very much for that. Thank you very much for that. Really
Can you speak a bit louder?
Going through how this new medicine works, and particularly the Victoria. I really enjoyed that.
Dr. Zafar, can you speak a bit louder? We are not able to hear you well.
Yeah, no, I'm just getting a lot of feedback. I wanted to thank you for giving talk on the Victoria trial and how it fits in. So I would encourage the audience to try and participate with some questions. But just in the meantime, pointed out there are a number of medicines that we have to treat heart failure. So where would you place this very and this is always a little bit cautious about new medicine.
So as I understand, though the audio is not very clear, that where can we place this medication at this point of time? I believe we should follow the inclusion criteria of Victoria group patients who were very sick, who were chronic heart failure patients, had recent hospitalization within last 6 months, or required IV diuretic therapy in last 3 months. So such are the patients who should be included with very high NT-proBNP with GFR at least above 15. So we would tend, and then they must be already on proper standard of care, standard therapy for heart failure. And still if the patient is falling into that category, this medication holds some evidence at the moment and also in the guideline of ESC. So we look forward, and we have to have our own experience now once it is available.
Yeah, and I think that's an important point. As you pointed out in the Victoria study, around two-thirds of the patients that are triple care therapy of MRA. And if you look at the ones who are taking about 90% of patients, and yet these patients still come to hospital with heart failure. And it's nice to be able to have another tool in our armamentarium to try and stop these patients from coming to heart failure. Because again, you showed quite elegantly that the more frequent they come into hospital, their outlook gets worse each time they come into hospital. Each time they come in, it's just a stepwise degradation. I suppose the other question really is that because this really increases the sensitivity of the granulate cyclase to nitric oxide, and the old treatment we had, particularly in the Afro-Caribbeans and patients who couldn't take the ACE inhibitor, was the hydralazine and nitrates. Are patients who take nitrates, is that a concern with this medicine? I mean, should we stop the nitrates for fear of having exaggerated hypotension, like the PDE5 inhibitors? So I hope you guys can hear me, but I can't hear you. So the other question that really comes to mind is that when we start this medicine, I know you showed that there were the side effect profile and the number of patients who had to stop taking the medicine for hypertension was very similar between the placebo group and the active arm group. But is there anything that we should be looking out for? We know that with the atrial fibrillation, people had both blood pressure and renal function, and we know with some of the SGLT2 inhibitors, depending on additional oral hypoglycemic may warn the patient about getting a hypertension. With this medicine, is there anything in particular we need to be concerned of or warn the patient that they may suffer from?
Well, what we have reviewed here is the only one trial, and as of now we have only one available trial data with their inclusion and exclusion group and mentioned side effects and comparisons. So it is not very sufficient for us to say that what exactly will happen in the real life unless we start using it and start seeing the side effects, because trial patients are slightly different, and when we do in the real life, it's slightly different story. So we have to have our own experience. I assume that drug will be made available very soon, in next 1 or 2 months, if I think correctly. So once we have, and then we have our own experience, then we can shed more light into it.
And what you say? I'm going to check see if we have any comments. Are there any groups of patients that you would not give this?
Any group in which we could not use?
Yeah, that you
is
would
this
not.
the question?
Yeah. Are there any groups
Obviously, the group with the ejection with the renal function less than 15, that was completely clearly excluded, and systolic blood pressure, baseline blood pressure less than 100, do not use. This is what we know at the moment. So other groups which benefited less was the one with very, very high NT-proBNP to start with, more than 4,000, and the group with ejection fraction more than 45% was not a good candidate because there was not much benefit of the medication per se. So those are the areas. I may think that if any of the audience want to have any comment or any discussion to carry forward, we have Dr. Virender Mishra, we have Dr. Amrish, cardiologist, and anybody in the background virtually if wants to interact. Is there anybody, Dr. Amrish, Dr. Mishra, any comments?
I think the only other thing I would say really is just highlighting these were really a sick group of patients. And again, if we compare the Victoria study with the paradigm heart failure and the DAPA heart failure, their inclusion criteria was a much lower NT-proBNP. And if you look at the mean NT-proBNP in Victoria compared to the study, the Victoria study, the NT-proBNP was almost double that of the mean of paradigm heart failure and DAPA heart failure. So, these are really quite symptomatic patients, and yet they still derive benefit.
That's true.
Yeah, I would like to add this, definitely this medicine has shown the readmission rate is reduced a lot. The patient's compliance is very good because it's a simple oral tablet medication compared to most of the other medication which we could infusion form or injectable form. So this has come up in something which is showing definite improvement in the patient's compliance, definite improvement in reduction in readmission rate. And probably then time will tell with the real world data how much it stands for.
Yes, thank you very much for Dr. Mittal for the excellent talk. And obviously for the heart failure, the biggest issues are cardiovascular death. And the second issue is the biggest is the heart failure hospitalization. And this point will be stressed by all the speakers over the last few talks and for myself and Dr. Mittal also. I will again like to say that ejection fraction is something which is a variable thing. The same patient, if you do the study twice or thrice, you'll find different EF. Second point is that the duration of the magnitude of the benefit by any drug is a function of the duration studied for the trial. So the current trials are not the historical trials where we study like in consensus and all the years for the data. For example, Victoria trial was far more shorter than the Emperor reduced and the Emperor preserved trials for the patient. So the magnitude of reduction will also be small. The magnitude reduction is on the lower side as compared to Emperor-reduced trial and the pressure trial. And there are a number of reasons for it, because each succeeding drug which comes in the practice is built on the previous database for the patient. That means these patients are on already on optimal therapy which is available with the time. So you can see when you compare the DAPA heart failure trial versus Emperor-reduced trial, the people with ARNI was 10% versus 20%. The same thing with the very good trial. So as the time will go on, we'll find more benefit, and there's a place for all the drugs in the pharmacology. This drug is advantageous because unlike ARNI, there is not much effect on the renal functions, not much effect on the hypertension. So I feel that this drug will be much more higher uptake than the RNA, which in spite of all the evidence, the uptake is not that high in the community, or even in our hospitals. We start the patients, and next admission, we find the patient hypertensive, and some of the patients come off board RNA.
Yeah. So, no, that's true. The total usage is in a very restricted group of patients at the moment. If there are other trials coming up with less sicker patient, does it help in that group also? That we will see later on. The pathway looks exciting because it's a new pathway to directly target the cyclic GMP to create more cyclic GMP to make it available. So let's look for the future. But right now, this is what we have. We have a medication in addition to other existing medications to reduce the hospitalization and to some extent reduce the mortality together if you combine them together. So that's an exciting molecule, a new innovation, and that is why we put this as a focused update in this meeting to discuss for the benefit of everybody who may not be aware about this new medication. So, Dr. Jafar, do you have any last comments or last line to say?
I would just echo the comment. Every new medicine we have is on top of the medicine that's been proven before. And hospitalization for heart failure should not be underestimated. It has a huge impact on morbidity and mortality. And any additional medicine that we have and we try and reduce the frequency of that is going to be beneficial both for patients and health economics as well. As you say, it's a very novel pathway, increasing the sensitivity of and also stimulating more cyclic GMP. So I look forward to the future with this drug.
Great. Thank you. So may we conclude this talk?
Yeah, so I think it's quite nice that heart failure has a worse prognosis than the vast majority of malignancies. 6% of patients will die within the space of 5 years. Any further readmission to hospital affects your long-term outcome. And this new medicine, very simple, has shown quite nicely that it will reduce, on top of add-on therapy, it will reduce the primary endpoint of cardiovascular death and hospitalization for heart failure. It seems to be fairly well tolerated compared to placebo. It's a fairly easy up titrate because every 4 weeks you go from 0 to your target dose. So I think very much enjoyed that. I look forward to when this becomes available.
Okay, so thank you so much, and thank you for coming over. Thank you. Bye. So we conclude this session now, and we proceed forward for the next session. Please be online if you wish to be, so you can. The next one is yes. Thank you. Thank you. So the next session starts in 5 minutes, and we are well on time. The next session is the most power-packed session of the whole conference. You will have some terrific speakers around the globe. Now, we have to have very good two-way audio communication, the technical team, because it was not very good communication. Yeah, it was not. So unless we have a good audio, two-way audio.
Yes, you talk with a mic.
Maybe.
It will be audible.
Yeah. So because now we have fortunately in the next session out of 5 speakers, 4 are recorded. So at least the presentation part will be good. It's only the interaction part when we may find difficulty. And these all speakers will be available on the backstage and will be interacting at the time of interaction. So we need to have a good audio. So for this session, which will take another 3 minutes to start, but in the meantime, you can play some introductory video by the time we plan the things. So our chairpersons and moderators are Dr. Fayaz Shaul from USA and Dr. Kshetrapal from USA, Dr. Jairam from Abu Dhabi. I think he will be also joining virtually. So I also request Dr. Lochan to please also chair and moderate besides being the speaker in this session. So we will not leave you, sir. You did not come in the morning session, so we'll trouble you now. So please come over and yes. So we'll be starting in 3 minutes. I don't want to go early. Earlier, the exact time is 2:45 because they will be available at 2:45. So Dr. Amrish, you can also actually join on the podium as moderator. It will be good. We can have some good discussion. Although the time, I do not know whether time will permit us for a long discussion, but sir, please come over here. So it's already, we are set already. If we are at 2:43, we will start at 2:45. So, and Dr. Amrish will also join and good evening. Welcome to the last session of this conference, session number 7. I have specifically given it a title, Cardiology Master's Voice. This session is very power-packed and with some prolific speakers. One among us is Dr. Lochan, very, very senior people here in this particular session. Good evening, Dr. Jairam, Dr. Fayaz Shaul. Good evening, Dr. Tan, Dr. Kshetrapal. Good evening. Welcome to this conference. I hope you are very well able to hear us well.
Yes, sir.
Dr. Shaul. Good morning for you. Good evening for us. Thank you. Dr. Kshetrapal.
Hi. Good morning.
Hi. Good morning. And Dr. Tan. Night for you. Good. So late good evening. Wonderful. So we have additional moderators here, just for good sake of discussion, Dr. Lochan and Dr. Amrish Agrawal. You will also see them soon. So without much delay now, we start with the session, and I would suggest Dr. Fayaz Shaul starts introducing the first speaker and introduce the topic also.
Thank you, Dr. Mittal. Very early good morning from Washington. It's a proud and privilege to be here. And I am honored to introduce to you Dr. Professor Chim, who is from Singapore. He'll be talking about primary PCI from care delivery to value-driven outcome. Dr. Chim.
So the presentation is recorded and will be played.
Thank you very much for the opportunity to participate in the SHAKEHEART 2022 program. I'm speaking on primary PCI from care delivery to value-driven outcomes. My name is San Hui Chim, and I come from the National University Heart Center in Singapore. When we look at the literatures and the primary PCI service care delivery, there have been a number of important observations. Firstly, I think there is a common recognition of the benchmark of excellence. Everybody agrees that the 30-day mortality rate, door-to-balloon times are important as a quality indicators for primary PCI delivery. And we also know that in different countries, there are also different stages of development of a STEMI care system. But everybody is constantly trying to develop a STEMI network and registry within their respective countries in order to improve the quality of care delivered to patients with ST elevations myocardial function. And what are the lessons that we can learn from some of the successful primary PCI programs in the world? Firstly, there are important elements with regard to medical leadership. And secondly, there's a key consistent theme to talk about the reduction of door-to-balloon time in care delivery. And thirdly, we want to create a conducive environment to implement changes that can lead on to a successful program. In terms of clinical medical leadership, I think that is obviously the key. What we need here are one or more clinical leaders who are extremely committed, tenacious, and uncompromising in delivering primary PCI care. There are pushers and drivers needed in every institutions that have been successful, and typically this will comprise people who are highly respected clinicians who are very persuasive with their peers and can motivate and inspire them to go along with the mission of providing the best care for patients with STEMI. And we also need the leaders to be willing to examine himself seriously, to monitor performance honestly, and talk with individuals and teams about ways to improve performance should there be any deficiency or shortcomings. The thing about another lesson to learn about successful primary PCI is the reduction of door-to-balloon time. And we know that this requires actually a very concerted effort, not just within the hospital, but also without the hospital. At the national level, what we need here is oftentimes a regional system design to form a STEMI network. We also need to have an effective and efficient inter-hospital transfer system. And within the hospital itself, we need a good collaborations and link up between the emergency healthcare services, emergency department, as well as the cath lab department. And indeed, there have been a number of publications to share the tips and tricks towards developing and improving a door-to-balloon time in patients and institutions providing primary PCI. And this includes the explicit goal to all the members of the department on the need for reducing door-to-balloon time. There's visible senior management support, innovative and standardized protocol, flexibility in implementing standardized protocol, uncompromising individual clinical leaders, collaborative interdisciplinary teams, data feedback to monitor progress and identify problems or successes, and an organizational culture that fosters persistence despite challenges and setbacks. And when I look at our own institutions, we realize that teamwork is really key. You need to have an inter-department and interdisciplinary collaborations involving the key physicians, preferably the head of the department, in order to drive the program. Only a teamwork approach can make it happen, as I realized from my own personal experience. And there has to be a mutual respect among the disciplines. You can't have a ER and a cardiology service fighting over care delivery issues. And we also need to engage the local and national healthcare leadership at all times in order that this program can be rolled out at a national level. In terms of education, this is fundamental. We will need to spread the message of the need for reducing door-to-balloon time to all the members of the group, from the junior college to the nurses and allied health. And it's really critical to be motivating them and sustaining whatever improvement effort that has been introduced every now and then. This is a publications from my centers on how our experience in terms of door-to-balloon time reduction has brought about a very highly effective results of reducing door-to-balloon time. Indeed, when you can look at our median door-to-balloon time from 2009 of 57, it drops quickly to about 47 in 2016, and we kind of reach a plateau thereafter. Just last year, our median door-to-balloon time is 42 minutes. I don't think we can go any further lower than that. But we also know that as you introduce measures to reduce door-to-balloon time, there is a clear learning effect in the beginning. And as people becomes more aware and becomes more familiar with it, you find that now the continuous quality improvement analysis continue to operate and refine and expedite the delivery of care. So actually the process becomes more efficient and more effective as time goes on. What are the tenets of STEMI care? Again, as I realized in looking at the literature, there are three aspects of it. We have to talk about emergency medical access, particularly with regard to a pre-hospital care of a patient with STEMI. Then we have to talk about evidence-based reperfusion strategy. And finally, not forgetting that cardiac rehabilitation actually play a very important role in the secondary preventions of patients with STEMI. When you look at the emergency medical service, and there has been a consistent messaging throughout the world, coming from the ACC/AHA 2013 guidelines for management of STEMI, it's quite clear that it's a class 1 recommendations that all communities should create and maintain a regional system of STEMI care that includes assessment and continuous quality improvement of EMS, emergency medical service, and hospital-based activities. And the first medical contact to device time system should be driven to 19 minutes or less. When we look at the European Society of Cardiology meeting 2017, it is also the same messaging, class 1 recommendations for the pre-hospital management of STEMI patients based on a regional network designed to deliver reperfusion therapy expeditiously and effectively, with efforts made to make a primary PCI available to as many patients as possible. And it's important that primary PCI capable centers deliver a 24/7 and are able to perform primary PCI without delay. So many studies have clearly shown that if you do a pre-hospital electrocardiogram in the patients with suspected AMI, you consistently bring about a reduction in the door-to-balloon time, and as in this two study. And this is quite intuitive because the system would have been activated even before the patients arrive when you start performing pre-hospital ECG and diagnosing STEMI in the field for those patients. Looking at the Singapore experience and looking at our current public healthcare system, we currently have 3 clusters here. And where I work in the National University Heart Center, we belong to the Western cluster, which is the portion marked green here, and it's called the National University Health System cluster. Within this cluster, we have a very effective emergency medical service, or actually this is an emergency medical service that's common throughout the country. And we have a rescue bike that can go to a site of patients reporting site in the quickest fashion. We call it the Red Rhino. We are able to dispatch teams of 8 in situations where there is cardiac arrest. And the ambulance is very well equipped with on-site ECG machine, able to do CPR, intraosseous adrenaline injections, and so forth. So what we developed within the western part of Singapore is this Western STEMI network, where all patients who are diagnosed to have possible STEMI outside the hospital will bypass all the other hospitals within the region and just go straight to my center here, where we concentrate the resources in terms of expertise, infrastructure, as well as surgical backup facilities to treat the patients with AMI, giving them the best chance for survival. So oftentimes, ECG would have been done in an ambulance and then sent to a HQ, which then sent to the hospital emergency department laptop. Now, at the National University Heart Center, we do about 600 cases of primary PCI a year, and this has been sort of on the steady climb over the last 2 decades or so. And we are pretty serious about tracking the quality and the outcomes of our patients within this Western STEMI network. We look at the individual campus performances, tracking the individual institutions' door-to-balloon time, and so forth. And right now, our door-to-balloon time across the entire region is less than 90 minutes, is happening in about 97.7% of our STEMI population. We also have now evolved to become a cardiogenic shock center within the western part of Singapore, and this provides all the mechanical circulatory support in the form of impeller and ECMO for patients who require such service. The second tenet of STEMI care, in my opinion, is to render evidence-based reperfusion therapy. And this, we have the advantage of going and adhering to the current guidelines from the ESC in 2017 as well as in 2018. Certainly, primary PCI of the infarct-related artery is a class 1 recommendation, and now there are also class 2A recommendations with regard to the treatment of a non-infarct-related artery lesions in patients with multivessel disease presenting with STEMI. As we deliver the patients expeditiously to the hospital system and perform the primary PCI, the next part is, of course, to ensure that they continue to remain well even after treatment and discharge. And in my opinion, cardiac rehabilitations is the key here. And we do have 4 phases of our cardiac rehabilitations in accordance with international recommendations. That begins with the patients undergoing simple rehabilitations process in the phase 1 rehabilitations inside the hospital, then go on to a phase 2, much more comprehensive outpatient supervised program, and finally phase 3 and phase 4 community-based cardiac rehabilitation program. This is our cardiac rehab centers within the hospital, and this is a phase 2 cardiac rehabilitation where patients undergo exercise and various educational programs and patient empowerment with support from our rehabilitation specialists as well as allied health nurses and so forth. Moving forward, as we think about improving the primary PCI care, we have to move away from the paradigm of just quality outcomes to that of value-driven outcomes. One of the things that we always realize is that clinicians oftentimes just do the primary PCI and they really have no feedback on the clinical outcomes, what happened to the patients thereafter, and how much of the cost did they generate as they deliver the primary PCI service. So clinicians don't know the cost and they also don't know the outcomes. So we came out with this value-driven outcome program, VDO as we call it. The whole idea here is to understand how we can improve healthcare value at the level of the individual patient and at the institution level. What is the outcomes achieved per dollar spent? For every dollar that we spend on the patient's care, how much of a return in terms of value are we getting? So the whole objective of VDO really is to develop the capability to allocate the cost of care and the quality measures to individual patient encounter. We will provide the clinicians with the tool and information to understand cost value, identify variances as best practices, and most importantly, to drive cost and health outcomes optimization. So specifically, we will look at the specific conditions, for example, AMI here. Then we define the quality to measures for this AMI patients, and then we will do a value-driven analysis and finally come up with measures that can possibly and hopefully drive cost and health outcome optimization. So in acute myocardial infarctions or in a value-driven outcomes analysis, it's really about quality divided by cost. So for acute myocardial infarctions, we go by the 4 dimensions. Number 1, which is clinical quality and safety. Number 2 is the appropriateness of care. 3, patient-reported outcomes, which is not so relevant, and patient experience. And then we look at the cost involved in terms of providing this service and measuring this quality dimensions. So in terms of the dimensions of quality for clinical quality and safety, we look at the number of readmissions, the in-hospital mortality, and the number of patients who stayed in hospital for less than 5 days. In terms of appropriateness of care, we want to make sure that patients come in and have their primary PCI delivered within 90 minutes, and we want to make sure that they actually have all these evidence-based medical therapies before they were discharged. And we want to measure at the end of it all is how the patients feel about the entire service and the care, because their experience is obviously going to make a lot of more importance. And so just in not just doing the procedure and then be discharged thereafter. So in a value-driven outcomes AMI programs, we have measured in-hospital mortality, tracking every month based on the number of cases admitted, what is the in-hospital mortality, and going by the individual consultants that are involved in rendering a primary PCI care to the patient. So every consultant will know about the outcomes of their patients, the length of stay within the 5 days, the readmissions within the 30 days, and the PCI within 90 minutes of those patients whom they treated while they are on service. And at the end of it, also measure the primary patient experience satisfaction based on the EPA-ES score that we developed. Anything more than 8 is considered satisfactory experience. So by aggregating all these quality dimensions, we come up with this thing called a CQI, which is Clinical Quality Index. It's the perfect index in which patients would have fulfilled everything and our care has been perfect. And then measure it with the cost involved here. And what have we learned in this video analysis? We realized that we actually can help to improve outcomes by shortening the length of stay in patients and setting up protocol where we can actually discharge early patients who are at low risk for cardiac event. We also have learned how to reduce overall surgical device costs by using cheaper implants, and we minimize the variations in terms of practice between the doctors. The doctors learn from each other the best practices in order to deliver the best care here. So with all this understanding of the opportunities for improvement, we track the costs involved. And again, you can see that if we look at the clinical quality index, starting from earlier on in 2016, it was 58%, and this clinical quality index has slowly climbed up to 65%. The cost involved in rendering a primary PCI for every patient started at $25,000 in 2016, and it's now dropped to $17,000, chiefly from a reduction in terms of the length of stay, patients who exceed more than 5 days, reduction of a readmission, and improving the door-to-balloon times of less than 90 minutes percentage. So all this has told us and that video has certainly helped in terms of delivering a quality, high-value care to our patients. So in conclusion, Mr. Chairman, ladies and gentlemen, the current primary PCI requires a successful STEMI network, and this needs a system and process optimization, as well as, of course, the procedural competence of the operators providing it. Certainly, as we move on further and in our development of care for patients with STEMI, there is a changing paradigm that will entail new metric measurement and a move to value-driven outcomes in order to optimize health and medical cost expenses. Thank you very much for your attention and appreciate this opportunity.
Thank you very much, Dr. Lecture covering an important aspect of the delivery of STEMI care. I must congratulate your team achieving 42 minutes time, which is excellent, and we all have to do that in our practice. Thank you very much. This is open for discussion. Any questions? We'll have discussion in the end. Okay, we will continue with the other talks, and then we'll have a... Okay, and can I ask Dr. Jairam to introduce the next speaker, Dr. Roberts? Dr. Jairam, can you please go ahead?
Yes, sir. Am I audible, sir?
You're.
Okay. Thank you, Dr. Lochan, and thank you, Dr. Tan. That was wonderful. It indeed is a constant challenge to try and make a good selection between science and commerce when it comes to medical practice. And it is very, very important that we sort of look at both aspects of things, maintaining our clinical guidelines as well as trying to optimize costs. So thank you for that wonderful lecture. We move on to our next topic in this keynote address. So the topic is modifying outcomes in acute coronary syndromes to look at appropriate management strategies. And who better to give this rendition than Dr. Robert Guiliano. He's the senior investigator of the TIMI study group. He's a staff physician of the cardiovascular division at the Brigham and Women's Hospital in Boston and a professor of medicine at Harvard Medical School. We welcome him for this talk, and we hope to hear from him and take back plenty of take-home messages. Thank you.
Hello, my name is Robert Giuliano. I'm a cardiologist and senior investigator with the TIMI study group at the Brigham and Women's Hospital and professor of medicine at Harvard Medical School. And I want to thank the organizers of the SHAKEHEART2022 conference for inviting me to present today's topic on modifying outcomes in acute coronary syndromes, appropriate management strategies. By way of disclosures, you see I have relationships with several companies that have developed various therapies in acute coronary syndrome. This is part of my work in clinical trials, and I also participate in CME programs, lectures, and consulting with a variety of different companies. I want to share with you two important guideline updates related to this topic. So one is the 2017 ESC guidelines for management of patients with acute MI who present with ST segment elevation. That was published in 2018 was the publication, but it's the 2017 guidelines. And then in 2020, the same organization was, updated their guidelines for patients without persistent ST segment elevation, so the non-ST elevation ACS patients. A couple other publications that I'm going to pull from include a seminar on acute coronary syndromes that has just been accepted for publications in the Lancet that I participated in, and then two chapters, one in the textbook Heart Disease and the second in Harrison's Internal Medicine on acute coronary syndrome that I co-authored along with Dr. Braunwald here in Boston. And I want to start, since this is a global audience, with a recognition to this publication by Salim Youssef that drew attention to disparities across the globe. And when we look at patients from low, middle, and high-income countries, we see widely varying event rates of cardiovascular disease and also mortality, but opportunities for better care in all countries around the globe, but particularly those with lower income, where additional optimal therapies to manage cardiovascular disease could lead to large decreases in the incidence, but also the subsequent morbidity and mortality from cardiovascular disease. And one of the places where there's been a big change has been this shift in the underlying pathobiology for acute coronary syndromes. Now, we all know about plaque rupture. That's what we learned in medical school was the most common cause of an acute coronary syndrome. But over the last several decades, we've seen a shift in the pathobiology. More and more, we're seeing other causes for ACS, including plaque erosion, or a fixed coronary stenosis with a second non-cardiac etiology that is causing a so-called type 2 myocardial infarction, and then other cardiac etiologies of ACS, including microvascular spasm, coronary embolism, myocarditis, particularly in the COVID era. Takotsubo syndrome and coronary dissection are also other causes of acute coronary syndrome. And it behooves us to understand what the mechanism of the ACS was, because once we recognize the etiology, be it a type 2 MI or spasm or embolism, etc., we can then modify our treatment plans to address what the underlying cause is. So recognizing this evolving pathobiology of ACS is a good place to start in this discussion of what's new in managing patients with ACS. Now, the 2017 STEMI guidelines have published many changes from the prior versions, and I'm going to just take you through a few of the highlights. So important changes from the 2012 prior version include use of radial access, using modern third-generation drug-eluting stents, and completely revascularizing patients who are not in cardiogenic shock at the time of PCI. Several studies have shown that routine use of aspiration, so the total and the TASTE trial, was either did not improve or was in one case associated with some worse outcomes, particularly increased risk of stroke. So important changes in 2017, use radial access, modern generation drug-eluting stents, and in patients who are not in shock, a complete revascularization at some point, either at the same setting or in the upcoming days to weeks, would be indicated, and avoid routine aspiration. Other new changes in the 2017 STEMI guidelines include an aggressive treatment of lipids, lowering the LDL well below 1.8 millimoles per liter. And then we talked about a complete revascularization. The culprit shock trial, which was published just after the guidelines came out, showed worse outcomes in patients who were in shock who underwent complete revascularization. They tended to have more or higher risk of renal insufficiency and heart failure. But for patients who are not in shock, considering complete revascularization, either later during the hospitalization or in the upcoming weeks, is associated with better outcomes. With regard to lipid-lowering therapy, we now have a very potent class of parenteral agents, the PCSK9 inhibitors, and here are data from two of them, evolocumab and alirocumab, in the FOIA and Odyssey studies, respectively. The baseline LDL was in the high 90 milligrams per deciliter, as you can see in both trials. And if you look at this group of patients who had a recent acute coronary syndrome, or MI, within 12 months, lowering the LDL well below 50 was associated with a marked reduction in cardiovascular events, around 20% reduction, 15 to 20%, with early divergence of the curves after randomization. So PCSK9 inhibitors now established to reduce subsequent cardiovascular events in patients who had a recent MI. The 2017 ESC guidelines in STEMI have published a number of key slides here. They call them the do not forget slides, and I'm going to share with you the key findings. First, in the immediate therapy, so meaning within the first 90 minutes or so, the four early key steps include bypassing the emergency department, getting the patient to the catheterization lab for primary PCI as soon as possible, to use dual antiplatelet therapy with aspirin and a potent P2Y12 inhibitor, either prasugrel or ticagrelor. Remember to give loading doses of these antiplatelet agents. Using radial access, unfractionated heparin, and in patients who go on to have stenting, a modern drug-eluting stent. In the next day or two, some of the key recommendations from the guidelines include a statin. I put this in capital letters to remind us that it should be high-dose statins that are initiated early, along with beta blockers and ACE inhibitors, particularly in patients with low EF or history of heart failure, an echo to assess left ventricular function post-PCI, and in patients who have LVEF less than 40%, particularly with heart failure, to consider mineralocorticoid receptor antagonists, so spironolactone or eplerenone. And then lastly, in the STEMI patients, I want to share with you for patients who cannot or present to a hospital that does not have PCI and it's not possible to transfer them in a timely fashion, they can and should undergo fibrinolytic therapy. The key recommendations here are to administer a bolus lytic with enoxaparin as the preferred anticoagulant, and dual antiplatelet therapy with aspirin and clopidogrel loading these. And then once these therapies are started, a call should be made to a PCI center for early transfer, because many of these patients will need to undergo coronary angiography and PCI either in the upcoming hours or prior to discharge. Now I want to transition to the 2020 ESC guidelines for patients without persistent ST segment elevation, so the non-ST elevation ACS group. And here an important new recommendation is for measurement of the high sensitivity troponins early and serially. Now the favored algorithm is called the 0-1 hour rule out, where high sensitivity troponin is measured as the patient arrives and then an hour later. This can help sort out patients who can rule out and don't need to be admitted if the troponin values are low and don't change over time. Or on the other hand, patients have a high value or a large increase within the hour of rule in, and these patients should be admitted to a cardiology unit and undergo further testing. Now, there will be patients who fall in between these extremes, and they require further observation and testing, including possibly a 3-hour high sensitivity troponin or other imaging studies like an echocardiogram, stress tests, or coronary CTA. But remember, this 0-1 hour rule out, it can really help expedite the evaluation and accurately triage patients. One of the other key figures in the non-ST elevation ACS guideline is shown here for the early administration of antithrombotic therapies. This includes aspirin with a loading dose in patients who are not chronically on aspirin, unfractionated heparin, preferably, and then a potent P2Y12 inhibitor, prasugrel or ticagrelor. Remember to load these agents, 60 milligrams prasugrel or 180 milligrams ticagrelor as the first dose. Then we have the question of, okay, once we've got these therapies started, does the patient need to go for a coronary angiogram, and if so, when? And it's helpful here to assess the risk of the patient, because very high-risk patients, those with hemodynamic instability or shock, refractory chest pain, life-threatening arrhythmias, complications of MI, acute heart failure, etc., are very high risk and need to move to the cath lab very quickly, preferably within 2 hours. Those that are not so high risk, but still at elevated risk, dynamic ST changes, a high GRACE risk score, etc., should go to the cath lab perhaps within 24 hours of the recommendations. In low-risk patients, one can be more selective about use of angiography. And then depending on the institution, whether at a non-PCI center or at a PCI center, you can see the full algorithm here. Patients at a non-PCI center should be transferred to a PCI center if they're very high risk, immediate transfer, or high risk, same day transfer, to allow for coronary angiography, whereas the low risk patients can be selectively managed with an invasive strategy. And then, of course, the very high risk patients cath within 2 hours, whereas the not so high risk patients, or here they're called high risk, early invasive within 24 hours is the recommended approach. Second important consideration regarding revascularization is which patients should be managed with PCI versus CABG. And the general advice here is PCI should be performed in patients with single vessel disease or those that are so clinically unstable it wouldn't be safe to wait for bypass surgery. And bypass is most effective in diabetics with multivessel complex disease or multivessel disease with a low ejection fraction, less than 40%. And in patients in whom the decision is not urgent, then involving a heart care team can be helpful for each institution to make the best decisions for their patients about PCI versus CABG. And then as far as the long-term antithrombotic treatment post ACS, in general, the default should be dual antiplatelet therapy for 12 months, provided there's no bleeding. Other important recommendations include referring the patient to cardiac rehab. This is often overlooked, yet plays a critical role. Because through the cardiac rehab, working with the cardiologist and the GP, one can then address secondary risk factors, including controlling lipids, glucose, blood pressure, and ensuring a healthy lifestyle management. So smoking cessation, improving the diet and exercise plan, and achieving an ideal body weight. These are key recommendations in the post-discharge setting after ACS. I want to spend a moment on a complicated area, and that is the long-term selection of antithrombotic regimens. And I'm going to split it into two slides. One is a group without atrial fibrillation or without an indication for ongoing oral anticoagulation. And here's the key algorithm from the non-ST elevation ACS guidelines. And you can see it's rather complicated. Central to this algorithm is assessing the bleeding risk of the patient. Is the patient a low, high, or very high risk of bleeding, and also the ischemic risk of the patient. If we start at the far right, you see the patients with very high risk are treated with a brief course of dual antiplatelet therapy, perhaps a month of aspirin and clopidogrel, and then single antiplatelet therapy afterwards with clopidogrel. At the far left, you see the low bleeding risk patient, but high ischemic risk. These patients deserve more intensive and longer dual antiplatelet therapy, perhaps 12 months of aspirin with a potent P2Y12 inhibitor. And then after 12 months, either continuing dual antiplatelet therapy long-term or considering low-dose rivaroxaban with aspirin after that 1 year mark. So key to this algorithm is to look at assess the bleeding and ischemic risks, and then modify the plan for the intensity and duration of antithrombotic therapy according to the balance of bleeding and ischemia. Second group I want to discuss, and this might be is 15% or so of the patients you see with non-ST elevation ACS, are those patients who have an ongoing indication for oral anticoagulation, most commonly atrial fibrillation. Here again, it's helpful to consider the bleeding and ischemic risk profile. The default strategy would be a short course of triple therapy with an oral anticoagulant plus 2 antiplatelet agents. By short course, I mean a day up to 1 week. And then the default strategy would be a year of dual therapy with an anticoagulant plus a single antiplatelet, and after 1 year, just the oral anticoagulant alone. Notice that the NOACs, or the non-vitamin K oral anticoagulants, are preferred over warfarin in these situations. Whether that be the default or the high bleeding risk patient or the high ischemic risk patient. The difference between the middle column and the right-hand column, again, has to do with the intensity of triple and dual therapy. High ischemic risk patients, maybe a month of triple therapy before de-escalating to a single antiplatelet with an oral anticoagulant. Those with high risk of bleeding, keep the triple therapy very short, less than a week, then move to double therapy for 6 months, followed by oral anticoagulant alone. And certainly by 12 months, all 3 pathways lead to oral anticoagulant alone for the long term. I want to tackle 2 more topics, and these are the less common or atypical presentations of ACS. We'll start with MINOCA, MI with non-obstructive coronary arteries. It's more common in women, perhaps 4-fold more common. And it is a diagnostic and therapeutic challenge. There was an important study called the HARP-MINOCA study published in Circulation in 2021 that looked at women, 301 who were diagnosed with MI, 170 ended up having MINOCA. And many of these went on to have additional imaging studies, including optical coherence tomography, MRI scans, or both. And what you can see here is that the causes or mechanism of MI are quite variable. Sometimes there's a traditional plaque rupture with or without thrombus, but also you see patients could have had coronary artery dissection, myocarditis, Takotsubo's, non-ischemic cardiomyopathy, diverse causes here. And the message, I think, from the HARP-MINOCA study and what the guidelines are getting at is if you have a myocardial infarction, particularly think about this in women, and there's no culprit lesion, then further evaluation with additional imaging studies like OCT or MRI may be helpful to figure out what the underlying etiology was and then modify the treatment. Obviously, we'll treat a patient who has myocarditis very differently from someone who had a plaque, a rupture with a non-obstructive lesion. And so you can see that the information is actionable that we often get from these additional imaging studies in patients with MINOCA. Second diagnosis I want to discuss is spontaneous coronary artery dissection. Again, also more common in women, particularly younger women. And there are different types of SCAD, but what's really important, more so than the appearance of the lesion, whether it's multiple radiolucencies or long diffuse smooth stenosis or focal tubular stenosis, more important is the anatomy obstructive and is the coronary flow reduced? Because patients who have obstruction of the coronary due to SCAD and reduced coronary flow, these patients should be revascularized either with PCI or CABG. At the other extreme to the right, you have patients without obstruction and they have normal flow, then allow for spontaneous healing and treat your underlying risk factors. Now, there'll be some patients where it's less clear. They may have an obstructive lesion, but the flow appears normal. In this case, additional intracoronary imaging with IVUS or OCT could be helpful to delineate who has high-risk anatomy. So I want to summarize then by saying, making these 4 key points. There are 2 recent ESC guidelines in STEMI and non-ST elevation ACS recently published. Following these provides you the best evidence-based approach in our patients with ACS and could improve outcomes. Recognize that the pathobiology, the underlying etiology of ACS has shifted over time. Sometimes it's hard to recognize when the sand under our feet are shifting. But learning a little more and understanding better what the mechanism of ACS is could lead you to a better way to manage patients. Key new updates in the STEMI guidelines include making an early diagnosis and initiating treatments quickly, thinking about atypical presentations, initiate anticoagulants and antiplatelets, dual antiplatelets early, with an emphasis on early revascularization and reperfusion, either through PCI or if not available, lytic therapy. And then to remember post reperfusion that there are critical steps that should be initiated in the hospital to reduce the risk of a recurrent MI in secondary prevention. New updates in the non-ST elevation ACS guidelines include the early 0-1 hour high sensitivity troponin rule-out algorithm, assessing the risk of patients to select the optimal time for angiography, who needs to go immediately to the cath lab versus who could wait or could even be managed conservatively. Important recommendations about the timing, intensity, and duration of antithrombotic therapy, and particularly that tricky subgroup of patients who also need oral anticoagulants long-term. And keep in mind the atypical presentations, MINOCA and SCAD, because these patients need a little more thought, understanding of the etiology and the severity of obstruction and coronary flow to best guide therapy. Thank you very much for your attention today.
Thank you, Professor Gugliano. And I believe the first 2 speakers have justified the title of this this particular session, Cardiology Masters. So 2 masters have presented. Now 3 masters are on the way. So may I request Dr. Shaw to introduce and bring in Dr. Lochan. He will be, Dr. Lochan sir is with me and he will be delivering his talk from the podium. So Dr. Fayyaz Shaw will, they are known to each other for 3 decades, so I think that's the best way. Dr. Shaw will introduce Dr. Lochan.
Thank you, Dr. Mittal. It was a great talk by Dr. Gugliano. on this important topic of ACS, particularly how to improve outcome. It's my privilege to introduce to you the next speaker, Dr. Rajiv Lochan, who's a consultant interventional cardiologist at Alzheimer Hospital. I think Dr. Lochan needs no introduction. I have known him for decades. And the golden hands. And let's see what he has to say about unusual suspects during primary PCI. Rajiv.
Thank you, Fayaz. Thank you, Dr. Shaw. It has been an excellent introduction, and I think I remember the days you helped us about 3 decades before when I was working in Batra Hospital, and you set up with cardiopulmonary bypass, and we did a complex cases with you and at your Washington Adventist Center. So it has been a great experience working with you and learning from you. Thank you very much, and our team learned a lot from you. So we'll try to expand today on the primary PCI, as Brajesh Mittal has been instrumental in keeping this primary angioplasty in a academic format. We all are doing primary angioplasties in all the hospitals, but he has been instrumental in coordinating people from east and west and making a good part for this particular subject, which is very practical. Next slide, please. So primary PCI is the preferred mode of STEMI treatment and is superior to thrombolysis, we all know, and various guidelines, as mentioned in previous speaker, that this is the European, American, Australian, and England, and they all agree this is the treatment which you have to follow. And the time-sensitive treatment is important for STEMI, and survival improves as Dr. Shima told, that door to balloon time or first medical contact to wire time or device time is an important factor. Reduction in mortality have been proven with a shorter than 90 minutes recanalization time. However, the last guidelines from the European Society, they are recommending the time can be still reduced to 60 minutes to have a better results. So, in our hospital, we have set up a system of STEMI, and I must tell you, it is as the first speaker mentioned, it's a teamwork, right from ER, not even from ER, from the ambulance, and we have been able to form a group where the ER coordinates with the ambulance as soon as they get a call. We get a ECG from the ambulance, and then in Dubai, it's a good system. DCAS is sending the ECG to nearest hospital where there are ambulances located, and the same hospital, they can access to that ECG and start acting. And we do that at the same time. We have developed our own WhatsApp group, and as soon as the ECG come, it is circulated among the people, those who are involved with that work, and they immediately become ready to come as soon as, even if they are not officially called by my nursing supervisor, which has reduced the time. And in fact, I have been pleased to inform that our center has done the shortest possible time was 19 minutes. And this is not believable, worth believing, but it was in the night, 9 o'clock it was done. And luckily Dr. Barad is here, and who was the one who did this procedure. Congratulations, Dr. Barad. So this was a very good achievement, and we have been able to improve this time by reducing the interaction or reducing or almost bypassing the ER. Oh, sorry. So this is our primary PCI figures. What we have done in last 1 year is about 124 over the year. And what we try to define between the day and night procedures, but they are nearly equal, because most of the daytime literature say that nighttime or early morning hours are higher. But this has been, I think, nearly same for us, and we have lowest number to 6 to maximum number of 9 in a month. So I think we are doing reasonably well as we are able to get the more and more patient support from the patients directly coming to the ER, or the DCAS helping us or helping all the hospitals in UAE. History of the prolonged chest pain with the sweating, dyspnea, dizziness. This is the usual presentation. And ECG marked ST elevation in anterior or inferior leads. Cardiac markers are usually we don't wait for them, but at point of care sometimes give the information, which is half of the time is positive, half of the time it is not. Single coronary artery is the abrupt block, is the usual finding what you expect in a thrombotic occlusion in acute MI. And most of the time it is suitable for direct stenting, and as we prefer direct stenting without pre-dilatation to avoid thrombus dislodgement or distal embolization, and reasonably recovery is good. This is the usual pattern, but sometimes you end up with something which is you don't see every day. And this is, and out of this over 100 patients, we found these about 14, 15 scenarios where we had a tough time in completing the procedure. STEMI with left main stem block. It was a thrombus, and this thrombus was tough. They tried to put a intracoronary anticoagulants, and still it did not work, and it was continued for a week. We did a recanalized angiogram after 48 hours. It did not dissolve. Then it was done after a week, which showed the recanalization without putting any stent. So stent was not required in left main, and it would have not done the job. So this was a very unusual case. Sometimes you find a triple vessel disease, and you don't know what to do at that time. Of course, we have surgeon, Dr. Babar or others, they can help us in these situations. And this patient, one of them was successfully operated. And another patient had a CTO, which is the tough lesion, and it was one lesion was unsuccessfully attempted, but later on went for surgery. So STEMI and anterior wall MI with a ruptured plaque in right coronary artery has been seen, and PCI for the left main stem was done, and it was a successful recanalization, which is we don't expect having a problem in the left main or the proximal arteries, but this was the ruptured left main which needed a immediate treatment. STEMI of anterior wall, highly calcified fibrotic lesion, unstable to dilate with different devices which we tried, and even the guide wires, the guideliner support, and it did not work. So it needs a very special approach to complete the procedure. STEMI of ectatic vessel, this is also unusual because in ectasia the problem is that you don't find a right stent. Many times ectatic segment is 5, 6 millimeters, 8 millimeters, and you don't have a right stent. So how to manage? Either we just do a balloon dilatation or use a anticoagulants more vigorously. This is the approach can be used. STEMI with thrombus in proximal LAD and circumflex artery. So you have two lesions, two problems at the same time, and this can be managed. So this is that stent which we have a thrombus in the left main, as I mentioned to you. And this is the still picture of the same after dissolving the thrombus in the right side. You can see that. Can you play this? There is the next one. You can just move the video. No, next one. Yeah, on the bottom you can play on the picture. Yeah, please. So this is the same picture on the moving picture, the thrombus in the left main. Next slide we'll go to. And this was, go to the next one, please. Next view. So this was the partially thrombus dissolved after some medication. Next. And this is again, now one more picture. Next one, please. So even you can see that after 2 days we did not see much improvement after this dissolving of the thrombus. So it was a tricky. Next one. Next slide, please. After a week, we could see that it gradually completely resolved, and it did not require any stent placement or surgical intervention. So it was quite frightening initially to see this patient, but eventually we could do that. My team could do it. This is a case was done by my colleague, Dr. Sharif. Next. So unexpected findings continued. If you look at the other one with severe triple vessel disease, which we managed with surgery, I'll just go to the, I think, yeah. This is the angiogram where you find severely diseased disease, and I know the surgeons will not be very happy to receive this patient because distal targets are not so good, but I think they can still do a better job than the cardiologist can do. This case, triple vessel disease, but it was managed by intervention in a stage care manner. Sometimes although the guidelines say that you can do it as a complete revascularization, as the Dr. Roberts mentioned in his presentation, these are the recommendations. You can do complete revascularization in multivessel in acute MI, patient without shock. But sometimes we have to look for our working station, like our centers and very many centers in UAE, they are not supported by a surgical center on-site surgery. So if triple vessel disease is real challenge if without a surgical backup. So I believe that it can nicely be done in the same admission, but not in the same session. So that way we can do it. So triple vessel disease, it was managed by PCI in this matter. This is the pictures during the procedure. Next one. And during the balloon, and it was dilated in stages, and patient improved. So culprit versus complete revascularization is a debate, but it's getting to a sorted in a way because PRAMI, culprit, DYNAMI 3, PRIME multi-trial, and compare acute and complete. These are the trials which have covered this issue, and mostly either to do it in the same sitting or same admission. And this is the difference, whether to use FFR and not to use FFR. And these are some information with the new technology has been mentioned in different studies. So in PRIME, there was 460 patients, 65% decreased in ischemia and PCI, which is a very important point. But in the similar trial, effect was on culprit, which is a 50% decreased ischemia, but there was no reduction in mortality. So whatever you are doing, you are reducing the number of repeat procedure, probably reducing the cost, and stay in the hospital or in next sitting, but it does not change the mortality. DYNAMI 3 PRIME multi-stage, they did a 600 patients, and they showed an improvement, and compare acute also showed improvement, but both had FFR guidance. But FFR did not make a difference in terms of the total outcome. So these are another patient which we have got a multi-vessel disease, which was done in complete revascularization. And in one patient, sorry, it was attempted and it was unsuccessful. Primary PCI during the acute CTO, it has a CTO of left anterior descending artery and right coronary artery, and circumflex and proximal block was there. So triple vessel disease, which was difficult and it was not successful. Next patient was a challenge. Can you, this one. In the red, you can see this, came with inferior wall MI, STEMI with RCA. He had a previous stent 2 years ago. There were double culprit, obtuse marginal artery, which was the large branch of circumflex, was totally blocked, and distal posterior left ventricular branch was totally blocked. So we were changing the catheter from diagnostic to guide, and when we tried to start the procedure, after the first shot, we realized that circumflex was totally blocked and patient developed VTVF. It was actually a test for our team to follow the ACLS protocol. And we had multiple shocks. DC shocks were given, VF for VF, and all sort of medications which we normally use were utilized in this case. Next slide, please. This you can see the multiple blocks and the LAD, right coronary artery chronic block, and all the triple vessels were there is a complete block. Next. Next slide. So this was after recanalization, after we realized that there's a total block. And next slide, please. And then it happened like this. The patient developed VF, which required a ventricular fibrillation to Torsade, and it requires all drugs. And our patients to see, it took about, I think, 20 minutes to resolve this case. And then we decided to take help from anesthetist. Patient was losing consciousness. Next one. And this was the usual steps: CPR, DC shocks, epinephrine, magnesium, beta blocker. Then we decided to sedate the patient and intubate. And after giving intubation and sodium bicarb, then by the end, the medicines of antiarrhythmics were working. And amiodarone was given, which is not written here, and that improved the stabilized. Then we opened the circumflex, stabilized the patient. And this was this story that was on the tops. You can see the total block, which was not there when we started. It was then stabilized. We opened the artery. Next. And patient was discharged after 4 days. So it was a miraculous recovery, which we were at halfway. We were thinking that we are going to lose this patient. But sometimes your persistence, you know when this problem is acute. So treatment has to be acutely managed, and you continue with that, and it helps. So coming to the debate on the complete versus partial recanalization in this STEMI situation, there was a meta trial of the 10 trials, including 7,000 patients. There was a 31% risk reduction in cardiovascular mortality and revascularization. No significant difference in acute mortality was seen. Its clinical implication was in patient with STEMI with multivessel disease, complete revascularization was associated with the reduction in cardiovascular mortality compared to culprit lesion only treatment. There was no difference with or without use of FFR on major cardiovascular events. So NICE UK guidelines are very similar. They also say that you should do multivessel either in the same admission or same time, depending on the profile of the patient, and that's recommended to complete revascularization. If it is shock, then you have to do a culprit vessel only, and later can be decided later. Next. So in conclusion, unusual suspects during primary PCI is a very different topic I've chosen, or Dr. Mittal has asked me to discuss this. So it's an unusual situation, sometimes stressful, and sometimes you have to design your therapy or treatment accordingly. Primary percutaneous coronary intervention is an accepted treatment for STEMI world over, unless contraindicated. Primary PCI STEMI, unexpected findings were double culprit many times, which we see, and heavily calcified arteries, which is difficult to treat, undilatable in spite of various devices, severe triple vessel disease, left main directly involvement or left main equivalent occlusions, chronic total occlusion you don't expect, but sometimes you have tough time, which is looking in a single vessel and you are not able to cross, and which all poses a different challenges. At times you find an atrial fibrillation, and then atrial fibrillation can have multiple thrombotic acute MI, which we recently had, and it has been again managed by intervention. So treatment has to be tailored. One size fit all theory does not apply and may take a tailor-made approach or a strategy in the case of unusual suspect during primary PCI. Thank you very much.
Thank you very much. Dr. Shal would like to comment, and then Dr. Kshetrapal will introduce Dr. Shal.
Presentation, since we have a few minutes, I was going to ask you, when would you not do a complete revascularization in a patient who is not ideal for PCI? Say you want to send him surgery, when would you do that? Or would you do the culprit vessel and do rehab? What is your thought?
So, if I understood your question correctly, that if it is a multi-vessel, when I would do it in my setting, because which we don't have a cardiac setup on site available. So most of the time, if patient is dynamically stable, we try to do culprit vessel and if needed a simple lesion at the same time. If we have to plan 2-3 more dilatation and subsequent vessels, we do in the same admission, but at times we don't do in the same sitting. So it's the case-based approach. It's not generalized. If I think the patient is hemodynamically stable, lesion is simple to dilate, not requiring too much of contrast, I would probably do in the same sitting. If there are 3 discrete lesions, simply a good response from the first dilatation or second dilatation, I will continue, probably finish in the same sitting. That's what my approach is.
Thank you. I take this opportunity also to welcome for the first time Dr. Subhash Kshetrapal, who is one of the moderators here. So Dr. Subhash Kshetrapal is a practicing interventional cardiologist in Florida. And this is his first meeting. I invited him for a talk. So he preferred to be in the moderation. He said, I want to see whether this meeting is worth of his speech or not. So probably next year you will be a speaker. So please welcome and thank you so much for joining as a moderator.
Yeah. Hi, good afternoon, and it's a privilege to be here. This meeting is as good or better than all the meetings I attend in the United States. I have attended ACC for 30 years, and you have tremendous lineup of speakers here. Without delay, I like to introduce Dr. Fayaz Shawl. We see him in all the US meetings, and he's the director of the interventional cardiology at Washington Administration Healthcare. They have their own courses and a lot of meetings. And Dr. Shawl, thank you.
Thank you very much. I think there's an echo. So I would like to speak really slowly so that we can all hear each other. So my topic is high-risk supported PCI. Thank you very much, Dr. Mittal, first for inviting me. And let me tell you, I was listening to your lot of lectures yesterday. I learned a lot, just to let you know that. So going to my topic, high-risk supported PCI, I have nothing to disclose. Now, why supported PCI? Well, we make patients ischemic during PCI because guide catheters interfere with aorto-ostial flow, particularly ostial RCA, left main lesions, or when using large bore guiding catheters. Also, contrast, which we give, does not contain hemoglobin. Therefore, it is a myocardial depressant. And also, wires, inflated balloons, stents, they obstruct blood flow. So these adverse hemodynamics can make what appears a controlled and stable situation unstable, should not be ignored. So when we talk about supported PCI, we're talking about patients with complex coronary artery disease, multivessel left main disease, and patients with hemodynamic compromise, depressed ejection fraction, arbitrarily 35% or lower, and comorbidities, heart failure, diabetes, advanced age, peripheral vascular disease, complex lesions, which includes left main, bifurcation, calcific, unstable angina setting, valvular disease. Nowadays, we see a lot of concomitant valve and critical coronary disease as well as previous prior surgery. And when we use hemodynamic support, we call this protected PCI or supported PCI. Now, what are the kind of support devices we can use? I think everybody is familiar with balloon pump. Now we can use ECMO, tandem heart, or Impala. Now, the type of hemodynamic support for supported PCI will depend on the severity of the hemodynamics. I mean, there are some cases, where you can use small dose of inotropes so long as it's very short. But in some cases, we have to put a balloon pump or Impala 2.5 or Impala CP, or extremely high-risk patients undergoing CPR, cardiac shock. We're talking about Impala 5 or ECMO. I'm going to give you, this is just a video to show you Impala. There are two types of Impala, Impala 2.5, giving up to 2.5 liters, or Impala CP, which can give up to 4 liters. So when you use Impala CP, it's a 14 French. You can see here how it works. There's an inlet in the left ventricle, and basically sucks the blood from the left ventricle. That's why it can unload the left ventricle. And then you can see the flow into aorta. Impala CP can give up to 4 liters. It increases the cardiac output. It will also cause active LV unloading. It will increase the coronary blood flow, as well as reduce myocardial oxygen demand and increase end organ perfusion, especially kidneys. Now I'm going to give an example of a patient where we did not use a support, but something happened. That's what I talk about, why to use support in certain patients. There's a patient who's 75. He had a cardiac cath because of class 2 angina and a very abnormal stress test on medical therapy, but he has a normal LV, normal right, but has a critical left main LAD and circ. Actually, he was sent to me by the surgeon for a high-risk PCI because he has severe COPD. He's on home oxygen. They thought he can't go through the surgery. So I did not do any support, but we learned something from this case. This is his very small right coronary artery. His issue is distal left main, ostial circ, ostial LAD, as well as the circ OM bifurcation. So the distal left main, ostial LAD, mid LAD, and a circ OM bifurcation. As I said, we did not use any support on this patient because the LV was normal, but we got a contralateral puncture and put a 5 French introducer sheath in the left common just in case. Let's see what happened. Well, we took him to cath lab. Our plan was to do this bifurcation first, this circ OM bifurcation, and then do a mid LAD, and then bifurcation left main. So this is the circ OM bifurcation provisional stenting, and looks pretty good results of this circ OM. But at this point, he has a wire in the LAD, he has a wire in the circ. Patients start having chest pain, shortness of breath, marked ST segment depression, and monitor leads showed not only ST segment depression, a drop in blood pressure. Now you have a patient here who you have just done the bifurcation circ OM, has still wire in the LID and the circ, and having chest pain and ST depression, and you don't want to proceed till you make him more stable. So since we already had the left femoral access, I went ahead and put an Impala, and he had an LVDP of 40. So it's very important that I had kept that left femoral access and do not leave the access from the LID and circ wires. The rest was very easy. As soon as the Impala was in, patient had marked improvement in his hemodynamics, blood pressure came up, patient became chest pain free, and ST segment back to baseline. So it's very important. Now we have a patient who is very stable and with no chest pain. It makes your operator to do a better job because patient is stable. And we were able to do a complete revascularization of this left main, ostial LID, ostial circ. And this is the results. You can see here pre and post. I'm going to just say the pre and post. So really, we were able to do complete revascularization only when patient was stable on Impala. I think that is the key thing. When your patient is stable, the operator is relaxed, you can do a better job like this patient, complete revascularization. Anyway, patient Impala was removed in the cath lab and was discharged next day. I'm going to show you an example of a second case where we put the support before. This patient has heavily calcific aortic stenosis, critical left main with bifurcation, and also has mild heart failure, angina, and a low blood pressure. The woman is 87, but she lives by herself, independent, and looks much younger. So what she has is critical aortic stenosis with an ejection fraction of 45%, with moderate MR, critical AS. Now what she has is very complex, heavily calcific left main nodule here, very calcific nodule, and has angina, and has critical AS. So really, here you need a support, what we call supported PCI. So we decided to do something different. I double pigtailed the left ventricle because my plan was also to do a balloon aortic valvoplasty as a bridge to TAVR same time. So you double pigtail the left ventricle, you remove the one pigtail and put the Impala across. This is the Impala across the aortic stenosis. And the second wire, we use the balloon pump, the balloon valvoplasty. This patient had a peak gradient of 70, mean of 38, LVDP 2020. So the next thing what we did is we did the simultaneous Impala and the balloon aortic valvoplasty. In fact, when you do that thing, honestly, you can do multiple inflations. You can go up to 3.5 liters, and look at here. You can see here hemodynamics, virtually no gradient with just BAV. And after we did the BAV, the next thing we did the rota stent of this heavily calcific left main. First rota, and then the bifurcation stent. Second view showing the bifurcation part, heavily calcific, and this is the post rota stent. But you cannot really do a left main unless you do an IVUS. The IVUS showed left main area of 11.9 millimeters square. we learned from left main XL trial that if you use an ultrasound IVS base and the area is more than 10, if the area is more than 10, you have no restenosis. I'm sorry here. Somebody's playing with it. If the area is more than 10 by IVS, there's no thrombosis in the trial, no death, and no restenosis. So same patient was, Impala was taken out post PCI and BAV, and then he came 6 weeks later. She came 6 weeks later for TAVR. 23 millimeter TAVR was put in, and she did very well. You can see here, no gradient, note the improvement of ejection fraction, and a reduction of the MR, and no paravalvular leak. So quickly, PROTECT 2 trial was a study done where they put prophylactic hemodynamic support for non-urgent high-risk patients, unprotected left main, patients with only patent vessel and ejection fraction of 35% lower, or 3-vessel disease and LVEF of less than 30%, randomized to balloon pump PCI or Impala PCI. The primary endpoint was 30-day composite MACE and 90-day. So what are the results? Well, there was not much difference in the hospital MACE, but there was definite post-discharge and at 90 days. This is a much more important conclusion that if you do one vessel only intervention in these complex cases, there was no difference in mortality or in outcome. But if you do 2 or 3 vessels, you had much lower MACE with Impala support than balloon pump. This is a PROTECT 3 trial, 469 patient compared to the PROTECT 2, showing again, when you're Impala supported PCI, you have a much better outcome and lower MACE. And also, this was from another PROTECT 3 trial. We looked at the acute kidney injury, and not a randomized trial, but it was a propensity matched to age, gender, diabetes, contrast volume, and GFR. And what we concluded that Impala protected kidneys, and there was less kidney injury with Impala supported than control. We have also shown that if you have a low EF and you do complete revascularization, there's improvement of ejection fraction, and of course, reduction in the functional class. Now, how about if somebody is hemodynamically unstable, undergoing CPR? It's an example of a patient with STEMI. Actually, it looks like an anterior STEMI, inferior STEMI, very bizarre electrocardiogram. So this patient was taken to cath lab. On the way to cath lab, CPR, all advanced life support, did not respond for 20 minutes for advanced life support. At that time, you have only one thing you can do here, that is to put ECMO. So this is the cannula in the right atrium. And then after the ECMO, we did the angiogram. To my surprise, the left side was clean. But what this patient had, just the proximal right coronary artery occlusion. Just telling you, single vessel can kill you. The rest was easy. While on ECMO, he had complete right coronary intervention. And we did the LV gram showing just moderate inferior hypokinesis, still with well-preserved LV function. Patient was taken off ECMO in the cath lab and was discharged 3 days later. So in this particular case, what ECMO did made us to stop chest compression, made the patient stable, allowed angiogram and then intervention. So I like to conclude that type of hemodynamic support to manage these high-risk supported PCI in cath lab really depends on the hemodynamics of the patients. In some people, you may have to do a right heart catheterization. You have to also look at the clinical scenario, unstable angina, STEMI, or non-STEMI. But as I showed you from PROTECT trial, current data does support the use of Impella during high-risk intervention. Also, I think the key thing is patients with stable hemodynamics who are stable, no chest pain, no drop in blood pressure, allows an operator to do complete revascularization. I think that complete revascularization without stress gives you the better long-term outcome. I think currently we have an ongoing PROTECT 4 trial going on, which is really randomizing people to Impella versus no Impella. Hopefully, within a year or two, we'll have the results. Again, I thank you for your kind attention.
As always, a terrific presentation from Dr. Shawl. And sorry for waking you up so early. I think it's 7 or 8 a.m. in the morning now.
No, it is 8:15.
8:15. Yeah.
Work very early. Always like on a day I get up at 6 in the morning.
Oh, thank you so much for coming over. And as always, the best of the presentations. So please stay on. We have another talk of 15 minutes. My colleague, Dr. Amrish, is with me, and he will introduce and welcome the next speaker and introduce his topic.
Thank you very much, Dr. Mittal. After hearing masters, and we have another master, and this master will speak not of the 3 topics before. All the 3 topics before were talking about primary PCI. Today we have Dr. Andreas Goethe, who is the Chief of Cardiology and Intensive Care Medicine at St. Vincent's Hospital, Paderborn in Germany. He is the head of Working Group for Molecular Electrophysiology at the University in Germany. And also, he is the faculty member of EHRA, and he is in the board of directors of the Atrial Fibrillation Network at Münster, Germany. So Dr. Goethe is going to speak on one clinical dilemma which we face, all of us in the field of cardiology. We know that atrial fibrillation is the most common arrhythmias which requires anticoagulation in our practice. And also we have a dilemma in the patient with PCI, particularly with the potent DAPT, which we use in our practice. They are necessary evil, they are needed, at the same time increase risk of bleeding. So Dr. Goethe topic is going to speak on difficult to treat atrial fibrillation patients, NOAC use in the patient with ACS and PCI. So please, sir, the floor is yours.
Yeah, welcome, Professor Goethe. This is the first time in this meeting, and we are very happy to have you. So welcome to Dubai, though online, but someday it will be on-site as well, we believe. So your presentation is already recorded, so we will start playing it now, and after that, we'll have a general discussion altogether.
Dear colleagues, it's now my pleasure to talk about difficult to treat AF patients, NOAC use in patients with ACS and PCI. So these are my disclosures on this slide. Of course, I mean, in these days where we can use antiplatelet drugs in patients with AF, we are left with more than 2 million options how to vary different therapies after PCI in these patients. So we need guidance how to treat these patients. And in the last couple years, there were from various NOACs, so non-vitamin K oral antagonists, of course, different studies. And so the main studies in AF patients was not the VOST, but Pioneer, Redual, Augustus, and Entrust. And of course, we have learned that the more drugs we combine, the higher the bleeding rate, of course. So triple therapy actually turned out to be, in these trials, the worst option, in particular if you use warfarin in combination with 2 antiplatelet drugs. So all the trials are different, but indeed, taken all the information together, we actually do have a lot of information how to treat patients, in particular after acute coronary syndrome, if they come to the hospital. So the last trial which was published in this sequence was the Entrust AF PCI trial, which was published in the Lancet. And what we found, and I think this is of particular interest, especially dealing with ACS patients, is that in a chronic phase, starting after 2 weeks of the successful stent implant, dual therapy is a way to go, because bleeding with edoxaban plus clopidogrel is much less in comparison to warfarin with aspirin plus clopidogrel. However, what we have learned in this landmark analysis is that in the first couple of days after successful stent implant, that there is a different behavior. And the question is, how can that be related in clinical practice? Because we have seen less bleeding in triple therapeutic arm. And that can be explained by the fact that warfarin in these patients is actually stopped. So right after the procedure, patients were designed to get a triple therapy. However, actually they received just a dual antiplatelet therapy. And this, I think, is of interest. So if we compare all the data and put all the data together from all the 4 trials, we could see that indeed dual antitherapeutic approach is a way to go, because there is less bleeding. However, we pay a price because the risk of stent thrombosis is increased. The question is there a timeline when actually stent thrombosis occur? Because that could shorten the duration of triple therapy if you have to go for a NOAC or a warfarin after a stent procedure. And I just showed you that the Entrust AF PCI trial showed that after 14 days, we had a crossover of the lines. And also the Augustus investigators did the same approach, and they could prove that after 30 days, aspirin, in addition to an anticoagulant plus clopidogrel, is of no benefit. So there's no good clue or no reason to use aspirin beyond 1 month after therapy. However, in the first month, there is an additional effect of aspirin by reducing ischemic events. So besides the results of Entrust AF PCI with 14 days, they could show that after 30 days, there's this crossover. And just recently, this was very nicely explained in a paper in the New England Journal. And they could show that in particular, of course, thrombosis occurs in the first 30 days, and thereafter the risk of stent thrombosis appears to be over. However, you have to keep up with the bleeding rate, of course. So the first month is a way to go probably with triple therapy, and that is the longest duration. The question is, what's the shortest duration? And we think, of course, due to the change in the curves in the Entrust AF PCI trial, it's probably 14 days. So what we also did was, is there at all a difference between CCS, so chronic coronary syndrome patients, and acute coronary syndrome patients at all in this clinical situation? And that was published in the European Heart Journal just recently. And what we have seen in this paper, including about 777 patients with an ACS and the same number of patients with a CCS, what we found was between ACS and CCS in various analyses that there is no difference. And I think this is a very important message, because many physicians think, okay, stroke risk or stent thrombosis risk might be massively increased. However, we have to see that in this subcohort of AF patients with an oral anticoagulant, this appears not to be the case. So I think this is very important. And what we also did, we calculated the net clinical outcome, And what you could also see here, that the overall result of the Kaplan-Meier curves actually in CCS and ACS patients really looked very much the same as the overall primary publication of the whole study results. So there is no difference in the time course of bleeding events with regard to dual therapy based on edoxaban versus classical triple therapy. And this, I think, is important. And just recently, we included data from all the other trials as well. And we did a meta-analysis, and the outcome was that with regard to bleeding, CCS and ACS is really similar. There's no difference between the different clinical phenotypes, and also occurrence of stent thrombosis is actually the same. So the strategy to treat patients with atrial fibrillation in CCS and ACS coming from these data should not be different. At least this is not supported by the trial data. However, the question is, can we predict patients or can we identify patients who are candidates for stent thrombosis? And we analyzed data from Entrust AF PCI, and we could show that at least at a CHETS-VASc score of 5, the risk to suffer stent thrombosis in the first weeks after the procedure is increased. So it's a rough parameter. However, it also supports the CHETS-VASc score to be a cardiovascular risk score, and also very helpful in this clinical situation. And this, I think, is the very first time to relate the CHETS-VASc score to the risk of stent thrombosis. So what do the guidelines say? And this is from the latest AF guideline version for atrial fibrillation. You could see that there is still a differentiation between ACS and CCS. However, a NOAC-based therapy is a way to go, also in accordance to the guidelines, and the add-on of a P2Y12 inhibitor, and usually that is clopidogrel, and then there is room for aspirin up to 1 month. However, of course, shorter durations could be preferred, and in the guidelines it's stated for a week. However, from the different trials, we have very limited data about true therapy with aspirin just for a couple days. And Entrust AF PCI trial was the only trial starting immediately after stent implant. And in that trial, we have clearly learned that very brief durations of aspirin therapy are not safe. So this is a bit different. What does the practical guide actually say? And I think this figure is very nice because it shows how to treat patients coming to a cath lab which actually need to get a stent if they are elective patients, and they recommend to stop a NOAC for a brief period of time, 24 hours, to reduce bleeding, and then do the procedure with heparin, of course, and then reinitiate the therapy. Of course, that cannot be done in patients with ACS because there's no time prior to the procedure to stop the therapy, but it explains very nicely how you should actually manage peri-interventionally your patient. So this graph, I think, is very nice. With regard to the strategy of therapy after the procedure, I think there's still a discrepancy because they clearly discriminate between ACS and elective PCI patients, so CCS patients. And I just showed you that this might not be the best way. However, you still have the option to do it similarly, but again, a very short period of aspirin therapy. And we think that if you do an elective procedure in the left main coronary artery, so to speak, just to go for 1 week is not really supported. And the risk of stent thrombosis and mortality is very high. So even in elective procedures, the anatomy and the location of stent placement has to be considered. So I would be a bit reluctant just to use this in clinical routine. So the question is, how do we do it? And our interpretation of the trial data, it's a personal opinion, and our institution is really to go for the results from the different trials. And I think the shortest duration, at least for triple therapy, supported by a phase 3 trial was Entrust AF PCI. So what we do is in ACS as well as in CCS patients, we have triple therapy with edoxaban or another NOAC in a full dose for 14 days, then we skip aspirin and go, and this is the main difference, we go for dual therapy for a year, 12 months in ACS patients, just for 6 months in CCS patients, and then skip clopidogrel as well, and then have monotherapy with edoxaban or NOAC. And of course, we have adopted this strategy in accordance to the puncture side, and this allows us to start early on with after puncturing the radial artery. So this is my interpretation, and I hope now for a fruitful discussion. Thank you.
Thank you so much. So now we are open for good discussion. We have sufficient time. So technical team, can you put all of us together? All the speakers, moderators, and let's start.
So, Dr. Andreas, that the talk was very clear and it's very practical. But as we understand that aspirin should be given for the least period when we are talking of anticoagulation combining with the other antiplatelet drugs. So is that 1 week period is too short, or 2 week period as shown in the guidelines? Will that be your take for the department?
So Dr. Andreas,
can you hear the question?
Well, we think at least that there is an increased risk. I hope you can hear me well. That
yes,
there is an increased risk if you stop aspirin too early. That's what we learned also from the PCI trials, that an oral anticoagulant is not the way to protect a stent. So you need antiplatelets, and dual antiplatelet therapy is a way to go to protect in the first weeks the stent struts for stent thrombosis. So I think this comes really from the old data, that we should forget about the initiation process for stent thrombosis. So to be on the safe side, at least it's our interpretation of the data, it's at least 2 weeks, but there are no data to continue dual antiplatelet therapy beyond 1 month. So now the overall time of triple therapy is way reduced, but I think just to give aspirin during the procedure and stop immediately after procedure, that this was shown in our trial that this is potentially harmful for the patient. So of course, everybody now working in the cath lab has to make up his own mind, but we have to just to be sure, or to interpret the data with caution, because none of the trials was really designed in a way to study the exact duration of aspirin. So the data we do have are weak, and for this reason, I think we, in the long run, dual therapy and NOAC plus clopidogrel is the way to go. There is no doubt that this is the best way. However, the first weeks after the procedure, probably it's better to go for triple therapy plus gastric protection, of course.
So a supplementary question is there any particular dose of aspirin, 75, 100, 150, in a triple therapy regime?
Usually what we used, and there was the general term, I think in most trials, is 100 milligram of aspirin.
Okay.
May I ask one question? Now we know that the antiplatelets are very important for the stent integrity and to keep the stent patency. But the main bleeding risk comes from anticoagulation. So there is a strategy tested, instead of using full dose of anticoagulation, like 150 milligram of dabigatran or 20 milligram of rivaroxaban, the lower dose which has been effective in atrial fibrillation, like 110 milligram of dabigatran and probably 15 milligram of rivaroxaban, along with the dual antiplatelet therapy for a month. What do you think, in the lack of data, this can be optional regimen?
I mean, it has not really been studied. I mean, all the trials usually went for the full dose, which I think makes sense due to the label of the drugs. If you want to prevent a stroke, you should go for a full dose. There are data for rivaroxaban in that trial. However, they used a non-recommended dose of rivaroxaban for protection of a stroke in AF patients. So I think this is a bit to be debated actually, because there are no data. But of course, you're right. The initial bleedings occur from the puncture site, and we think and we can show that the puncture site relating bleedings are really related to the immediate effect of the oral anticoagulant. So for this reason, of course, you have to go and consider the way you do the procedure. So the radial artery may give less problems with bleeding. However, if you have done the whole procedure through the femoral artery, it might be wise, at least for a couple of days, to withhold the oral anticoagulant to reduce bleeding from the puncture site and then restart the oral anticoagulant. I mean, also this approach has not been studied, but just from the analyses of the bleeding around the procedure, the puncture site appears to be very important. So for this reason, actually, it might be wise, at least for 24 or 48 hours, to withhold the oral anticoagulant, because at least in the initial time frame, we did not observe an increment in stroke. So this might be one way to deal with the problem in clinical practice.
So, Professor Gagliardo, now it is shown that 1 hour rule out is possible. Nowhere in the guidelines ever anybody discussed that it is the duration of the pain. Suppose somebody comes to me with a 4-hour history of pain and I do first opening, it is negative. Is it not valid to rule out at that point? I mean, is there any dependent relation between the duration of the chest pain at the time of presentation?
Yes, this is a good point, an important question. I would say the duration of the pain, it is important. If the patient presents within an hour, for example, of pain, I think the first troponin may be normal or just low level elevation, and you can and should do a second one. In your example at 4 hours, I think of continuous pain, a simple troponin with other information, the electrocardiogram, could essentially rule out the patient. In practice, we rarely discharge a patient within 1 hour of the emergency department presentation. So if there were any question, to get a second one at 1 hour would be definitive in your example.
Thank you.
Robert, on the same point, is there any particular difference between the high sensitivity troponin, whether troponin I or troponin T, which we can help our residents in emergency room to decide or how to go about it? Is there any difference?
Yeah, that's a good question. With the proliferation of the various troponin assays, it has not been well studied. But I think if you truly have the high sensitivity modern version, I think there's probably only small differences between I and T. The difference, the challenge can be in the nomenclature. Sometimes it gets confusing and we have first, second, third, fourth generation troponin, but it's truly only the high sensitivities that were developed in the past several years that you could rely on the very early testing, the 0 and 1 hour.
Thank you.
Dr. Scholl, can I just ask you one question or one observation? Because I attended with you at Washington Adventist Hospital, and you were doing, if you remember that 30 years ago, you used a shawl cannula for the right atrial support, which you are using a different machine. Was that can be considered as the precursor to ECMO? Because at that time, you are putting your own name cannula, which is a shawl cannula for the right atrial collection of blood and recirculation. And you have been always doing very high-risk angioplasties with very good results. So would you say it was the precursor of ECMO?
Well, the ECMO has been there for decades. I think what I did made it available percutaneous. So current ECMO, which we have from Medtronic and other companies, make the same cannulas and can be put percutaneously. 17 French arterial and 21 French venous. But I may add further that you really, with the advent of stenting, you really have to use an ECMO now as a support, but the ECMO has the best role when patient has a cardiac arrest and nothing is working. Chest compression, I think that is one support. It would not interfere with your chest compression. You can go through the femoral. But again, when I developed this almost 3 decades ago, we just call it CPS, cardiopulmonary bypass, but really same as ECMO.
And may I have a question to Dr. Robert? For the 0 and 1 troponin, high sensitive troponin, is this dependent on the kit or just any high sensitive troponin will do? Or is it kit dependent? Is there validity required for a kit?
There have been multiple validations with the various high sensitivity troponins, so I think if it's truly the current high sensitivity troponin, you're okay with the 0-1 hour.
Thank you.
Yeah. So Professor Andreas, this is a practical question which we always in a dilemma when somebody is already on NOAC, and how much heparin to give, not to give at the time of procedure. If suppose patient comes with an acute coronary syndrome, half dose, full dose, enoxaparin, what should we do at that time?
Well, honestly, I would, what we do an ACT guided approach. So usually we give the full dose of heparin and then we check the ACT. And interestingly, the use of heparin or the amount of heparin you need to reach the ACT of 250 is actually a bit increased. So no, I would not use reduced dose because just to be on the safe side during a coronary intervention, you want to be fully protected. So for this reason, of course, I think it's necessary to check the ACT because sometimes really you think that you may over anticoagulate the patient, but that is obviously then not the case if someone comes in with a NOAC.
Oh, thank you. That's a good.
I have a question.
I always thought that I would give half the dose, so that's yeah. So let's hear something from Florida, Dr. Kshetrapal.
Yeah,
Do you have any comments?
I have a question for Dr. Andreas. Once you have treated a patient with AFib and an acute coronary syndrome, after a year you stop the either the Brilliant or the Plavix, would you put him on, in addition to the NOAC, would you put him back on aspirin or not?
Well, this is a long debate. If someone really has coronary artery disease or peripheral vascular disease, if he needs platelet therapy. At this point, what we know is a combination of an antiplatelet plus a NOAC increases bleeding substantially over time. So from the data we do have so far, it's really recommended to stop all antiplatelets after a combined therapy. So to stop it after 12 months, after ACS, or after 6 months, if you have stented a CCS patients, because the bleeding risk over time is just tremendously higher in comparison to monotherapy. So no, we do not put patients back on aspirin after we stop clopidogrel.
So that's.
If they do have an indication, of course, for an oral anticoagulant. I mean, this has to be present, of course.
Yeah. Okay. Dr. Jairam, your story from Abu Dhabi, you are also a high volume interventionist.
So I have a couple of questions for the, for the panel, sir. There are some patients, for example, who for various reasons cannot be put on either NOACs or cannot afford the NOACs and required to take warfarin. What happens with these patients? Would you consider after a year, let's say, to consider these patients to be put on aspirin plus warfarin to protect their hearts, or to keep them only on warfarin to treat warfarin like a NOAC? And my second question would be, patients who come in with an acute coronary syndrome or a STEMI who are on aspirin and Brilinta, ticagrelor, and subsequently develop atrial fibrillation, let's say 2 weeks, 4 weeks down the line, how would treatment change for these patients? Would you change the Brilinta to clopidogrel or continue Brilinta and the NOAC? Thank you.
Oh, very smart and very important and interesting questions. Yeah, I mean, if someone develops atrial fibrillation and he is more on a modern type of P2Y12 inhibitor, I mean, so far to use those in combination with a NOAC are not, at least per label and in accordance to the guidelines, that is not recommended. So what we do is actually then we switch them back to clopidogrel just to reduce the risk of bleeding, because that's what we learned, that the modern type of P2Y12 inhibitors really have a substantial increment of bleeding risk. So we do not combine, at least on a routine basis, and it's not really supported by the data, to have NOAC or warfarin combined with ticagrelor. So I would actually down titrate those to a regular clopidogrel therapy. And the other aspect is, yes, if someone has an indication for warfarin, like a mechanical valve or so, then we use warfarin in the same way as we would do a NOAC. So we would leave them on warfarin plus clopidogrel for 12 months or 6 months, and then go back just to monotherapy with warfarin if that cannot be changed. So this is the same, but of course, due to the higher risk also of bleeding events, we always use gastric protection. And I think this might be one of the clues, really, if you have an oral anticoagulant plus an antiplatelet, that gastric bleeding can be prevented by using GI protective drugs.
Great answers, actually. It's a lot of learning from this. Yeah.
Dr. Shell, can I ask you one another question on the supported angioplasty? So the patient which you showed who was having cardiac arrest, CPR, cardiopulmonary resuscitation going on in cath lab, and patient was not responding, and you put the ECMO. Do you think in that case Impala could have been used?
Well, you know, when you use Impala, the only situation is you have to cross the aortic valve, put a pigtail in, and you change the Impala. When you have CPR going on, chest compression, you know, it's very hard to stop the chest compression and put ECMO, no, the Impala in. I think that's why if you have somebody with a true cardiac arrest, it doesn't respond to chest compression. Nothing like ECMO. There's no other alternative. Yeah, you can put Impala, but you have to stop chest compression, close the aortic valve, prepare the system. Not practical. Now, if you're in cardiac shock, you have a stable rhythm, yes, you can do that.
Good, thank you. So we are in the last part, in the ending time. This is one of the best sessions of the whole 2 days. I would do this last 5 minutes in a different way. So all available speakers and moderators, please take on for 1 minute and give the best message to all the audience for daily practice from your talk, from your perspective, from your thought. So everybody, this is rapid fire, 1 minute each. That will help our audience to get the key messages. So we can start from anywhere. Let's start from Dr. Shawl and continue.
I think my key message is if you have a complex patient and you want to do complete revascularization, make sure patient is stable. If patient is unstable or is high risk, start the support first. Don't do it later on when there's a crash. Because by keeping the patient stable, you will be able to be more comfortable in doing complete revascularization, which has the best outcome. So don't wait till something happens. Make it prophylactic.
That's great. Thank you. Dr. Jaram, you are next on the frame on the left side. What's
you
your
all.
take for
And
the whole symposium? And I do not know whether you attended yesterday, you attended in the morning, so what's your take on all this whole proceedings?
I did, and Dr. Mittal, to tell you the truth, the last few years I've been, part of the audience, part of the podium there. Every year it only gets better and better. Truly
Thank you.
state-of-the-art lectures, wonderfully timed. One of the few conferences where I see people are pinpoint on time. And I think as cardiologists,
Thank you.
this is the message that I'd also like to give, that time is muscle. And I think that this and SHAKEHEART sort of signifies this, that safety first, keep patient on priority, and time is muscle. So thank you again. Wonderfully organized program.
Thank you so much. We have Professor Robert for the second time. We were honored to have you last year also, and I'm sure I book you in advance for next year as well. So thank you so much for coming over, and your talk was terrific. I think all the proceedings will be uploaded on the website for the audience review and accessibility anytime. So what's your key message today?
Well, first, thank you very much for involving me again. It's a tremendous conference that you've organized. I would have two messages. One is with regard to ACS, just the recognition that the pathobiology is changing in front of our eyes, and that we now recognize and have learned about some unusual etiologies like myocardial infarction without obstructive coronary disease or coronary artery dissection that we need to consider in our unusual cases. And the second is there's such a rapidly changing field that one can find many of the answers in the two most recent ESC guidelines, covering newer topics like the 0-1 hour rule out, or how to select between antiplatelets and anticoagulants in patients with atrial fibrillation and ACS. So, take a look closely at those guidelines.
Oh, thank you. These are the great messages. Next is Dr. Lochan sitting beside me. Sir.
Brajesh, it has been excellent journey. You have started with this acute coronary syndrome or STEMI care, which has been, we are performing, and at our place, STEMI patients are everywhere and we are taking care. But you have formulated a platform where we can bring our experiences and discuss. We can learn from other people's experiences. There are two ways. Either you commit a mistake and learn from that, or you see other people's experience in the similar situation, you can apply in your practice and you can do it. Likewise, that the time is important and everyone is trying to achieve very short possible time. At our center we have done, Doctor from the Far East, Dr. Shima showed 42 minutes, which is also commendable. And I think we all learn from each other the way they organize their system, national level. So we have to start our own practice and learn how we can apply their principles to our own. Thank you very much for this.
Thank you, sir. Dr. Amrish.
Thank you, Dr. Mittal. And I will not any more saying that you've been really wonderful organizing successively better conference every year. And this was probably one of the best meetings with very short focus sessions. I will like to just add one thing, that I think the heart failure is going to change dramatically over the next 2 years. Apart from pharmacology, what will change is the characterization of the heart failure, in the sense that it will be no more preserved EF, reduced EF, and mildly reduced EF. It will come, in my opinion, somewhere down the line, heart failure with the normal EF and heart failure with less than normal EF. And the normal EF will be cut off by the age of the patient. It will be probably some of the range of 55% for males and 60% females. So anything below will have the same therapy for the patients. And these 4 therapies, which are pillars for reduced EF, will be extended to the range we had talked about. Thank you very much.
Thank you so much. Next, Dr. Subhash.
It's a great meeting.
First of all, you promised me next year you will be the speaker.
Absolutely. It's been a privilege and an honor to attend your meeting. I've been practicing cardiology for 30 years, and I attend ACC every year and some of the SKY meetings. And this is very well focused and a very educational meeting with excellent speakers. It's like a board review course for everything. I think
Thank you.
focusing on STEMI matters. You know, all cardiologists, all physicians do a lot for their patients, but where we, as cardiologists, where we really make a difference is changing their life, save their, you know, everything could be blood pressure and angina. When you do acute STEMI, primary PCI, you change the course, save the patient's life. Most people don't realize 30 minutes delay in opening the artery doubles the mortality for the patient. So it's been a great teaching point and very well covered about all the pre-hospital treatment to the actual going home, and a good summary course for everything. It's been a great meeting, learned a lot of things, as good as any national meeting in the US we attend. And thank you for inviting us to be here. Thank you very much. Great speakers.
Thank you so much. Professor Andreas, your some key message.
Well, first of all, again, I'd like to thank the organizers really for the very kind invitation. And I think this also shows how important it is to have an exchange and how important it is to have good meetings and that the people can actually talk to each other and to get impressions. Because besides pure science, there's always a clinical reality where we have to see how we can actually implement data coming from randomized controlled trials. And it's not always as simple as suggested, because usually most of the patients do not really clearly fit into the study outline. So for this reason, interaction is important. And this is one of the key messages I learned again today. And with regard to PCI and in atrial fibrillation patients, I think the key message is you have to be very aggressive early on and then to be less aggressive during the chronic treatment phase to get rid of aspirin and to protect your patient. And that is something you have to adapt to the different patients' profiles you're treating and the different NOACs you're using. So thank you very much for having me.
Thank you for your kind message. Now, I have two messages from my side which I would like to present because we are organizing STEMI care in some way or the other since 2015. So one key point which I wanted to give to all the audience right from the beginning, that doing primary PCI is a technique and you learn a technique, but that's just a very small part of the whole spectrum. Doing a primary angioplasty is much easier than to manage the patient before, manage the patient during, and manage the patient thereafter. So it is equally important that there is a lot more to be done besides the technical part of primary PCI, the medical management, the good rehabilitation of the patient, and secondary prevention is the key. I usually tell my patients that if you suffer first myocardial infarction unknowingly, this is your fault. If you suffer once again, this is also my fault. I must do everything to prevent you having the second episode in your life. And that is where, and we are privileged to have such wonderful medications where we can prevent a second episode to a great, great extent. This is my first key point. The second point is that right from the inception of this program, we never focused only on intervention cardiology or in technical part of it, and we not focused only on treatment, but rather on prevention. So what I usually talk to my patients, that when you come to me with acute MI and you are dying and I do something for you and I save you, I'll be a hero. But could I not be a better hero in preventing this? But there are no marks for prevention actually, unfortunately. There are so many marks for treating a dying patient, but no marks for preventing him to reach at that stage. So prevention is the key. So with these remarks of mine, I humbly thank you all for being part of this program. I can't thank you enough. I can't thank you, the whole faculty, for the last 2 days who have supported, who have come forward, who put in a lot of time and effort. And I wish to see you all again. I hope our viewers, our audience, our attendees, our delegates did get a lot of points to learn. And we are always ready to take the more feedback. And with this, we say goodbye to this year. Thank you so very much once again.
Great meeting.
Thank you.
Great meeting.
Thank you. Thank you. Thank you, sir. Bye-bye. See you again. Thank you, technical team, support team, sponsors, all other people who worked hard to make it successful. Thank you.